Welcome for this session. And this session is going to be looking at a regulatory framework in the health workforce. We shall be having a panel before us here. And I want to call them first. Before I call them, I want to introduce them. We shall be having Professor Emmanuel Rudakemwa. Karibu. We shall also be having Professor John Charles Okiria. And you'll forgive me if I pronounce your name not so good, because that is how they are written here. We shall also be having Advocate Kamalo. And then we shall also be having Dr. Kioko. Our panelists, you are welcome. And we shall start straight away. And I want to ask all participants to settle for the session. So, Karibu, Professor, I think you are the one starting for us. Okay.
Thank you, Honorable, and good morning, everyone. It's an honor and a privilege to sit on this panel to discuss our experience in the regulatory frameworks and professional regulation. If you do a scan on the state of professional regulation regionally, continentally, and internationally, you find that there is no size that fits all. So professional regulation has been contextualized, and professional regulation essentially is done in a contextual manner, as we say. So when you look at the professional regulation, essentially a few sub-themes cut across. And these include how do you categorize the instruments for professional regulation? Should we be for self-regulation, co-regulation, where you see there is regulation between professionals and the government? And I think most of us do associate to that in one way or the other. Then what comes into focus essentially is the reason for regulation. Yesterday a lot was talked about, but when you talk about professional regulation, it is aimed at guiding the professions indeed, and then protecting the population. So at the heart of everything is accountability. If the government sets up a legislation, does that legislation only involve professionals? Remember, we are regulating in a context. Now, we know that different jurisdictions also involve lay people in the boards of different councils on our continent. And we know that when you talk about regulation, some people think and start considering what we call the negative solidarities among the professions, to the extent that they feel we always want to support our own. But when you include different other cadres and lay people in general, you actually find that the regulation probably fulfills part of it, or part of its core mandate. So when you talk about professionals, these are people that indeed provide a valued service to the community, and a lot again was mentioned yesterday. So should we have a one-size-fits-all at a national level, regional, or international level. We know we have specific professions regulatory frameworks. We have overarching regulatory frameworks at both national and regional. A case in a point is probably EAC. Out of the six countries so far, we all have different landscape in the way we regulate our professions. We have profession-specific regulatory frameworks. We are now having overarching national regulatory frameworks. Some have put in actually oversight regulatory institutions, and we are looking at setting up an EAC regulatory authority. So how do we fit in? How does the purpose become achieved? And remember, apart from being accountable to the population that we serve, it is equally important that continuous medical education or quality assurance generally among the professionals becomes critical. Can we bring in the issue of certification and recertification among the professionals such that we keep ourselves updated, the life learning principle? Should we only concentrate on the CMEs or the CPDs that most of it is what is taking place on the continent? So we need probably to see how we can diversify and make people uncomfortable and consider doing planned exams so they get certified, recertified, such that they are kept on their toes. So how does professionalism and professional regulation contribute to what is regarded as the modern social contract? You know, the modern social contract, or the contract that we have with the populations that we serve, is as well contextualized. So the only trusted profession among other professionals are the healthcare professionals. So how do we maintain that respect, that trust, and how do we bring fairness, justice among ourselves without any intervention, without any core regulation by the government? How do we actually disentangle professional regulation from the government interventions? Chair, I submit for now, and my other colleagues can take it from there. Thank you very much.
Thank you, Professor. We shall now go to Professor John Charles Okiria. So Charles, you are welcome.
Thank you very much. Greetings from the Republic of Uganda. Professor Emmanuel has really laid a nice foundation on the regulatory frameworks. But I think the issue about the regulatory frameworks is more of an aspect of implementation. We have the frameworks that have been established. We have the frameworks countries have designed. We have the regional, we have the national, we have the global frameworks. But the question is, why are services, why are professionals, why are practices what they are today? I know His Excellency yesterday saying we are making progress. I agree. The argument could be probably the progress is slow. Now, in terms of the frameworks, I think we ought to be looking at it from first principles. The oath we swear at the time of graduating as a professional should be the first framework level for every professional. The Hippocratic oath you've sworn, is it part of your journey as a professional? How many people keep them on their walls and say, this is what I swore to do as a profession? Or we are simply doing it as a ritual for the graduation day, and lift up your cap and say we are done. When you moved from that swearing, then we move to the code of conducts for various cadres. We have these small booklets in all professions. People are busy revising them. But even then, they are not looking at what was the problem with the previous code of conduct. What didn't we achieve? And if we didn't, what could be the challenge? But people are saying, no, it is over 5 years, it's over 10 years. We need a new code of conduct. But then exactly to do what? So we have a challenge. So we have the codes of conduct for different professionals. We have them, but apparently there is laxity in ensuring that the professionals abide by the code of conduct that they have. Institutions, therefore, apart from just providing the book to this, must engage the professionals into enhancing the implementation of code of conduct of the professionals as part of their CME or CPD. Because the challenge is that all of us, if not, know that we have a code of conduct. But the question is, are we looking at this as a very important weapon for regulation? Are we looking at this as a baseline for our conduct? Now, at regional, national levels, we have laws. The Ugandan case, we have an act for Allied Professionals Council, where I'm the chairperson. We have the Medical and Dental Council, we have the Nurses Council, we have the Pharmacy Council, and all these have acts of parliament. And so what is the problem? If the acts are there, how far, to what extent are we fulfilling the obligations that are expected of us as professionals? The people who are supposed to be regulating this, how far are they in their due course of providing the technical support to ensure that the provisions of this act are put in place? So we have an issue there. We have books that we carry everywhere. I have the act, I know the act, but how much of the act is in you, in your practice, in your professional life, in your daily life, in handling patients? So these frameworks tend to bring us together, but we tend to neglect them when it comes to practice. Now, at regional level, Professor Emmanuel has just alluded to that. We have the ESC protocols that are being determined. And then globally, WHO and all this. But then we have the frameworks, which are cross-cutting, enshrined in the constitutions of countries that also affect health professionals. To what extent are these in line with what we think should be for the professional? You now have, in countries like Uganda, we have the patient's charter. The patients are also saying, please look here. You are not doing what we expect of you. So we want to tell you what we expect of you and what is expected of us. Now that the regulatory framework begins to take sides, you probably now should be sitting and saying, can we have one regulatory framework that includes both the professionals and having consulted the clients? Now, when you normally talk about the frameworks in the health sector, there has been a tendency to talk more about medical professionals. I heard the arguments of yesterday, doctor, nurse, but nevertheless, that's not the main thing. We're talking about professionals across the board. The doctors, the allied professionals, the nurses, the pharmacists, call it. But in today's theme, we are talking about a health worker. So we have now a challenge in the provision of services. We now introduce persons in the health workforce. Some of them, by virtue of their professions, have never taken any oath. So how then do you become part of the system when you yourself has no professional guideline? And so we have then these people as part and parcel of the system of providing healthcare services. We have the administrators, we have the biomedical sciences, not falling under any regulation. But yet they are very, very critical in the provisions of services. So if we then have to strengthen the regulation framework, then we should be talking about the broader context of a health worker. Otherwise then, we may want to regulate the medical practice as professionals, but service provision calls more of your character, behavior, attitude, more than just the clinical knowledge that you have. So in terms of what is currently going on, we see that these frameworks exist at all levels, but we need to dust them out from the dust from our shelves, dust them out from our so-called known, and we know it all, and bring them back on the table. Thank you for now.
Thank you, Professor Charles from Uganda. He has just said that there are frameworks, both regional, international, and also at our national levels. The issue is the implementation of those frameworks and the product, the end product. Okay, I now want to welcome my other colleague, coordinator, to continue with the other two panelists. So I now want to give a chance to Kamalo, Malo, to continue from there.
Thank you. Hope I'm audible. So I want to cover a few themes this morning. The first one being the need to review our regulatory framework, because some of these frameworks were crafted 100 years ago. Like ours, the Health Professions Act is very old, and it has to be reviewed and amended to support the new way of the provision of healthcare services. As we review these frameworks, we need to take into account the role of health practitioners in the universal health coverage. We need to take into account the role of multidisciplinary teams, because if you look at some of these ethical rules and regulations, they created a situation where health personnel was segregated, that a medical practitioner will have to practice solo, and you cannot practice or share a room with another practitioner. For instance, in our country, there is an ethical rule that says no person shall share rooms with a person not registered in terms of our Act. And the literal interpretation of that ethical rule means that a medical practitioner may not share a room with a nurse. And the question is, does it make sense? So we also need to review our ethical rules and guidelines for practical reasons and purposes. We must not have ethical rules that do not make sense in practice. Another thing that I thought we should take into account as we review these frameworks is the issue of telehealth or telemedicine, whatever you call it, because during the COVID time, most regulators, they struggled because their ethical rules and guidelines were based on a practitioner having to have a physical contact with the patient. And now it became difficult to apply that framework during the COVID. And I hope that colleagues will take that into account as they review their regulatory framework. Another thing that needs to be taken into account, in my opinion, is the issue of primary health care as well as health promotion, because you find that most of these prescripts and regulations were crafted from a system of health that was curative, not preventative. So you need to infuse that, otherwise it makes it difficult to deliver healthcare services if your prescripts are still based on the curative approach to healthcare delivery. Another biggest theme that has actually developed in our country is the issue of scope or jurisdiction. We have found that as we try to enforce ethical rules and as we try to enforce discipline, that more and more healthcare practitioners have taken us to the High Court and challenging that we do not have jurisdiction where an act or an omission has taken place in a context that is not within the healthcare practitioner-patient relationship. High courts have agreed with practitioners. We have to challenge that to the Supreme Court of Appeal, and we have a case in point, which is the Health Professions Council of South Africa versus Dr. Griev. The Supreme Court of Appeal agreed with the Health Professions Council of South Africa that it cannot be that when an act or an omission has taken place outside the context of a doctor-patient relationship, that you can then argue successfully that the regulator doesn't have jurisdiction. The Supreme Court of Appeal concluded that the Health Professions Council of South Africa, as well as its professional boards, are the guardian of the professions. They set standards and they are the regulator par excellence. It depends on how the board looks at the conduct. If you are accused of having stolen sweets from a supermarket and somebody complains against you as a practitioner and say this conduct is unethical, is unprofessional, then the board must decide when they have regard to your profession whether such a conduct is acceptable or not. Should a board decide that it is not acceptable and then the jurisdiction is found. So that was an important development in our jurisdiction. Had we lost the case in the Supreme Court of Appeal, it meant that we had to pack our bags and go, because the doctor in question had argued that he was practicing as a businessman, not as a doctor. He had set up a company and persuaded his patients to invest therein, and when he knew that it was in financial distress, and he then withdrew all the funds and put the funds in his personal bank account, and that was what we were charging him for. That's why he argued that he was not in that time operating as a doctor but as a business person. Well, I will try and summarize the rest of the themes unless I take more time. Another theme that I wanted to cover this morning was the issue of health regulation training. Who trains regulators? Do we just wake up and say, I am now in the council and therefore I can regulate? Is regulation a discipline? Is health regulation a specific discipline for which people must be trained in regulatory affairs? Is there a regulatory affairs training for health regulation? Is there such globally, regionally? And my desktop research has found that it is very limited, it is not pronounced, and people are just taken to these councils, they are taken to these boards, they are appointed there by ministers, and they are told that you must now regulate the professions. I am of the view that you need a specific skill in regulation in general and in health regulation in specific. And that, in my opinion, is not something that one can get by way of osmosis, that you can just get the information from higher concentration to the lower concentration. If we are serious about health regulation, we have to, as regulators, working with institution universities, put together a curriculum for health regulation, and we train regulators. And I hope that that will help. Now, also when we practice health regulation, and as we review these prescriptions, I think we must also watch, because there is a very thin line between taking the principles of self-regulation and codifying them and creating a legislative control that makes it difficult to regulate health practitioners. So it has to be principles of self-regulations that go into those ethical rules and regulations. We mustn't create a legalistic thing that is so hard and rigid, so hard to amend. Let those things at least be easy for the council or the board to amend. If every time you need to consult the ministry to amend a simple ethical rule, then you have put yourself in a fix, unfortunately. Now, I think, Chair, as I conclude, one of the themes also is the enforcement of ethical standards. In South Africa, this has proven to be financially unsustainable, as we spend more than 25 million to prosecute, and I will use prosecute because our system is legalistic, to prosecute practitioners who deviate from the set ethical standards. It is unsustainable. Council cannot afford it. The board cannot afford it. Now, the questions this morning, and I don't know whether there is a jurisdiction that is experiencing the same. The questions that I have this morning is a legislative punitive approach still a way to go? Are there other alternatives? What about expanded mediation? What about peer review? How do we ensure that the lessons that we learn in prosecuting practitioners, they can feed back to our curriculum? I think my colleague has touched on something like that. And you link this to another theme of medical malpractice, which also in our country has made the healthcare system unaffordable, because a large portion of our funds that were budgeted for delivery of healthcare services is diverted to the legal cost and legal claims. And we're talking billions of rands that every year are paid towards claimants that have claimed for medical malpractice. And in that space, do we have to continue with this unsustainable model? Is there a space for apology law? I'm sorry, but that has to go with a no-fault system where the health regulator and the health minister can investigate a case and they can determine what a claimant should be paid, instead of a claimant going to court to prove that which is obvious, and where we have deviated from standards. And we can say we are sorry, and we can pay whatever capped amount that we can pay to the patient. And I think that could be a sustainable system, other than the current system of medical malpractice, where people go to court and amounts that are ordered have not even budgeted for. And of course, Chair, I would then like to stop there, but maybe pose one question on my last theme, whether or not the issue of bogus practitioners is a matter that should concern health regulators, or is a matter for the police. Should we leave it to the police? And if we leave it to the police, are we true to the principle of the protection of the public? Thank you.
Okay, let us give him a clap. Thank you so much. We now have Dr. Jackson Kioko from Kenya.
Thank you. Thank you, Madam Session Chair. I guess I'm the last panelist, but one of the challenge of being the last, that you attempted to repeat what has been said. But I want to make it very short, Madam Chair, first of all, I need to make known some of the basic principles so that all of us who are in this hall, we are in sync with what regulatory frameworks we are talking about. First of all, is to let you know that regulatory frameworks are there to set standards and norms for training of health professionals. I think that is very, very essential. But we also know that a regulation framework are there to ensure countries or member states have strong and resilient health systems that are needed for universal health coverage. And therefore, for us to be able to move towards universal health coverage, we need very strong and resilient regulatory framework. But we also know that regulatory framework in training are there to impart knowledge, skills, attitude, and health processes that are expected to improve health. It's very, very critical that the training that we develop or we design for health professionals really are geared towards that direction. But one of the things that we find, and I think it's across the African continent, is the issue of lack. The frameworks are there, but the lack or absence of harmonization of both the education and the training regulatory framework has actually resulted in the production of health professionals who are not regulated in most of the country. And yet, these professionals who are being trained and produced in the training institutions are actually part of the healthcare delivery system, a team in both private and the public. It's not just in Kenya, but I believe it is happening across the country. And therefore, the issue is, what then would be the impact in terms of the quality of care, in terms of patient safety and the overall patient health outcomes of these health professionals who are not regulated, but they form part of the healthcare delivery teams in our institutions. I think these are issues, ladies and gentlemen, that we really need to take into consideration. But one of the most important things is that the public usually is not able to differentiate in hospitals who is regulated and who is not regulated. For them, they have actually developed confidence with health professionals, whether you are regulated or not. And what they all care is, are they able to get the services that they require. Allow me maybe to comment about the issue of continuing professional development, because I know this is an area, it's actually a regulatory function, but it's an area which, as my colleagues have said, it has not been implemented fully in across the member states. And I feel that it is an area that we really need to address as a way of improving the capacities of our health professionals. Ideally, continuing professional development, it is just there to ensure that the health professionals remain relevant in their field of practice. It's about relevance, right? And it's about, so your license is renewed based on acquisition of certain points that the regulator have been able to establish. But now, the question that I want us to ask ourselves that will give directions on the regulatory framework, first is, what is the relevance of the CPD points? Who designs the CPD programs? Is it the regulatory body, or are they the professionals themselves who say, we want to acquire certain skills in this particular field? Then the last question is about, how are we being able to implement the cross-cadre continuing professional development program? Again, because I know regulators have concentrated so much on their respective cadres, but there are other areas that cross-accord various professional cadres, but they are also important improving the competencies of our health professionals. But then, in terms of the effectiveness of the CPD programs, there's an area that I want us really to look into. What impact does it have in terms of improving the practice and the fitness of the health professional to continue practicing over time? There, ladies and gentlemen, that there is a need for us to think to introducing and maybe implementing a fit to practice assessments. In addition to the continuing professional development, we need to ensure that the practitioners do not just acquire the CPD, but also practically they are fit to continue providing services to the people. Several issues that I want us to consider maybe in this discussion. Although although we have the framework, regulatory frameworks are there, but the question is the adequacy. How adequate are the regulatory framework, whether within the member states or across the member states, in terms of, do we have regulatory framework for all? And for all, I mean, do we have plans that do exist within countries all across member states that will take care of the emerging health professionals? Because we have a challenge here. We are continuously producing health professionals of different cadres, but are we ready to have a regulatory framework for them to ensure that their training, their registration, and their practice is taken care of? So the issues of adequacy of regulatory framework need to be taken care of. And then again, the existing regulatory framework, how standardized are they? I want to maybe look at the issue of complementary. Do they complement each other, or is there a lot of conflict? And you realize that it's not just in Kenya where we have regulatory framework that actually conflict or overlap each other, but even in some of our member states here, you realize that there are regulatory framework that they do not speak to each other. They do not complement to each other. So it's an area that we really need to look at. And then the issue of standardization, what I meant is that between education and the Minister of Health, you have regulators in education. We have regulators in the health sector. But the issue here is that the regulations in the education do not speak with the regulations in the health sector. What do I mean? Is that we would want to have
you have only 1 minute.
Yes, I'm finishing, and because this is a very important point. We would want a situation where the regulators in education and regulators in health are able to sit down and to be able to produces health workers, but the Minister of Health is able to absorb the health workers. We want the Minister of Education to produce health workers that Madam Chair, is that unless we have very strong collaboration and partnership in developing and the implementation of regulatory framework, I do not think that we'll be able to move far. Thank you, Madam Chair.
Thank you. Can we have a good hand clap for the panelists? Thank you so much. Of great interest is all of them have confirmed that we have regulatory frameworks, but what is the impact? What is the end product? and what is the implementation, and especially when it comes to regulating standards in the trainings. I think that was a very good session, and I want to thank all the panelists for having kept their time. My names again for those ones who have just come when we started. Mary Senator is my name, the Vice Chair of the Health Committee in the Senate. And in the Senate, we oversight counties, and I'm happy that our governors are represented here. Professor Nyang Nyong is here, and others. And what we look at is employing professionals who are having the skills, the profession, and also who are able to offer service to our citizens. I want to thank everyone, and I want to hand over the session to the next coordinator of the next session. Thank you.
Good morning, everyone. Let's applaud the panel and the session chair, which has just completed this morning's session. Thank you again, delegates, for your participation. I think we are here in good numbers, despite being early. I think at 8 o'clock, we had 70% of the room occupied. We now want to embark on a subject that is an emerging issue that is affecting a major section of the population, health workers being part of our community, the issue of mental health, and the issue of mental health in the training of the health workforce. I will introduce the next speaker, Dr. Frank Jenga, who is my teacher and a mental health practitioner in this republic for over 45 years. He also advises His Excellency the President on issues of mental health, and is a chair of the Mental Health Task Force, which in the last 2 years has developed a roadmap for prioritization and placing mental health in the center stage of the Ministry of Health and the country's planning. And I would not be wrong to say is the face of mental health in the Republic of Kenya. I now take this opportunity to introduce Dr. Frank Jenga. Kindly let's applaud him as he comes to the podium. Welcome, Prof.
Amjambo. Wapi slides za mzee? This presentation of mine is a natural progression of the session that we have just had, in the sense that at the end of it, I hope to have persuaded those who are responsible that no medical practitioner should be registered unless they show competence in the field of mental health. That's a conclusion of my presentation. My presentation, which is about to be projected, very good, answers three simple questions. The first question is, do we have a huge problem in mental health? The answer for that is yes, we do have a huge problem. The second question is, do we have solutions to these huge problems? Again, the answer is a most emphatic yes, and I will demonstrate this in just a minute. If I am given that gadget that forwards slides. And the last question that I would like to address is, are we, okay, we'll do it traditionally. They will do the slides for me. So the last question is this: are we doing that which we should be doing to resolve this crisis? Sadly for all of us, the answer is yet emphatic. We are not. No, it's not working. Where, Kijana, come here. Huh? Okay, it is. So the first question first. The evidence that we have a huge problem actually comes from Maseno, a part of the country well known to Professor Nyong'o, where some years ago we went to the marketplace and the streets and people looking after their cows and goats and established that almost 11% of them had mental disorders of one form or another. Maseno district is a normal part of Kenya, and there's nothing special. Studies have been done in other parts of the country with identical results. We then looked at the more serious mental disorders to try and establish the relationship between psychotic symptoms and common mental disorders that we had found in Maseno. And again, people with common mental disorders were also showing psychosis. We then looked in the same district at the relationship between malaria, mental disorders, and immune markers. And again, we were able to show in the same place that there was indeed a relationship between a common infectious condition and common mental disorders. So, with that knowledge, we went to a place called Chulaimbo, again well known to Professor Nyong'o because he knows the place well, and examined the knowledge levels of clinical officers who practiced in Chulaimbo. And very sadly, they were typical of clinical officers all over the country. They knew little about mental disorders. We then decided to do something about it and trained 41 trainers. We showed that they were able to recognize and manage common mental disorders. And in a project funded by the Nuffield Foundation, at the end of a period of 3 years, we had trained close to 4,000 clinical officers who had achieved a mean change in knowledge of from 42 to 77%, confirming that our intervention actually worked. We had developed training materials with the WHO, the Kenya Psychiatric Association, which was based itself on the primary healthcare guidelines, modified adequately for use in the Republic of Kenya. So, high levels of ignorance, we showed it was possible to train them, and we didn't have to who we trained very, very inexpensively. Our program was 5 days, and it contained a number of modules that I cannot discuss now. But basically, we showed that mental disorders are common and that there is a relationship between common mental disorders and physical diseases. So through theory and role play and that sort of thing, we managed to help clinical officers and nurses recognize and competently treat mental disorders. Another study done by another team had already demonstrated that healthcare workers in general knew very this is your job. I'm happy to report that we are in advanced stages of ensuring that that comes into being. Secondly, and relevant to today, our task force says we have to develop literacy materials to liberate ourselves from these states of advanced ignorance. That is what brings us here this morning. And we're in the process of training and recruiting mental health workers everywhere. The reality is that every health worker, whether it is the watchman at the gate, the cleaner, the nurse, the clinical officer, or the doctor, must understand that mental health is at the center of all that we do in healthcare. The WHO is clear on the point in stating that there is no health without mental health. I therefore, ladies and gentlemen, want to leave you the following questions. Do we have a high burden? No doubt about it. Have we studied the impact on our services? No, we haven't. Do we know what to do? Well, the evidence is available to those who can read. Have we tested the available training materials? Evidence is abundant in published literature. Do we change ignorance into knowledge? Again, published data confirmed. Are we using our knowledge effectively? No. Is this the right forum to start a conversation on this subject? Most certainly, yes. Ladies and gentlemen, I thank you for having the courage to listen to me. Thank you very much.
Thank you very much, Dr. Frank Njenga, for excellent presentation. Let's applaud him once more for a work well done. The last 8-9 years in the Republic of Kenya, after promulgation of the 2010 Constitution, 2 levels of governance in the Republic of Kenya were established, and health was one of the functions that was significantly devolved to the county governments. Yesterday, before the opening session, official opening ceremony, His Excellency Professor Anyang' Nyong'o, the chair of the Health Committee of the Council of Governors, the governor of Kisumu County, and a former minister in the Ministry of Health was making a presentation, but because of constraints of time, we had to cut off the presentation, and he will shortly continue with his presentation. Allow now me to welcome His Excellency Professor Anyang' Nyong'o, the chairperson, the Health Committee of the Council of Governors, to continue with his presentation from yesterday. Tumkaribisheni kwa makofi. The governor is a politician, and there used to be a party called KANU, which still is, and tulikuwa unafanya makofi tatu. 1, 2, 3. Welcome, Prof.
Thank you very much, my brother Mulwa. Good morning, ladies and gentlemen. Yeah, thank you. I will continue from where I left, but maybe just remind you of a few things that I said yesterday, which would lead to the conclusion of my speech today. But let me thank my brother, Dr. Frank Njenga, for a very clear and specific and pointed presentation of the mental health issue, which each one of us should examine ourselves whether we are actually normal or we should see Dr. Njenga to give us a clean bill of health. Now, yesterday, in talking about service delivery and the health workforce from a devolved system governance perspective in Kenya, I talked about 2 things which I would not like to repeat, but just to summarize. One, that since the devolved system of government was introduced in the Republic of Kenya, notwithstanding some of the shortcomings in the Constitution, at least the division of revenue bill along what is stated among counties, and therefore the effect varies from one county to the other, especially in the area of human resources. Counties which previously were regarded as being in marginal areas, particularly the ASAL countries, the drought-stricken countries, mainly to the north of Kenya, have really been constrained in establishing health facilities because they were the poorest resource previously, and they need substantial resources to catch up. Nonetheless, the access to health facilities has been easier now after 8 years of devolution than before. I therefore called yesterday for this transition to a default system of governance to be managed better and to avoid conflict of interest in the allocation of resources or conflict in between the national government and the county governments to this effect. Today, I want to talk more about the training of healthcare workers and the need for collaboration in design and delivery of healthcare through this training system. Our Constitution clearly says that we have 48 types of government, 47 devolved and 1 national, separate but interdependent. Unfortunately, in interpreting the Constitution, we have tried more to look at the separateness and resolve problems that arise from this separateness than emphasizing the interdependence, particularly in the health sector, to ensure that health delivery is effectively done, notwithstanding the fact that we have these 47 governments versus the national government. And I think this kind of conference makes that kind of discourse possible. Kenya Medical Training Centers has expanded campuses to enhance equity with the county government in some cases providing co-contribution in the form of land. One of the areas of training healthcare is really to be found in the Kenya Medical Training Colleges. They're a very important source of producing human resources for both the national government and the county government, and we should put emphasis on them. For example, as my friend Dr. Frank Jenga is talking about mental health, to what extent do Kenya Medical Training Centers infuse mental health knowledge to all ranks and cadres of healthcare workers that are trained in Kenya Medical Training Centers as institution of preparing the workforce of the health sector? So while these gains of expanding KMTCs into counties are significant, county governments have also experienced hurdles, especially in the following key areas: bearing a disproportionate burden paying for salaries of doctors undertaking postgraduate training with the national government only funding tuition. You understand that postgraduate training cannot be done in KMTC, but in much more advanced institutions usually controlled by the national government. For example, in Kisumu County, we shall lose our postgraduate doctors going to Moi Teaching and Referral Hospital and Kenyatta National Hospital. And now, of course, the Kenyatta University Hospital, Kenyatta University Referral Facility that has just been established recently. Once they go there, they render their labor to those national institutions, but their salaries are still paid for by the county governments. That disparity, that contradiction should really be settled through proper discussions between counties and the national government. Unfortunately, the Intergovernment Technical Technical Relations Committee, which was designed to do that kind of thing, has not been given the recognition or capacity to do that work when there are such conflicts between the county governments and the national government. There is also inadequate compensation for providing county health facilities for internship and attachment to training institutions. Now, the final solution, or the eventual solution to this problem, is not really to continue crying about it, but make referral hospitals or referral facilities in counties, especially within regions, develop their capacity for doing postgraduate work for doctors. For example, there's no reason why Jaramogi Oginga Odinga teaching a referral hospital in Kisumu should not have a postgraduate program for neurosurgeons, for example. That can be done locally, and those neurosurgeons can help build the capacity for neurosurgery within the region rather than going to Kenyatta National Hospital, Moi Teaching, or whatever, and then depriving those regions or those counties of their skills and professional capacity. There's also percentage staff absenteeism resulting from their participation in capacity building activities coordinated by National Ministry of Health Department. I don't know whether the ministry realizes this, but the frequencies which the ministry organizing task forces or training programs or whatever, and using our own doctors in our referral facilities or even sub-county hospitals to participate in these training programs or capacity building programs or so on, quite often deprive counties of very critical staff at very key areas. I've had experiences in Kisumu County, for example, where somebody goes for surgery, for example, in Jaramogi Oginga Odinga Hospital, and the only anesthetist who is in that hospital is attending meetings somewhere without any substitution being arranged in that hospital. This scarcity of human resources, and I think the two of us, the national government and the county government, should sit down and examine very critically those key professional capacities in our particular referral facilities within the counties of the region, which cannot afford the absence of one individual on any one day with critical skills. If you know that this is going to happen, then please let us double the capacity or triple the capacity so that we can have training programs going on, but at the same time, these facilities are not deprived of very critical resources in terms of specialization at critical times. Quite often, it has caused fatalities. So I think we should avoid this. Collaboration between county governments and tertiary training institutions, including those offering certificates, diplomas, degrees, and short-term courses for career development, has thus been complex but not dynamic enough to respond effectively to changing county needs. There is lack of synchronization of plans for the training institutions with the development plans of county governments, resulting to inefficient resource allocation, overburdening of county government with costs for supporting students on attachment and internships, and inadequate preparation for mentorship and coaching. In other words, market readiness. Further, there is urgent need to address the fragmentation through greater involvement of devolved governments in co-creation of training programs. Further, the revision of training curricula for the various courses offered to health workforce and allied workers should utilize information generated by county government from service delivery experiences and county planning tools such as CIDP, ADP, and county health sector plans. I have a feeling that though counties religiously plan these documents, these planning tools, I don't think they are shared very effectively with the national government's institutions. So the left hand may not know what the right hand is doing, and perhaps this is to our detriment, because we should capitalize on our ability to plan and focus into the future rather than live for today without knowing what planning is going on at the county level and the national government as well. Experiences garnered during the COVID-19 response in terms of use of virtual platforms for collaboration and capacity building is important. Task shifting of health workers' roles and mobilizing sectoral coordination in health protection, promotion, and preventive services should be incorporated urgently into the more normal healthcare delivery programs, both county and national. Now, we learned, I think, a very useful lesson during the COVID crisis, which is not over yet, that actually we are underutilizing some of the resources we have in terms of human resources. We want to organize meetings in Naivasha, people will travel, get per diem, say for 2 days, travel back, and just the amount of time wasted in terms of traveling from one place to the other, and arranging meetings, and the cost and so on, it's not really necessary. If we did things like we did during COVID times, just arrange Zoom and talk and finish and go back to work. Sometimes I find it useful to hold cabinet meetings at night when everybody have finished their day, they have eaten their dinner. You can have 2 hours, 8 to 10, rather than watching TV and do very important government business without interfering with the day work of, for example, my people in the health sector who may spend that time better in the county referral facilities. Let me talk then of strengthening regulation of health providers for improved accountability. And this will be my penultimate point this morning. There are several legislations, at least 11 of them, that establish agencies that govern the regulation of training, registration, licensing, and the practice of health professionals. However, several professionals, including radiographers, biomedical engineers, dental technologists, optometrists, emergency medical technicians, orthopedic technologists, morticians, health administrative officers, and medical social workers are not regulated, yet they account for a significant proportion of healthcare workforce. I think Professor Jenga just referred to this. These are very difficult terms. Sometimes we don't understand what they mean. But there are people working in the health sector, and you wonder what kind of regulation exists to keep them into account during this very difficult professional work that they're doing, but whose delivery must actually be regulated. This calls for greater collaboration with a clear framework on delivery of regulatory functions where county governments have a significant input, such as recommending internships, maintenance of register of professionals, license issuing and renewal, disciplinary actions, migration in and out of the county of health workers. Such efforts will support county governments in harmonizing management of human resources under the county public services boards. I will give you an example. One of the things I discovered when I became governor of Kisumu was the problem of equipment in all county government facilities, from the dispensary to Jaramogi Oginga Odinga Teaching and Referral Hospital. You can go to a health center and find they have a microscope which is not working. You ask them and say, well, some spare part is missing. You say, but that's very simple. If all our microscopes in the county were from one model and one make, we should have access to some company who makes them, who knows that maintenance is important. We then got an Italian company to come and look at all our equipment in the county, and they told us, you are in a mess. There are all kinds of makes and models of every equipment, and something very simple breaks down, you have to call somebody in Holland to get a spare part. This is crazy. There should be a standardization of makes and models of equipment in our hospitals, both national and county, so that we maximize on economies of scales in terms of spare parts. And that's a very simple message that if we were collaboration closely with the national government, can be solved immediately. I think the MES program is trying to do that, but those problems or the MES program, we can sort out and do something better. Let me talk about reorienting of our primary health care to optimize available resources. We decisively need to reorient our investments to support the public health system agenda and as the anchor of universal health care. The need to systematically plan for and address the broader determinants of health through informed review of public policy empowerment of citizens cannot be overemphasized. Further, there's urgent need to prioritize investments for community health services, appreciating the role of communities as co-contributors of health programs. Now, my brother from South Africa mentioned this. Unless we begin looking at the healthcare system from family health, community health, and then the curative system, we shall always have a very high bill in the health sector. But if we invest effectively in family health, community health, as indeed Cuba stands out as a good example. By the way, the Cuba's polyclinics, which are the equivalent of our health centers, are the most important institutions in the Cuban health system. The Cuban family doctors, and every Cuban who becomes a doctor must qualify as a family doctor, is perhaps one of the best things that was established in Cuba, so that Cuba stands out as a county, or a country with the best health system. I remember when there was a World Congress on health, public health, it was held in Cuba. And the majority of participants from America, I attended it, I think sometimes in the early 2000s. Most of them were from the US, although there was a barrier, what you call a blockade between the US and Cuba. The Americans went to Canada and flew to Cuba just to make sure they were participating in the Congress, and they were the majority. So you can understand the importance of what Cuba is telling the world. There's no reason why we should not copy what is already there, rather than trying to reinvent the wheel. Reorientation of the health worker towards this end entails acquisition of a wide range of skills and expertise across the health system and sectors. Multidisciplinary teams approach with greater focus being laid on health promotion, clean air, access to healthy food choices, green spaces, water and sanitation, waste management, adequate and affordable housing, road safety, and effective public transport is cardinal to developing a health workforce which will find a friendly environment to deliver their services. That is one of the reasons why the health sector must work closely with the other departments of government, like Department of Housing, Urban Affairs, and so on, to ensure that as they implement policies in those departments, they are health friendly. Both pre-service and in-service training programs will need to emphasize generation and collaborative use of evidence. Reorientation of reward and incentive structure, including better recognition of private healthcare workforce, just like has happened with specialists, is important. Evidence-based decision-making is what we are calling for here. We should not say these things for purely populist and sentimental reasons, but because there's evidence that shows that if we follow that route, there will be improvement, not just in healthcare delivery, but in understanding and imagination and commitment of those who are trained to deliver healthcare. Our policies and legislation at both national and county government levels will need to take care of the pervasive expansion of health technologies and ICT. Point-of-care diagnostics are currently accessible to both health providers and patients, thus posing new challenges on information availability and ethical issues. Hence the need for telemedicine. Let's not think of telemedicine simply as something at the top level of healthcare delivery, in other words, health referral facilities, but telemedicine from the dispensary. It's not rocket science. In fact, if our kids at the age of 3 can pick up a mobile and know what TikTok is about, that fellow working in a dispensary should easily be capable of participating in a telemedicine program, connecting the health center or the dispensary to Jaramogi Oginga Odinga or Kenyatta National Hospital. Finally, use of technology and deepening accountability, logically following from what I've just said. A persistent priority issue in all health sector discourse has been strengthening of data management, improved planning, and decision making. Electronic patient records must begin at the dispensary level. And since Kenya is now known for a country with the widest expansion of mobile telephony, there's no reason why we should not mount a program where technology is used, ICT is used from the dispensary upwards. Let us not concentrate up here when up here cannot communicate with down there. County governments have been walking this journey through investment in revenue collection systems, health management information systems, and even performance management information systems. Additionally, county governments have implemented several human resource information management systems in a bid to improve resource allocation and accountability. There is increased call and commitment to implement electronic medical records and commodities management system that assure visibility of commodities-related inventory data. This calls for not only rethinking regulation, but also curriculum design and delivery. Just 2 weeks ago, we signed a memorandum of understanding with a company that is going to make us use drones to deliver medicine, blood, and so on in the Lake Region Economic Bloc. The chairman of Lake Region Economic Bloc, Professor Dr. Paranya, and myself signed this on behalf of the 14 Lake Region Economic Bloc counties. We believe that that technology will help cut the delay in delivering products from the referral facilities to the primary health facilities, from the Kempsa depot in Kisumu to where it is distributed by lorries, which may take time and the life is lost. So these technologies are not that expensive. It is just liberating our minds and receiving them and making sure that we incorporate them in our system today, not tomorrow, and then we'll find that we reduce on the cost of human resources, and we use human resources critically and effectively where it is demanded. We have also had critical lessons in managing specialized health workers under the current arrangement that allows dual practice. Whilst acknowledging issues of scarcity and limitations in mobility of the professionals, it is important that we relook at the current arrangement for improved accountability. What I'm saying is the following. Yes, we do have shortage of certain professionals, like medical physicists, like radiologists. We may have them, but I think improved systems of communication that is available given modern technology can help us mitigate those shortages and not continuing to deny services to our people simply because we have those shortages. I think the way Cuba overcame the blockade by the Americans and developed very fast to use what they have to become the best county with the best medical system, Kenya can do it in double quick time. Thank you very much.
Us, we have many representatives of various partners, but I think it's important to recognize the partners that we have worked very closely with in organizing and planning this conference. And I want to recognize the CEO of the AMREF Health Africa, Group CEO, Dr. Gitai Githinji. Kindly let's appreciate Gigi. We have the WHO, represented by Juliet Nabioga. Feel recognized, WHO. UNICEF, Dr. Maniza, I saw her yesterday. Yaron from UNICEF, we have quite a team. They really supported us. J&J are some of the partners that I've been working with. We have other partners that we have been working with very, very closely as a ministry and as conference organizers. And I want to take this opportunity to detour from the official program and invite Julia Scott, who is the Deputy High Commissioner and Development Director of the British High Commission, to make quick remarks. Then we revert to our program. Mr. Juliet, kindly welcome. Let's applaud him as he comes to the podium.
Good morning, colleagues. It's a real privilege to follow Professor Nyang' Nyong'o, who has really been living and working on these issues for so long. And it's a real privilege to be addressing colleagues from across the continent. I've had the honor of working in a number of countries, not just here in Kenya, in Nigeria, in South Sudan, in Ethiopia, and living and working in those places and traveling much further. So it's a real honor to be with you. And thank you very much to the organizers for such a terrific event, but also for allowing me to speak. On behalf of the UK, but also I'll reflect a little bit on some of the partners. And I know I'm a detour on the program after we had to change things yesterday. So I'll be very brief. Colleagues, I wanted to start by just reflecting that when I was at the coast 2 years ago, was just when COVID was hitting. And I happened to be with the governor of Kilifi, and he was taking call after call, and tourists were cancelling, and it was hitting. And it's just terrific to be back and seeing the coast busy. Maybe colleagues from other parts of the continent won't realize how busy this part of Kenya is. And it's just terrific to see it back, busy, buzzing with life. And it's been difficult. But it was also 2 years ago that companies such as AstraZeneca and researchers across the world started looking for a vaccine and all the other treatments for COVID. And it's been incredible effort through you and your teams that have got 2.5 million vaccines injected into people's arms, doing all the treatment for people who've been ill. And I say that very, very conscious that there has been a disparity in access. And to me, that's one of the huge challenges ahead, to make sure that we get that equality in terms of vaccine distribution and into arms. It's got to be an absolute priority going forward. But we shouldn't also underestimate the effort that's gone in and the success that's been had. And again, speaking with a Kenya hat, I think that it's been an amazing effort here. One of the key lessons, I think, that's come out of COVID is two things, and one of them Professor Anyang has covered, this point about evidence-based policy. When you follow the science, you get the good result, to put it crudely. The other key lesson, of course, that we take away is that when we work together, we have that success. We know we're all in this together, and we've got to have that common endeavor. And it's exactly through efforts like yours that happens. So as the UK, we're very, very proud to be associated with the push here in Kenya, but also across the whole continent on universal health care. And of course, we, like everybody, we take a very system approach to that. It's really important because even though we're talking about times of COVID and we'll have to deal with this as we go forward, some recent research across 18 countries has shown that for every official COVID death, you have at least 2 other preventable deaths that have happened. And so while we need to keep focusing on COVID, this issue of wider health systems and wider health workforce is absolutely central to this discussion. As the UK, we're very proud of the different mechanisms of support we have. In many of your countries, we'll work bilaterally. We'll be providing direct support to your ministries of health or your partners. I think as the moderator highlighted, we actually support many of the UN organizations, UNICEF, WHO, etc. And we put most of our funding actually through multilaterals. We put it through the Global Fund, we put it through Gavi, we put it through the World Bank, so that this pooling effect happens, so that it's not just people working individually. We do some of that where we think we have a particular comparative advantage, but it's that pooling effect so that you get to scale and so you get real expertise on an issue. On the topic of this conference, we will continue absolutely supporting workforces, mentoring, training, all those kinds of good things, because we know at its most simplest, healthcare is about the people. It's about you and your teams dealing with people who are unwell, dealing with the systems, trying to make them work better. And ultimately, that's what has the effect on outcomes for patients. We see this in health. We see this across the whole public sector. It's that point of delivery that makes the key difference. And that's exactly what this conference is about. And we're so proud to be part of it and to endorse it. So just a couple of examples really from Kenya. And again, this is part of that focus on the front line, as the nurses, the midwives, the community health workers, as well as helping build the next generation. So we're very proud that we've actually trained 12,000 health workers here in the country, and particularly on emergency, obstetric, and newborn care. And we've done this actually through in-service training. And that's been great, but as we've gone along, for example, we found actually it's quite disruptive to pull people out, train them, train them sort of slightly later on in their careers. So of course we've been working with the ministry to try and rejig it a bit and have that pre-service training. So again, working through a fantastic UK institution, the London School of Tropical Medicine. So we're looking at that, we're looking at the curriculum, we're looking at for nursery and midwifery to make sure that those kind of issues are covered in pre-service training so that the next generation don't have to wait until they're already in the job before getting that kind of training. Let me be brief. The key issue, capacity matters, the wider system matters, because again, it's that point of delivery. It's often the same people or the same teams that are immunizing children, that are then providing care, that will then be providing vaccines to elderly people to protect them against COVID. It's those key workers that make the difference. 1 minute on our partnership with Kenya. Last year, we were very proud His Excellency the President was in the UK. He signed our health memorandum of understanding, a bilateral health agreement essentially. And we're very, very proud of that because it's not just about the piece of paper, the signing, that partnership, that intent. Actually, one of the key things we're already working on is getting nurses from Kenya, where they're unemployed, into the UK, where they can be deployed to the NHS, which is our National Health Service, which is under deep pressure. And that's all within, codes of conduct from the WHO, our own internal standards. It's done in a win-win way where extra nurses from here can go to the UK, they earn money, they send it back, they support both ways. And both the Cabinet Secretary for Labour and the Permanent Secretary for Health were part of the delegation that was just last week, or was in the UK last year and then was relaunched again last week to make sure that works. One final thing, and again, really echoing what Professor Nyang and Nyong'o has said, this issue of innovation and technology. One of the things that we feel really symbolizes the UK and we feel really symbolizes Kenya is this focus on research, on innovation, on digital approaches. And we're very proud that we've worked with the KEMRI, the Kenya Medical Research Institute, literally just up the road here, for over 30 years. And it's not just been a government-to-government partnership, but this has actually been a partnership between KEMRI and the University of Oxford, and particularly with the Wellcome Trust. So that partnership, again, 30 years, research, innovation, focusing on vaccines. And I'm very privileged that, that after this I get to go up there and we're launching the next phase of that partnership. Very much, forgive me colleagues for jumping through that, but just in closing, really welcome the support that was, the program that was launched yesterday on rolling out universal health care. We will continue to support Kenya as we support countries across the continent on that, but making sure that the issue of this conference on workforces, on capability, on human resources as really the central part of that program are absolutely front and center, and that colleagues have the training and the support they need as we go forward. So in a few words, I mean, whether it's on COVID, on vaccines, on nurses, on capacity, on these health systems, on innovation, really our partnership is to support you and support governments across the region so that we're supporting your priorities and that we're supporting the aspirations of, in this case, the Kenyan people for healthier, longer lives. I mean, ultimately, that's what it's all about. And we're very proud to play our small part in that. So thank you very much to colleagues across the region. For Kenyan colleagues, asanteni sana.
Thank you very much, Julius, for wonderful remarks, highlighting the relationship between Kenya and UK in the area of health. Let's applaud Julius for his wonderful remarks. I now want to retire, and I want to introduce the next chair of the next session, Honorable Sabina Chege, the chairperson of the Health Committee. in the National Assembly, who is serving a second term in Parliament, and having previously served as the chair of the Education Committee in the last Parliament. She blends the curriculum and the health experience very well, and she is also the Member of Parliament for Murang'a County, and this being 2022, may be the next governor of Murang'a. I want now to invite you, Madam Sabina Chege, to the podium to take charge of the next session. Let's applaud her as she comes. And as I said, Kanu were 3 slaps. 1, 2, 3. Welcome.
Well, good morning, everyone. Good morning. Our session is going to take 30 minutes, so I hope it's going to be a very interesting session. Thank you for that great introduction. And we're going to take up on the repositioning of today's workforce for the future. I want to request the following persons to come up. Yumbia. And so I understand the team could kindly be seated. I request that we sit, you take the other seat so that I'm near here and I'm able to facilitate just kindly. And the gentleman, you could have sandwiched a lady in between. I don't know where you are mean. Yeah. Thank you very much. So this session is going to be a quick one because I already understand you have really worked on this and there have been even a paper before. And so we will start with home from Daniel Yumbia from Kenya. Please take us up and do the introduction. Let us know where we are, what we need to do. Mine will be basically to give a conclusion after you do the discussion. So let me start with Daniel Yumbia. Take it up, please.
Thank you, Chair and delegates. Our topic is health workforce migration. We're looking at it from 3 perspectives. One, I'll look at it from the local setup. Why do health workers migrate from one county to another? What are the reasons that make them migrate? We did initiate a study under the support of AMREF. And we did it under the auspice of Association of Medical Councils of Africa. And we established that doctors migrate, or health workers migrate, move from one place for various reasons. So in the context of our county, and I wish Prof. Anyang' Nyong'o was here, we realized that in the counties, health workers migrate because they do not have a uniform service benefits. Therefore, health workers move from one county to another because some counties have very good packages for training, and others also take care of their workers in terms of remunerations in a timely manner. So we have numbers that indicate doctors and nurses and clinical officers have tended to move from one county to another for those various reasons. Amenities that are there, and more so the training aspect, where they want to advance their training. Some counties indicate that once you want to move, you are on your own, and therefore when you go, you don't come back and you are not compensated. That's the Kenyan perspective in the counties. We also did initiate a study because we do have a form. Initially, when doctors were going for training outside, we had a form that was referred to as a certificate of status, and you would indicate where you are going. Now, it used to be called certificate of good conduct. Now it's certificate of status. And in that form, we like doctors to indicate and nurses to indicate where you are going and the purpose. So the report that we have the last 3 years indicate that most of our health workers migrate for further studies. So as we sit here, let us think of the training opportunities that our doctors and nurses look for outside, which we can address locally. In Africa, our health workers mostly migrate to South Africa. Some of them go for further training in South Africa, but also Southern Africa, particularly Namibia, gets our health workers for better pay as compared to what they get here. So others migrate to UK and Canada for greener pastures. Therefore, our position is that health workers must be trained adequately. They must be accorded adequate opportunities for further training, and they must also be, efforts must be made to retain them by considering their welfare. And I'm sure if those issues are addressed, we shall ensure that our health workforce is motivated, remunerated appropriately, and therefore their chances of failing to migrate from one country to another will be controlled. Chair, I submit.
Thank you very much, Mr. Yumbia. Mr. Yumbia has taken us a journey on why we are migrating. But just for us, we are looking for the repositioning of today's workforce. I'd like to go to the next person, and I just want to ask ourselves, where are we? And as somebody said, COVID came to teach us a lot of things, especially in the health sector. Are we in a position to give a clear direction? I want to go to Professor Namu Tandai from South Africa. Just tell us your experience. Where are we, and where do we need to go?
Morning, colleagues. I'm Prof. Nemu Tandani from South Africa, the president of the Health Professional Council in South Africa.
I'd like, Prof, just position your microphone properly so that we can hear you.
Where we have 12 boards, including medical and dental board, where we've got Prof. Ratamane is in our midst, is the chairperson of that board. Prof. Ratamane, thank you. Now, the issue of repositioning of today's workforce for the future. There are critical questions that we should be able to answer. What is the vision that we have for those health professionals for the future? We need to first acknowledge that disease does not need a passport to cross into any country. And that is what we should be preparing our health professionals for. It does not need a passport. And we also need to acknowledge that human development it's coupled with environmental destruction. As we develop, there is an environmental impact. So the disease of the environment or the environmental diseases are going to be with us. The other aspect is we are all moving into technology. And the previous speaker, as they have indicated, technology is with us, and there will be related diseases with it. Very few of us here, we are controlled by the gadgets. We are always looking at what is the next message, whatever is happening around us. So there should be a multidisciplinary approach to that in terms of the health professionals that we have. As I indicated, it's people and technology, and we are more and more affected by it. Now, this workforce that we are talking about should then be introduced to the future that is coming in terms of the disease patterns, where we would have a lot of diseases that are related to technology, related to environment, and other issues. So our kids, as early as they start schooling, or whether it's in the kindergarten, should be introduced to technology. Otherwise, we will remain behind with other countries moving very fast. We should allow our kids to have an inquiry mindset, which is very important. A typical example that I need to mention here, which is also important, is the issue of our teaching and learning. Most of our curriculum is based on the teaching and learning. And I want to challenge you that our kids should start by learning, and then we tell them, or we teach them after they've learned. They should first be learning their own environment, and we assist them in terms of what more can they learn. The other thing that it's very important, and I think it's challenging for Africans. In my other life as an academic, I've learned that a lot of Africans, we are consumers of knowledge from the West. We do not consume our own knowledge. And I'm happy that the project of Prof. Njenga was very important. We need to start to write the story of our own. The project that he has conducted should be translated into policy. What do we mean by evidence-based? We shouldn't be taking the evidence of what is applied in Europe without taking our own evidence that has been presented here today. That's what we call action research. It must be translated into policy. It must be translated in what informs the best for us here in Africa. The last thing which I want to mention, and Chairperson, that unless we change our mindset, the workforce that we produce will never be enough for us. When you are in the academic institution, and I've heard here yesterday there are deans and vice chancellors, we need to encourage the mindset that does not only consume what our professors have taught us. We should not be remembering history of how our professors performed. Allow us to move beyond that. And I'll give you a typical example. When I was doing my PhD, the professor said, but I've never done that. And that's the limiting mindset. I should not be doing what the professor has done. Allow me to explore beyond what the professor has done. That is what we call knowledge generation, rather than consuming the knowledge that has already been done. Thank you, Chairperson.
Thank you very much. Let's appreciate Professor. Professor Macheka from Zimbabwe. Oh, great. You can take the podium. Maybe you can pick us from where the Professor Anne Mutandani has left, from our technology, use of technology, collecting data and evidence, and going to change of mindset.
Thank you. My name is Josephine Makutuya. Yes, standing in for Professor Macheka. I'm the registrar of the Zimbabwean Medical Dental Practitioners Council of Zimbabwe. If my presentation could be put, please. I was asked to talk about repositioning of health workforce development for universal health coverage. in order for us to achieve it by 2030. I would like to acknowledge Dr. Chirenda, Deputy Dean of the University of Zimbabwe, my professor who is my chairperson, Professor Kambarami, and Dr. TJZ Bungu, who is our vice chairperson, for assisting me in coming up with this presentation. The structure of my presentation is going to be, we're going to have a background. It's very short background, learning outcomes, strategies to reposition health workforce. And to recommend a way forward. I'll be quick, Mr. Yumbia. I'll be very, very quick. Don't worry. I won't waste time.
Wait, the slides are not moving.
Sorry?
The slides were not moving.
I thought they are moving the slides.
Yes, kindly, the ones who are moving the slides.
Okay. Through you, Chair, can they assist in moving the slides?
Yes.
Thank you very much. Thank you very much. Now I am on slide number 3, the strategies. If you can go to strategies, just quickly go to strategies. I finished background. Learning objectives are finished. Let's go to strategies now.
The next slide.
Yes, thank you very much.
Thank you.
What are the strategies to reposition health workforce in the region? What should we do as regulators? What should we do as stakeholders? There's need for optimization management of all health workforce in low-income countries. It's necessary. We need a realization of universal health coverage by 2030 by looking at the 6 pillars. There are 6 pillars of universal health coverage. I won't go through them. We know them. Just briefly, priorities, regulatory environment, where we come from, and laws, financial commitment, education, partnerships. We've just had a partnership from UK. We need them. And human resource management systems, as have been alluded to by Professor in the previous speaker. Next slide. It's a continuation of strategies. We need a paradigm shift, Madam Chairperson, as the professor just said, my predecessor speaker. We need to change the way we do business. We don't have to continue to do things the old ways. We need to change by looking at our recruitment. How do we recruit our health workforce? At selection criteria, we should consider university aptitude test. The UK does it. We don't have to reinvent the wheel, which assesses attitude, behavior, and character. That's part of the selection. We don't have to take by academic. We also have to look at those issues. We need health workforce which exercise empathy, which is consistent with clinical practice. That's what we should look at. In South Africa, during my desk review, I noted that they have got an inclusive policy on recruitment of underprivileged backgrounds, where they support them and have bridging support. This is what we should do. Let's not continue doing business the old way. We should think and move ahead. Strategies continued. Let's look at competence. based education systems. In the context of limited fiscal realities, linking education and training curricula to the needs of the country is critical. That's what we need to do. I think it has been highlighted before. There should be a transformation of education programs and learning strategies to ensure competence of health workforce for changing burden of diseases. In technological environment, telemedicine, we have heard the professor talking about drones and things like that. This is where we should be going, Madam Chairperson. There should be a shift towards education and training that prepares the health workforce to deliver the effective primary health care to meet increasing challenges of the non-communicable diseases. Nursing and medical training in Thailand, they've done that. In Zimbabwe, we've also adopted this in their curriculum. All these adequate mix competence-based, they should be addressed in the curriculum development. Research, as had been alluded by the professor from South Africa, is critical. We want to promote health research as part of promoting health workforce development. What is it that we need? We need to research and then come up with evidence-based curriculums. Now, how do regulators come in the repositioning of health workforce development? We are a group of regulators here, of course, and our partnerships, ministries of health, education, which are very critical, and our development partners. Accreditation is important. Accreditation of medical and training programs with external input. We need accreditation committees as regulators. We're now speaking to regulators now. They should have competent external members from the region. We are very grateful that in the East African community you have that. That should be promoted in ECOWAS, in SADC, North America, North Africa. We should have this accreditation committee which accredits our training programs, our training institutions. They should also be accredited. We should license public and private health institutions
prepared with a presentation, and she's the only lady in the panel. So let's appreciate her once again. Dr. Banyu Bala from Ghana. I think Josephine has really taken us deep into what's happening. But we know there's a lot of now digitalization, and we are saying the future is digital. How are we involving the students, the stakeholders, as we come up with the curriculum so that we prepare them well? I recall when I was doing some training and I was doing my master's, the things that were being taught out and I was in the industry were quite different from what was on the ground. So how well are we involving the stakeholders? Do we do enough research? How updated and well is our data? I want you to take it up from there.
Thank you very much, Madam Chair. And I wish to associate myself with the very brilliant submissions by my co-panelists. Safe to provide this added perspective. As professional regulators, what do we regulate? And what do we need to do in that will ensure repositioning? So when you are repositioning, it means that you have moved. There was some settled position, and you need to get back to it. We regulate three things I submit: competence, conduct, and ethics. Ours, the healthcare space, is a scientific space. And if we were in any doubt, the violent jolt of COVID-19 has told us that healthcare professionals can also be conspiracy theorists. Therefore, our commitment is to ensure we keep our eyes on the technical competence of the healthcare workforce, rooted in the scientific paradigm. That is critical. Now, the field of science, medicine, nursing, pharmacy evolves rapidly. It comes with technology as an enabler and innovation. And a future repositioned health workforce must necessarily have competencies in these areas. Evidence-based medicine, healthcare service provision should be the norm. And we need to get back to the science. And earlier presenters mentioned that. The events of COVID also showed us that being a multidisciplinary setting, it requires a certain level of leadership to generate the transformation we require. It became obvious during these processes that we need to get back to the healthcare worker, not just as a teacher, not just as the healer, but as the leader who can envision, who can inspire, who can direct change to deliver performance. There are no ifs, there are no buts. If it is repositioning that we desire. How to communicate? It became obvious to us that risk communication, we got too comfortable in our public health community engagement exercises. And communication was not socio-culturally sensitive, and in most instances, downright inappropriate, and fed into infodemic. So if we have to reposition, we have to also let the healthcare worker understand that you need all the critical stakeholders, the community, public sector, private sector, and the new healthcare worker must therefore have an entrepreneurial spirit and understanding of that context to know that when we work together, we achieve more. Private-public partnerships, so nobody is left behind. The new healthcare worker must understand that ours are professions with rich traditional norms, values, which have crystallized over the years. And they have been distilled through usages and practices into core principles and rules, which we then enforce when things don't go right. Now, it is important for the repositioning to understand that our commitment when we take oaths, for example, the medical class, is a commitment to science, to society, and to the profession. And it is absolutely non-negotiable that we have to go back to the core value of the patient as the primary concern of all our scientific endeavors, and for whose benefits and whose interest we are deploying the resources and the resourcefulness of our science and our being. So when you find that in our space, of all the constants, I dare say one is more constant, and that is change. And in science, medicine, technology, innovation, it happens really fast. And COVID has told us. A repositioned health workforce is the one that is capable of adapting. Hindsight must provide us for today's conversation deep insights into what we are sharing here. But these insights will not be anything unless they provide the foresight to get the healthcare workforce of today better prepared for the occurrences of tomorrow. So I submit that in medicine, in health in general, in science, and in technology, change happens, and it happens real quick. It requires a transformative leadership to mobilize stakeholders. And the new healthcare worker who is repositioned must not only be the greatest scientist who follows the science, but must be the leader. And a well-prepared repositioned healthcare worker is the one that in the midst of COVID can still see the patient with a smile. These are the core ethics. The basic dignity of our patients are not violated because of our own inadequacies, lack of confidence, and knowledge of the unknown. I submit. Thank you, Madam Chairman.
Thank you. Thank you very much, Dr. Nyubala from Ghana. And it's true that nobody should be left behind. And I had saved the last, this must be the best, to Dr. Lekau from Botswana. Leadership and management within the health sector is key. And I know you've listened to all the panelists, so I'll give you an opportunity maybe to touch on the issues maybe they have not touched on. You can add a few items, but do you think we need to invest also in upskilling the leaders and managers within the health sector as we reposition for the future? Upskilling the managers and the leaders within the health sector.
Thank you very much, Madam Chair. My name is Modisa Motswaledi. I'm with my colleague, Dr. Tacheba. I'm Dr. Motswaledi, and I'm the chairperson of the Botswana Health Professions Council, currently also working for the University of Botswana. And the question, as it has been posed on repositioning today's workforce for the future, also demands that we know what we expect in the future. And obviously, some of the things that have been discussed at the conference, including the designing of relevant and effective curricula that are appropriately regulated and monitored, gives us the basis for preparing a workforce for the future. But even in addition to that, the fact that most of these points have already been covered by those who have presented, I'm just going to pick on a few that I feel I might need to stress a bit. There has been a mention of continued professional development, and I think in anticipation of and in realizing that we cannot teach everything in class, therefore it is mandatory that we put in structures that mandate continued professional development as a way of catering for the challenges that we are definitely going to face in the future. We also need to, in my view, to strengthen professional associations as the gatekeepers of the professions to ensure that the future practitioners are kept in line in terms of maintaining standards that under a regulatory environment that also involves the appropriate professional gatekeepers. We need to integrate, this has already been mentioned, research as a way to inform practice and policy. But I think in addition to that, we need to create a platform where we can, as regions, discuss translational research so that what knowledge is gained is not just ending up in papers and publications and actually never comes to practical application. I don't know what the experience is from other countries, but in Botswana, government was the main sponsor of education. And ever since government started cutting down on sponsoring students to go and study in other countries, local institutions have also sprung up to provide some kind of training and degree programs. But often those are also, although they may satisfy the basic requirements for an educational program, the implementation often becomes a problem. And you find that very often for this, in pursuing profit, that the student admissions are far in excess of the capacity of the institution to train them to the quality that is required for practice. So that in looking at the future workforce, we also need to look at structures that will implement an inspectorate and verification to ensure that our graduates are actually being produced to the level that should actually practice at that level. We have other things that keep coming up that we have to cater for. Our regulations have got to be flexible or have at least a framework that allows efficient review of regulations. For example, in a lot of jurisdictions, issues of telemedicine are not regulated yet. And you find that with COVID coming in, suddenly we realized that we needed a lot of diagnostic molecular scientists which are not recognized under certain jurisdictions. And therefore, we've got to move such that our regulations can cater for changes as they occur. I think when we talk about universal health care, there's also the need to ensure that the people that are being trained are growing up with a mind to serve. That not only will they be working in cities, but they should work or grow up with an intention to serve. Some kind of patriotic training needs to be instilled, not just the science. And I think on the last note, I'd like just to come to terms with the fact that there's very likely to be overproductions. When you have got training institutions and now you are producing your own workers, very soon you reach the saturation level, for example, in Botswana, where government can employ only to a certain level. And then you are stuck. I think one of the things that we should be doing as we prepare our workforce is to also prepare for a transition from the basic programs to graduate programs. We should also look at ways in which we can actually enhance, instead of depending on the number of students to generate the funds, they should also be developing, say, other research aspects, so that actually people can now go into research and actually write project proposals that bring in the cash that would substitute for the students, but at the same time, create the cash flow that is necessary to continue in knowledge acquisition. I think those are some of the things that come to mind, and that the other colleagues maybe may not have mentioned, or maybe I might have missed as the other colleagues were presenting. Thank you, Madam Chair.
Thank you very much. And I think it's important we appreciate your presentation. And it's important also that we know that as we reposition, we must not only train for ourselves, because the world has become global, and we need to start training also for other markets. So it's not just about us. Yumbia, I saw you touching the microphone. We are concluding.
Yes, thank you, Chair. I think I got two additional remarks. One, when we look at repositioning a healthcare worker, we're looking at a healthcare worker who is skilled, that we have touched. But we also need to look at the attitudes. If you have the skill and the attitude is not good, what are we giving to the market? I think from the Medical Practitioners and Dentists Council of Kenya, where we sit, we got complaints, and when we go through all the motions, at the end of it, the complainant says, if only the doctor communicated this challenge at the beginning, it would not have gone that far. So we are looking at repositioning a healthcare worker who is a good communicator. Please communicate to to patients. That is one. So that some of the issues that come up are addressed early. Number two, I'm looking at the speech, the presentation by Dr. Frank Jenga. And I'm looking at the Medical Council, where we go and talk to the graduates. My chair of the council talks to them at the end of it, when they are just starting internship. At what level do we introduce the regulator in the training? Don't you think it would be practical, it would be important to get the regulator annual or quarterly, go and talk to these students and tell them this is the way to regulate? And I think Josephine from South Africa, from Zimbabwe, was saying we move from that forcing to that of bringing them on board. If Dr. Frank Jenga was given a session to talk to these doctors periodically, and he's an old man now, he's about to retire, so he can just speak throughout. What do you think would the benefit would be by engaging them so early, apart from engaging them when they go to his clinic, when they are already depressed? Let us reposition this and address these challenging issues so that we do not become victims at the end. We need to address them, and we work with the other workers together so that by the time we get a competent, skilled, and the other issue we have been discussing at a disciplinary level is availability. And the Medical Council changed their regulation last year because we were giving doctors part-time private practice, and that would say from 5 o'clock to whatever time and on weekends. And we look at the issue of dual practice. So for us now, we give a doctor a license to practice in the Republic of Kenya. If you want to do private practice, let your employer discuss with you. And as council, we are not culpable. If a healthcare worker needs to go and do some work, let them arrange with the employer. And that has really changed because the employer has total control. It's not the law that is telling you you are free to work at this time. And therefore, healthcare workers need to self-regulate themselves. So I think that's something that we need to look at the training level. So we move with it so that when we give the product, it is a product that is already self-regulated. That does not need the supervision like policemen working behind them, telling them this is what to do. I think, Honorable Chair, I thought that was a point I needed to mention. Thank you.
Thank you very much, Daniel. And as we conclude, it is important to note that we need to understand the current needs of the population. We are dealing with patients now who are very, very well informed and also very demanding. So as we look at how we reposition, we need to put the patients and the people we are dealing with in mind. So finally, I just want to ask every one of us, do we know where we are? I guess we do. That's why we are here today. Do we know what we need to do? Yes, I think we need to do, we know what we need to do. And finally, why are we not doing it? Let's go out there and do it. Thank you very much. I want to hand it back to Chair.
Thank you. Thank you. Thank you. I think there's somebody from WTO wanted to speak for 5 minutes. Allow them, WTO, somebody.
WHO, if you're here, you can take up the podium just for a few minutes before we take the health break. WHO, are you ready? Okay, let's give her a loud of applause and we welcome her. Karibu sana.
Yes, I guess still good morning. Good morning, everyone. Pleased to be here as the World Health Organization to participate and support this conference. I'm not giving a speech this morning, but my regional director has a video that is going to be played as a speech and a message to us in this conference. So I hope the organizers have it ready so it can be played and we all listen. So colleagues and friends, as the video comes up, I think I need to make one clarification. Dr. Tedros, the Director General of WHO, gave his remarks yesterday, but what we are going to listen to now is remarks from the Regional Director of the WHO African region, Dr. Shidi Moeti.
Your Excellency, Mr. Uhuru Kenyatta, President of Kenya and Chair of the East African Community, Professor Stanley Okolo, Director General of the West African Health Organization, the Honorable Cabinet Secretaries for Health and Education in Kenya, Mr. Mutahi Kagwe and Professor George Magoha, distinguished guests, ladies and gentlemen. It's a great honor to join you virtually here today for this very important meeting to share some reflections as we collectively strategize how to reposition our health workforce to ultimately achieve WHO's highest priority, universal health care for all citizens in Kenya and across the continent. I want to acknowledge the huge toll the past 2 years have taken on our health workforce and pay tribute to you all for the enormous sacrifices you've made and the extraordinary commitment you've demonstrated in the response to the COVID-19 pandemic. This conference comes at a critical time when we're entering our third year of battling the pandemic. Kenya and its African neighbors cannot afford the protracted levels of disruption that COVID-19 is causing. Last year, 1 in every 3 health facilities on the continent reported interruptions to services, including to childhood immunizations, HIV and tuberculosis treatment and care, as well as to family planning. Many lessons have been learned through our failures and our triumphs, primarily that COVID-19 cannot be isolated for special attention at the expense of the many other health challenges we face. Our health workers are at the center of the response. To build a new public health order, we need investments not only in public health institutions, health systems, and health structures at all levels, but in public health workforce training, recruitment, and retention. We're not starting from scratch, however. Africa has consistently built on and strengthened response strategies developed during outbreaks such as Ebola and the HIV/AIDS epidemic. Going forward, we need to leverage these critical lessons learned, including from the past 2 years, to guide our strategies. Health infrastructure cannot be improved without also boosting the number of health workers to run our facilities. Currently, only 1 country in Africa, the Seychelles, meets the requirement of 10.9 health workers per 1,000 population to deliver essential health services. Overall, there are only 15 doctors, nurses, and midwives per 10,000 people in the region. To make good progress towards universal health coverage, that figure needs to increase significantly to 45 per 10,000 population. The African region has only 35% of the required doctors, nurses, and midwives. Worse still, the region has an average of only 1 medical specialist of any discipline per 100,000 people. The capacity to train emergency and critical care specialists is non-existent in almost half the countries. These major gaps have been magnified by the pandemic, which has reminded us that without the inbuilt resilience necessary to withstand the type of shocks and stresses dispensed by COVID-19, the entire chain of care is compromised. Let me pause here to congratulate the government and people of Kenya for expanding investment in the health workforce. Your efforts have resulted in an inspiring 106% increase in the density of your health workforce from 14 per 10,000 people in 2006 to 47 per 10,000 last year. This means that Kenya is at 68% of the international benchmark, making this country a valuable example to its neighbors of the levels of change such investments can bring. These achievements aren't isolated to Kenya either. Data shared with WHO from governments of 43 of our 47 countries show that the region now has more than 4,000 institutions training health professionals. Notably, the number of medical schools in the African region also increased significantly from 168 in 2005 to 410 currently. However, it remains a concern that 4 countries, the Democratic Republic of the Congo, Ethiopia, Nigeria, and South Africa, account for almost half of these. The pandemic is also fueling international recruitment by high-income countries to fill their staffing gaps. This has resulted in excessive outmigration of health workers from the African region in recent months. As WHO in the region, we're working with countries to put in place concrete steps to address both the quantitative and qualitative gaps in the health workforce. One example is the support for 16 countries to conduct essential health labor market analysis. This offers data to inform policy and a solid base from which investment decisions can be made to improve staffing levels. We saw Ghana, Namibia, and Rwanda expand their staff capacity and allocate funding to absorb trained but unemployed health workers. WHO has developed several normative guidance documents, including prototype competency-based curricula to support countries to harmonize their curricula and improve the quality of training. These cover nursing and midwifery and general health challenges in primary health care settings, including eye health, sexual and reproductive health, and chronic conditions. The curricula include elements such as attitudes, knowledge, ethics, human rights, leadership, management, counseling, and service provision, among others. To enhance equitable distribution of essential health workers, WHO has also supported the mapping of health specialists in all 47 countries in the region and is currently supporting a workload assessment, workload indicators of staff needs, or WISN study, to develop staffing norms and standards applicable across countries. Turning to Kenya specifically, WHO is supporting the government to address various aspects of the health workforce challenge. This includes the implementation of the National Health Workforce Account, which is improving availability of reliable health workforce information for planning and management across both the public and private sectors. Multidimensional Productivity Index, or MPI. This is set to be piloted this year with a view to using the findings to improve wage bill management. Other countries in the region are eager to learn from the Kenyan experience on this. WHO is also providing technical advice to the Kenyan government on its agenda to export health professionals to other countries. On request from the Health Ministry, training on the implementation of the Global Code of Practice on international recruitment of health workers will be provided. All these inputs are critical elements towards repositioning our health workforce to advance progress towards universal health care in the region. Much more than only high spending levels is required, as we've seen from the experiences of high-income countries during the COVID-19 pandemic. What is important is the how of these investments in pandemic preparedness capacities such as surveillance, laboratory systems, response and surge capacity, and human resources procurement. What's critical is how to link these with functioning health service delivery, starting at community and primary health care levels. That is the basis for ensuring access to health care for major health problems by all people, and which will progress us towards universal health care. Equity is not just a principle or philosophy. It must inform decisions on investments before pandemics occur and must link with sectors beyond health, like housing and employment, water and sanitation, as well as health financing. The imperative of equitable access is practically demonstrated by what we've seen in the case of diagnostics and vaccines, and now new therapeutics for the COVID-19 response. The same applies for treatment of major diseases across different regions. This has spurred movement to diversify manufacturing capacity across the world, while African countries have adopted strategies such as people-centered responses and family-based index testing to overcome barriers during COVID-19. Working in integrated ways across different disease programs has clearly demonstrated the importance of this approach for health security and universal health coverage. Partnership between countries, governments, the private sector, and civil society, sometimes with some discomfort, but often with huge success, must be prominent in our future actions as we build resilience and response to disease outbreaks and advance towards universal health coverage. Going forward, COVID-19 has shown us that existing training and employment models need a reset. Given the new and emerging dynamics of disease burdens and models of service delivery, this conference has the potential to provide a blueprint for a fit-for-purpose health workforce. My call to action is for a collective effort towards better health workforce planning and competency-based training that addresses health needs, retention of health workers, improved working conditions, as well as safety and protection of these critical people on whose shoulders the future of healthcare rests. Shaping the health workforce we want is a collective responsibility. It requires transformed training and education curricula that address the evolving burden of diseases and risk factors such as health security. No health service can exist without health workers. These are our frontline defense, and they need to be at the center of all plans, initiatives, and strategies to ensure that we leave no one behind in our quest for health care for all. I wish you all a very productive conference and look forward to the outcomes. Thank you very much.
Let us appreciate WHO for that pre-recorded presentation. Thank you. Sorry, we are running a bit late, and that is a spillover of yesterday's presentations. And we really apologize that it was not intentional. Those in Amkwa, you do know that we run the program per hour and on time. And now we've got about 15 minutes break for tea. So grab your tea and let the team leaders in the panels take charge. We will not assemble here again until tomorrow. So the panel leaders are in charge of the discussions. You take charge from now. For international delegates, those who wish to be tested for COVID, and any other person also, because we have interacted, the testing team is going to be at the registration tent, which was at the entrance where we were registering, that they'll be there within the next 30 minutes, so that those who wish to take samples taken, indicate also the timings that you like the indicated time for your barcode results, so that you can use at the airport, because if it's 96 hours, if it's 76, but those who are staying longer, we are not exhausting the testing time. You can still expect to be tested when your time is near. Therefore, ladies and gentlemen, we are now free to go for tea, which is served here. And then after that, lunch will be at the main hall unless advised otherwise. Thank you. Thank you very much. Anything? Yes, yes.
Could I appeal to those who are on the health training subcommittee with their presentations to please be back on time so that we can proceed? The young lady who is helping me coordinate, can we have a chat, please? Could I also appeal to the subcommittee chairs, please follow up your abstracts. I am advised that as of yesterday, we only had 19 submitted. Please submit your abstracts real time. So, could I appeal to Dr. George Gidhu and Kelly Aloch? We don't have your papers in the system. Dr. George Gidhu, are you hearing me? Kelly Alwatch, I'm sure I met you yesterday. Can I ask you please to put your papers on the laptop so that we start straight away? Time is of essence. We are over an hour behind. We have to catch up. Dr. George Gidu, Kelly Alwatch, please proceed to the back stand so that you can upload your presentations. Again, subcommittee chairs, make sure your presentations or your comments, rapporteur comments, are uploaded to the system.
Among other presenters, on their presentations, because not all have made their presentations.
Okay. Please, once again, apart from Dr. George Gidu and Kelly, there are other presenters who have not submitted their presentations. Please proceed to your respective venues and submit your presentations urgently. Time is of essence here. How are you? Do you remember my face? I'm the one. We finally meet. You're not in my committee. You're not in my committee.
Do me a favor. This guy is George.
Yeah, that's what I've been announcing. Kelly or what? Kelly. Okay. So once again, those of you who are in the hall, the assumption is you're not going for tea, because tea, we are only allocating 15 minutes, please.
is to improve access to surgery for the rural population in Kenya. And I was one of the co-commissioners for the Lancet Commission, and we brought out this paper in 2015. If you improve surgery, the GDP of the country goes up by 2% per year. The growth is directly proportional to GDP. So our objective is to improve access for the rural populations to surgery in Kenya, and to improve the GDP and alleviate poverty. That's one of the most important reasons. Next slide. A huge amount of suffering occurs in the rural areas in Kenya. As all of you know, it's due to lack of access and adequate surgical availability in the rural areas. This leads to poverty. If any of you have had a wife who needs a cesarean section, you know the costs involved. If you have a complication of delivery with a fistula, these patients almost always do not have access to treatment. If you have a baby born with congenital abnormalities, that family is driven into poverty. And most importantly of road traffic accidents are requiring, especially the boda accidents, are requiring a lot of surgical care, and that drives the families to poverty. So a large number of our patients therefore suffer from neglected surgical diseases which do not have care in the rural areas. And we did a study in 2019 in Meru County, and we found, this was the Finders Keeper study, 6,283 cases for a population of about 1 million with neglected surgical conditions, which included clefts, clubfoot, cataracts, neglected trauma, fistulas, and hernias. So there are patients walking around, about 6,000 per million population in Kenya, who require a surgical procedure, but these are not being done. And this is what I'm trying to address. Next slide, please. The methods. We looked at the records which we have, okay, of accreditations and COSAXA and OTPEC database. OTPEC is Operating Theatre Practitioners Association of Kenya. So in COSAXA, what happens is if you're the president and then you step down, a year later, you're no longer on the council because we want the younger guys to take the organization to the next level. And each president is sort of trying to improve surgery in his country. So we established an organization called Operating Theatre Practitioners Association of Kenya, with which a few like-minded friends work together to improve surgery in Kenya. Analysis was then performed to ascertain the target of training and adequate surgeons required for this decade. Next slide. So we have 25 COSAXA accredited training sites, as I mentioned, with the capacity of training 62 surgeons per year. We have about 250, approximately 250, precisely 257 district hospitals, but these numbers vary according to where you gather your data from. And if you need 3 surgeons per district hospital, that would give you 771 surgeons required. That's 257 times 3. With the COSAXA training program at the present moment, you can train about 620 surgeons. It's not 650, there's an error there. 620 surgeons in this decade. 62 per year is 650 in 10 years. We've already started this from 2021, and we believe by 2030, with the support from the Ministry of Health and other bodies, we can actually provide enough surgeons required for the district hospitals in Kenya. All district hospitals can then be adequately staffed. Training a surgeon is training a leader, and improving a hospital to provide surgical services improves every facet of the hospital where all the other specialties can also perform. So this has been shown beyond doubt by WHO, by G4 Alliance, by the PGSSE team, that if you improve the hospital to perform surgery efficiently, then hospital will function well also for the other disciplines. Next slide. So this is the map of Kenya, all right? It shows the hospitals, where our hospitals are located, the 25 accredited hospitals at the present moment. Next slide, please. And this is the map showing the density of the population in Kenya. So if you look at the dark brown areas, that is where the population density is high. If you look at the light brown areas, that is the areas where the population density is low. So when we were planning the training of surgeons for rural areas, we were looking at the population densities. And you will find that most of these hospitals are located in high density areas. Next slide. So we have the capacity to train enough surgeons in Kenya, and we at the present moment are requesting the Ministry of Health that the medical specialist training document that was prepared under the direction of the previous CS, Honorable Cicely Kariuki, be adopted and implemented so that we can achieve this task. We also are requesting that the surgeons are coming. They're being trained. So the hospital should be ready to provide the services. If the public sector hospitals are not ready, then these surgeons will end up in the private sector. So this is my plea at the present moment to the Ministry of Health. This action has been delayed and urgently needs to be implemented. And I believe this is a right forum to address this, and that's why I'm here speaking to you. With adequate number of surgeons trained and well-functioning hospitals, our GDP will improve. Next slide. OTPEC was registered in Kenya by like-minded doctors and friends, and we wish to work with the ministry, the board, the Surgical Society of Kenya to make this happen, because it is all of us who are going to benefit if we have good surgical services. To date, we have been involved in other areas as well, like raising funds for the COVID era problems. And we're at the present moment also involved in Volant, which is wide awake, local anesthesia, no tourniquet surgery, and introducing laparoscopy surgery at the 14 COSEXA hospitals, training institutions where laparoscopy is not available. Next slide. So our recommendations for the Ministry of Health at the present moment, which is sponsoring this meeting, is please implement the medical specialist training plans that we had as per the recommendations. Adopt the National Surgery, Obstetrics and Trauma Anesthesia Plan for Kenya. Next slide. This is our document that we handed over to the previous CS, Honorable Cicely Kariuki, in 2018 on how to go about training medical specialists in Kenya. Next slide. The recommendations there were, recommendation 2 says, increase the quantity and quality of medical specialist training. Dr. Ruth Duarte was a co-chair with me, and we produced this document. You saw her in the picture. The recommendation is increase the number of trainees, improve the training hospitals, and plan to improve the district hospitals. As I speak to you today, we have over 223 trainees training in Kenya as surgeons at the 25 accredited hospitals. Our plea to the ministry is to improve the training hospitals of the things they need for better training, and to improve the district hospitals where these trainees will be eventually going to work. Next slide. Recommendation 3 says, provide regular grant funding to sustain and strengthen COSEXA and other EXA colleges. I'm happy to report to you today that following the example of COSEXA, CANEXA, which is training anesthetists, EXA-COP, which is training physicians, and EXA-COG, which is training gynecologists, has started training anesthetists, physicians, and gynecologists from this year. So that training has also started. So there are more than 80% of the district level 4 hospitals across Kenya without a full-time surgeon. I'm repeating this. And an obs and gynae with more than 90% without an anesthetist. If we put our act together, we can get this human resource developed. COSEXA training is an effective method of scaling up specialist training, surgeon training, and I want to repeat this. People misunderstand this, that we are training a rural surgeon. We are not training a rural surgeon. We are training a surgeon after 5 years of full training, equal to, if not better, than any other surgical training models in Kenya. Next slide. This is our meeting regarding the NSOTA plan, National Surgery, Obstetrics, Trauma and Anesthesia Steering Committee meeting. It was funded by the Henry Family Foundation and the report is with the Ministry of Health. We have a national surgery plan for Kenya, and I think if we follow that and improve on that, we can go to the next level of improving surgery in this country. Just to give you some examples, when we started all this business about COSEXA and all that, the ratio in Kenya was 80-20. That means 20% of the surgeons served 80% of the population. Look at it the other way around. 80% of the surgeons were concentrated in big metropolitan areas, serving only 20% of the Kenyan population. Today, we have managed to change this ratio to 60-40. That means 40% of our surgeons are now working in rural areas, serving 60% of the population. Next slide, please. So this was the slide that we had in the National Surgery Plan, which said at the hospital with 100 to 200 beds, we would have 3 general surgeons, 2 OB-GYNs, all right, and 2 anesthesiologists present. They would refer the patients to 25 facilities, which would be between a district hospital and a provincial hospital. And this would be 200 to 300 beds roughly. And you would have general surgery, orthopedic, pediatric, plastic, and neurosurgery represented at that hospital. So 10 district hospitals would refer to 1 intermediate hospital, which we referred to as there. These would then refer to 12 provincial hospitals. We already had 8 big provincial hospitals. So the idea was to add 4 more, and they're all ready. And these would be about 300 beds and all that. And they would have the specialists, and then you would have 5 national referral hospitals, which would have super specialists doing transplant and such work. So this was the NSOTA plan, which was to be launched by the CS then, Honorable Cicely Kariuki, in Mombasa at the SSK meeting about 3 years ago. But because of logistics and other problems, it was not launched. We are pleading with the ministry that let's work on this and get this done. Next slide, please. So we have the medical specialist training document, which is with the Ministry of Health 2019. We are requesting for it to be adopted and implemented. We have the NSOTA task force document, again 2019. We're requesting it to be adopted and implemented. 2019 is when I was the president of COSEXA, and I stepped down in 2019 December. These were the documents which were prepared, and we are requesting that they be implemented. Next slide, please. Before I come to the acknowledgements, I wish to request, and I wish to quote the Aga Khan at Serena Hotel when he was addressing President Moi. And he said, if you pay peanuts, you will employ monkeys. That is a quote. Let me tell you, if you don't play our surgeons well, these surgeons put 24 years of their life in training. 24 years. Count your primary education, secondary education, higher education, medical training, specialist training, with 1 year of internship. It was 24 years of training. They start at the age of 6, so they start earning at the age of 30. They're already 10 years behind any graduate who starts earning the money. So we're requesting that these students be paid well, these surgeons be paid well. The total budget that I have worked out, if you pay 150,000 shillings to a doctor to train in surgery, that comes to 1.8 million shillings a year. If you want to train 600, in 5 years, it will be 9 million shillings. And if you want to train 600, it is 540 million shillings. 500 million shillings. If you take the budget of this workshop and what we've been doing here with Ministry of Health and Ministry of Education, maybe we've got halfway through that. I'm not sure. I don't know the budget, honestly. But this is what I'm saying. Now, acknowledgements. I wish to really sincerely acknowledge the team at the Ministry of Health, Honorable Cicely Kariuki, Mutahi Kagwe, Patrick Amoth, Jackson Kyoko, are the Ministry of Health team that helped work with me before and even now to make this happen. I also wish to thank our country coordinator Patrick Moy for COSEXA, the OTPEC council members, and I'd be failing in my duty if I failed to acknowledge my close friend, Stephen Ogendo, sitting here, who was my president in COSEXA, and then I became the president, and both of us have been working to achieve this. It is as close to his heart as it is to my heart. And also Dr. Nyaim. So with this acknowledgement, any other slides? Thank you very much. There's a closing slide, but that's fine. Thank you.
Sit down. Thank you. Yes, you have heard from him. I think he has made a very successful plea for training of surgeons. You have heard of that say, train a girl and you'll train a nation. And I think what he's saying here is train a surgeon and you'll train an efficient health delivery system. He has made a lot of a plea about access to surgical services in the rural area, and he has given us a way that we could be able to address that gap. And his recommendation is about collegiate training. But I would like to say that one of the areas that really hinders surgery is lack of anesthesiologists. And I think this is something that needs to be addressed as we talk about training of surgeons. There are lots of people there in the community who have got what I would call a requirement for day surgery. That is, they come in and they go off the same day. Are we trying to develop that as well as we try to reach the community? And you said there's a very efficient referral system in the country. Is that being utilized to improve access to surgery? So those are his points. Are there any comments that the public would like to raise? Yes, I'll take one or two. Is there any microscope? This guy calls it microscope. Microphone, yes. Maybe you could come forward if you have a question. Yes?
Thank you very much. But before I ask my question, I would ask if Dr. George Gaido happens to be in the audience. He was supposed to be presenting.
Please ask your question. That's another.
Is he around, Dr. George Gaido? Okay. My question, thank you, Professor Jani, for the good presentation. And having taught us, I've seen you have made a very...
Please make your remark. The thank yous, we have done it.
That's what I'm doing, sir. Please, I don't think you should harass me. I think that we have a right to contribute, because that is why we are gathered here. Sorry, Professor, but I have a right to express myself. Professor, you have made justification for the collegiate system of training. I wanted to know what you think about the future of MED with regard to the proposals you have made. Thank you.
All right, sorry if you felt I was harassing you, but it's the time which is harassing you. I'll just allow Yaim to make a comment before I move on to the next speaker.
Thank you, Professor. You heard my name being mentioned. I really would want to add on to what Dr. Odhiambo has said.
Could you get closer to the phone?
You know, I'm one of the shortest people, and this was adjusted for longer people. So, Professor Jani, please, you need to clarify a few things even as we talk about collegiates, which is offsite. Number one, what kind of center or institution qualifies to be a training institution, and who decides that? Are there checklists? Who goes and works with those checklists? Number two, in those institutions, who qualifies to be a trainer, and who certifies that they actually qualified trainers? And once you certify them, what is their obligation towards COSEXA, including how are they compensated, how are they disciplined? Why I'm asking this is because sometimes if we go to the point where we think every center can train and every surgeon can train, then we get mixed up. And it ties up with the issue, do we have minimum standards even for that collegiate training? Because we've said there we need to train people who can address our local needs, but we also need them to be internationally competitive. So we must define some minimum standards. Thank you.
Thank you. Sorry, I cannot take any further questions because of time. But Rajani, I'll give you 1 minute just to answer. Please.
The mic is not working, so I'll use this one.
All right.
Thank you very much. The first question, I believe, was what is the future of MED if COSEXA progresses and expands? Now, this question was answered very appropriately in Botswana, where, and in the world, if you go to the US, if you go to Botswana, the other places, when you train a surgeon, there are 3 areas of work that a surgeon is involved with: research, training, and clinical work. All right? So when the universities or the MEDs train their surgeons, their focus, like the Ivy League colleges in the US, is to train the surgeons to be a teacher, to be a researcher, and do some clinical work. There have been percentages allocated to this. So in Botswana, if you're on the university side, 80% of your work is research and training, and 20% is clinical work. Well, if you're on the collegiate side, it's the other way around. You train in research, you train in training, but your actual job involves more clinical work. So that should answer the first question. If he's not happy, he can we can sort this out later on. With regard to Dr. Naeem's question, yes, there are fixed guidelines for accreditation. The hospital has to have at least 2 surgeons post 5 years, post MED. So the trainers are people who have a calling, so to speak, to train. And at the present moment, there are checklists, there are criteria for trainers, and there are criteria to certify the trainers. And that is what happens. Now, the obligation towards COSEXA, if you build any brand, and if it has a name, then everybody wants to join it, all right? These trainers are not paid in cash. There are very few of us today who will work if we are not paid in cash, especially the younger generation. But it is the brand name that they want to go with, and they will go and stand up with their shoulders high, saying they're a COSEXA trainer. So there is no monetary remuneration, but there is payment in kind. Thank you.
Okay, thank you. Let's give him a round of applause, please. As you can see, he's devoted his life in the area of surgery, and we'd like to thank him for that. Our next speaker is George. Is George here? I want to talk to this young lady.
Thank you. Here. So before we continue to the next session, I'd like to please urge the speakers in the room to give us their presentations, because most of us haven't received most of you haven't given us your presentations, so we are having a hard time putting up the presentations.
So does George have his? Can you ask George whether he has given us his?
Dr. George Githu, please give us your presentations. And we can move to Professor Nguka Gordon before George gives us his presentation.
Gordon? You're welcome. This is your talk. Just a moment. Okay. Yes, sit down. It's my pleasure to welcome Professor Gordon. He's Professor of Clinical Nutrition at Masinde Muliro University. He's going to be talking to us about a model curriculum development process for integrating universal health coverage into the health professionals' training. He'll tell you a little bit more about himself as he launches us into this area. Professor Gordon, you're welcome.
Thank you very much, Chair, for allowing us to speak to the congregation. Hope my presentation is on. Okay, as has already been alluded to, I'm Professor Nguka Gordon, Professor of Clinical Nutrition and Dietetics from Masinde Muliro University of Science and Technology, Department of Nutritional Sciences. Some of us have vertical advantage like my friend at the other side, so I'll have to bend a bit. That's okay. I'm a member of council for the Kenya Nutrition and Dietitians Institute, which is under the Act, Cap 253B of the laws of Kenya. It's a regulator for nutritionists and dietitians, and chair of the accreditation committee of that board. So I will take you through the process of integrating universal health coverage into the existing curricula of health professions training, particularly with regard to processes and procedures. And as all of you are aware, I know a number of you are also trainers, the role of reviewing or even developing curriculum in the universities is a Senate role. And all other players on matters curriculum are stakeholders to the curriculum development and implementation. In Kenya, for example, it is the Senate of chartered universities that have that role, and KICD in Kenya, and KMTC. But regulators provide guidelines for developing curricula, core guidelines. All our regulators on this country have that guideline to all training institutions, both at diploma and even at degree level. So if anyone wants to come up with a section that is going to either to be integrated or streamlined into the existing curriculum, then the only route in this process is to come up with what we refer to as a model curricula, stipulating specific units and provide it as an advisory to the bodies that are mandated for curriculum review and development to be able to integrate. That would be the only way, especially if it's from the ministry side. So I will take you through. Oh, so you're okay. Yeah? I will take you through that process. Let's just move to the next. Past the layout. This review took me through the processes, the various existing curricula development models, and I concluded with a final model which I'll be recommending to the stakeholders and by extension Ministry of Health to use to help in coming up with a model curriculum that can cut across the health professionals that are in this country and across Africa, for that matter. Next. It's not working. So In Kenya, for example, we are already dealing with competency-based curriculum under the CBET, which is held at TVET. And as you are aware, the students who are under CBET will be coming into the university in 2029. All of us who are in training know that at the university level, we are now preparing for these students. And in that component, the training is surrounded or started from the competencies. You have to define the competencies. This has been talked to. And from the competencies, you now build back to the specific units that you want students to take. Next level. In terms of evolution of approaches of training in health professionals, I'd give you some basic background information as per Frank et al. 2010 that talked about 3 specific generations of reforms in the medical education and recommendation for training of health professionals, ranging from 1900 all the way to date past 2000. I can bring it down up to the year 2001. 2021 for that matter, when Kenya shifted from the previous curricula into competency-based curriculum. To today, if you can see that progression all the way from the instructional to scientific curriculum, which is university-based, to problem-based curriculum, which Moi University was known for. And as that we talk, we are on competency-driven local and global experience, which people talk about evidence-based curriculum development, basically helping for health education systems. Next. What is competency-based education and training? Competency-based education and training is an approach, just like any other approach, to preparing health professionals for practice that is fundamentally oriented to graduate outcome abilities, the psychomotor skills, and organized around competencies driven from analysis of societal and patient needs, which means it should not come from us, it should come from where the service is being given. It actually de-emphasized the issue of time, so that the student graduating should not be a matter of 6 years, 5 years. It should be a matter of the mastery of skills. And Frank et al. Saw this way back in 2010. Next. The competency-based education, as per Frank et al., is provided there. Our traditional approach that we have been using even in universities today is the first one, where you develop a curriculum around educational objectives and assessment. Today, in terms of competency-based curriculum, and I want to emphasize on this, the emphasis is on the psychomotor skills. And we are saying, even for the award and retention, for retention on the list of practitioners, which is, as that we talk, is pegged on the CPD points, should actually go beyond that, so that what I would be proposing is we have an assessment for fit to practice assessment after a given period of time. If somebody has been out of practice, for example, and wants to come back and practice even surgery or nutrition for that matter, what are the criteria of returning this fella back to the profession to be able to provide the service? The fit to practice assessment is necessary. And very many other parts of assessment that is emphasizing on the psychomotor skills. So the competency-based basically should be emphasizing or majorly oscillating around the health needs of the health systems, local-based and international-based as well, to be able to come up with the competencies, to be able to generate the curriculum. So you cannot just sit down and come up with the curriculum. And each of the competencies must have the assessments. Already, the Kenya National Examination is doing it well. Some of you may not know, but these people are already doing the assessment at class 3. and it is being uploaded. And this is going to contribute to their assessment at year 6. Very beautiful. And we expect that that is going to help in building the skills of these students and nurture them towards the processes. Can we move to the next? And click again to be able to bring us those. So, before, curriculum was driven by experts, and I want to tell you, experts should not be the source of curriculum. Experts should be informed by the needs of the people you're actually serving. So before, it is the experts who used to develop the curriculum and come up with specific competence that they feel themselves should come into the curriculum. Today, in competency-based curriculum, the experts is just a conduit to consolidate the needs of the service or the person to be serviced, in this case a patient or a client for that matter, and surround your skills around those needs. That is the process. So before you can see, click again, just click quickly, click several times so that you get it. Several times. Yes, another one. So if you can see, usually such kind of a decision, you end up with a poor curriculum that is not responding to the needs. And that has been our traditional. The competency-based curriculum is saying otherwise. Now, you have to get this information from the person you're providing the service to. It is the patient to advise, other than your skills, what are these issues that you have to deal with, that the surgeon has to deal with. I remember Yumbia was talking about communication skills here. That some doctors are not able to communicate with their patient properly, in other words, and then they end up disciplinary issues because things were not explained. Where could we have gotten this? From the people themselves, isn't it? And be able to put this into a curriculum. And that forms the competence base. Let's move. So we are moving away from expert-driven to a competence-based training that is needs-driven. The expert decide on the specific competencies before training, get the competencies, characterize the competencies, the interactive, the lectures, and all the things that you want the program to contain, and then click to the next level. The trainee exit by passing through the specific skills that have been defined, and then we talk about a very good curriculum with curriculum specific outcomes that are skills-based. Now, this has been fractured into one common model. The model that I'm talking about is called the ADI model. The competencies are successfully selected and considered as outcomes, and of course, the Commission for University Education now has moved from the objective-based training to competency-based concepts. And as we talk, we more focus on the outcomes of the training and not objectives. People in education understand the difference. I know in the health profession, we might be challenged on how to come with outcomes. But if you go to the community, you'll get those specific outcomes. What the patient wants becomes the outcomes. So the curriculum is organized around competencies, and that is what we are emphasizing on, or competency frameworks. The training content, the teaching methods, the learning and assessment strategies are designed around those specific competencies. And even the assessment is criterion referenced assessment based on the standards, not the other learners or norm referenced as it has been. The skills are the ones, and that is why we are saying from this point, then it is not about the number of years. It's about the mastery of the skills. So if you can master it in 2 years, allow that fella to move. If you are taking 10 years, please let that guy maintain until the skills are mastered before he moves. We should not be in a hurry to push somebody who's not able to come through the system. That is what competency-based is talking about. So that everybody is learning at his own time. Let's move to the next. I think I'm finalizing. Yeah, okay, thank you very much. Let's move to the model itself. Those as explained. The issue of the behavior modeling, which competency-based curriculum is emphasizing on. The social learning theory that says that when conditions are ideal, a person learns most rapidly and effectively from watching someone perform the skills that are required. And the mentor supports the learner to be able to practice the skills. I know this has been so often in the medical field, and it has helped, but we would want this intensified. Let's move. The adult learning principles is key for us, even in competence-based, where opportunities of practicing skills initially in a controlled simulated situations. I think we have talked about the skills, and right now for nutrition we go have community labs, and then the issue of repetition and realistic methods of ensuring that somebody masters the skills. Let's move to the next. So to be able to develop a curriculum, we say you must get the needs assessment first. That's the ADI model. And after assessing the needs, you design the curriculum based on the competencies, then develop the curriculum. Let's move to the last bit. Just move to the ADI model itself. Yeah. So this is what I'm proposing for the Ministry of Health. If you have to integrate and streamline the universal health coverage into the existing health profession curriculum, then the process is what I've said. Analyze, design, develop, implement, centralize under each component of evaluation. This has been proposed by Frank et al. And last, go to recommendation. Okay. The framework, I've already explained the framework of the curriculum development. Let's move. In conclusion, to be able to effectively do this, we say explore the ADI model and you'll get the curriculum done. Lastly, thank you very much. There are existing models that we have. We have done curriculum models for East African community under EXA, if you get it, for the nutrition that is now providing specific units for all health professionals. You can take that and put it if you want to streamline nutrition. So we propose the same model to be used for the universal health coverage. Thank you very much.
All right, Professor Gordon has managed to save some time, so I'm going to allow one or two questions to him. But I would like to say this. As regulators, we have been going through the East African region inspecting the medical schools. And one of the areas that we look into is the curriculum. And when we look at the curriculum, we are looking at the design of the curriculum, what the content is, what the instructional methods are, what are the training staff who are there, who are the students, what are the materials for teaching, and the system for evaluation. And what is coming through in most of those universities is that they're using the competency-based training. And what Gordon has walked us through is what this competency-based training is all about. Of course, the starting point is what are the competencies that you want to see in these doctors? And that is what I was making in my presentation yesterday when I talked about the doctor that we want for now and for the future. And I think he has been able to achieve that and walking us through it. I'm going to allow a few questions or a few remarks addressed to him. But if you look at what he has presented as the model, we are actually talking about the PDCA cycle of quality improvement, that if you apply that into this system, you are going to get the product that you require. Thank you. Any remarks? I'm not going to harass anybody this time. But time will harass you. Yes. Go to the microphone, please. Yep.
Thank you, Professor Gordon, for that very well-put presentation. I want to ask a simple question because as we develop curricula in the usual way from academia, we actually consult the stakeholders. In the new model you're proposing, that the expert does not propose the curriculum is proposed from the environment. What strategies can we put in place to be able to get info from the expert, even as we develop or think about this, because we, quote unquote, seem to have the knowledge on what our environment should be best been. So just I'd highlight for us the exact model we should use to be able to get the stakeholder to give us this information. Thank you.
I suppose one of the stakeholders you're talking about here are members of the community. Any? Yes? This side, all right. Can we get one from this side and one from that side? Please. Oh, there's one there.
Thank you very much, Prof. My name is Dr. David Okeo, the CEO for the Nutritionist Council. I want to say that the competency-based model curriculum that Professor has presented is key. The only thing I would want us to think about is that health is a component that requires cross-cadre approach. Integrating a model curriculum should therefore look at the common communication between health cadres. So we need to think of cross-cadre integration of a model skills or competencies, and we also need to think about the inter-country model integration. So these two approaches need to come out in the competency, particularly for health professionals. So this is a thought that probably Professor can tell us the best way to do cross-country and also cross-cadre competencies. Yes.
All right, I'll get one from the other end. Yes. As you prepare to answer your questions, you raise a very important point about the duration of training. He says, if you can train the guy in 2 years, why keep him for 5 years? I think that's a challenge. Here we are talking about self-directed learning, and if somebody can get his time through, I think that's something that we need to digest and its implications. Yes?
Thank you very much, Chair. I would like to ask a short question to Professor Gordon. He gave us a list of what needs to be done in order to get the competence-based curriculum, needs assessment, design, etc. Can he add a column on the right side showing two things? First of all, who would do the needs assessment? Who would design, etc., and the time taken before it goes to the Senate. He mentioned something like senatorial, because we would like this for pre-service training, for medical course certification, and ICD coding. Lastly, Professor Gordon, can I meet you during lunch break or tea break? My name is Hamed.
Thank you, thank you. Yes. Time. I'm sorry, time will not allow us to take more questions, but you seem to have set your eye on one. Eh?
He's my seed, yeah.
Okay.
Thank you, Professor. In the interest of even gender, I appreciate. I am really interested in this issue of curriculum development with participation of the stakeholders driving the process. and vis-a-vis the complex technical health subjects. Because at the end of the day, I would like you to comment on how to exactly get the stakeholders from communities to determine their need. Because finally what that might do is dilute the professionals to only practice at a level that is determined by your local scenario and reduce the competitiveness, so to speak, because that might be shared by only one or two stakeholders and may not become a part of the key component to be taught. I would like your comment on that. Thank you.
Okay, thank you. Thank you very much. I think I would like to acknowledge to the team that I have my Vice Chancellor here from Masinde Muliro University of Science and Technology. Professor Solomon Shibairo is here. And I also have my DVC here, Deputy Vice Chancellor in charge of academics, Professor Golicha. And then I have my colleague, Dean of School of Medicine here, Dr. Kokonya, who wanted to ask a question, but I saw him. So we have a team here from Masinde Muliro. Let me answer the questions. Yeah, very quickly. I will combine the last question with the first one. They are the same. The model to get information. First and foremost, I've said very clearly that it is the professionals, it is the experts that develop the competencies. So within the competency curriculum, it is the experts that generate the specific competencies. Once you generate the specific competencies, you use it to get the needs assessment. So the competencies around which you are going to develop the curriculum is determined from the society. That's where the needs assessment. Who does the needs assessment? The expert does the needs assessment in participation with the community and come up with the specific competencies that are required to service the needs. For example, after several surgeries, Prof, you have realized that a specific disease is not common here in Kenya, but it's common elsewhere. You will have to tune your curriculum to be able to fit the needs of the specific conditions that you are dealing with majorly in Kenya, as you have defined, isn't it? It is based on touch with the community and the conditions that you receive more. That is what we are saying, rather than coming up with issues. For example, let me give you an example in nutrition. We have BMI. Some of us, as experts in nutrition, we have serious issues with the standards that were provided, for example, by WHO, which says, 18.5, 19. We have serious issues. We are saying that is not us. Can we come up with ours? Are you seeing? So that's what we are saying, competency-based. It is based, local-based, driven, so that when you are generating a curriculum, I'm not supposed to say that the ketogenic diet is a standard diet for everyone, as long as you are diabetic. No. It will be very vary. That's what we are talking about, competency-based curriculum. That's what I'm advising. Lastly, I think I've talked about the two questions, cross-cadre, cross-country CBED. I happen to have done cross-cadre, cross-country. And I've advised, I think I've told you, I've done a curriculum for the nutrition, cross-cadre training. If you go to EXA, you'll see it on the website, that has defined the specific content that a doctor can fit into their curriculum, although the curriculum is too large. It's about, I'm just wondering how Commission for University Education will have to deal with it. But we have defined those specific skills which they need as per the cross-cadre. We have also done it cross-country because we did it for Tanzania, Uganda, and Kenya. So usually you expand the stakeholder needs. Lastly, who does the ADI? I've already said it. The ADI is done by experts to be able to collect the information. Thank you very much.
Thank you. Could you give him a round of applause, please? One thing that somebody asked is that one of the skills that we are not talking about is psychosocial skills, psychomotor skills. One of the areas that people are not talking about is psychomotor skills. That's one. Yes, that's something that we need to do. Is Kelly in the house? Kelly? If Kelly is not in the house, hey, don't go away. I'm detaining you because you have got another presentation. Okay, is the other presentation of Professor around? That is, which one is this? 25. You are presenting number 25. You are ready for it? Hello, session 21 and 25 is virtual. All right. Okay. So Georgia, are you ready with
Hello. Yes, I am.
Okay, you can go ahead and make your presentation, please. It looks like you have got two presentations. Which one are you giving us first?
I have only one presentation.
Which one is this? Okay, give him the one that is giving us.
African reimagined opportunities to advance cutting-edge research.
All right. Can we have that?
Are we together? Yes. So my name is George Njoroge, and I'll be presenting on this African reimagined. And an introduction, I'm a research drug hunter, having been out of the country for the last 40 years and working on various type of diseases. But today I'm going to talk more on how Africa can advance in terms of drug production and expanding research. Before I do that, I'll just give you a brief story of boceprevir, which is a drug that I discovered in the United States for treatment of hepatitis C. This is a drug that was filed and accepted by FDA, that's the U.S. Food and Drug Administration Agency. It was accepted by the year 2010 and sent for priority review, which takes about 6 months. And fortunately, the FDA Advisory Committee, which is composed of various experts from various universities, and 18-0 for approval. And from that, the FDA approved it as a drug for treatment, for the first treatment of protease inhibitor for hepatitis C on May 13, 2011. Thereafter, European Commission approved the same drug on July 18, 2011. And the name of the drug is Victryris. Original name, the chemical name was boceprevir, and you can see the label out there. In 2012, the sales of boceprevir, or Victryris, was about 20.1 billion Kenyan shillings. I'm giving this because I'm going to relate it to what we need to do in Africa and the emerging markets. This drug, boceprevir, also very recently has been found to be very active in COVID-19 as a COVID protease inhibitor. And actually, a group from Pfizer has developed it, developed part of that molecule in Paxlovid, a drug that has sold close to $17 billion. You can see the structure there of this drug. The scientists have even taken the drug and put it on the protein and it binds very, very well to the COVID-19 main protease cleavage. So it's a very, very important drug, and people are looking into it in terms of advancement in inhibition of various proteases. Now, this is the team that worked with me in the discovery of the virus. It's a cross-sectional group, an international team from America, from Europe, and a lot of people from Asia. You can see we don't have many Africans, but things are getting much better. And from the discovery of that drug of the virus, the American Chemical Society awarded Fellows of Chemistry for that invention in 2012 in a meeting that was held in Philadelphia. And from the work that we did through the journey of discovering the virus, we had remarkable developments. We got about 300 publications, peer-reviewed publications, and over 100 patents during that journey. So this is to excite people here in Africa as we move on to share with the rest of the world what we can discover in our continent. Now let's come closer to home, and I start with a statement that was made by President Kagame of Rwanda in advice to Africa, where I quote, "Application of science and technology is fundamental and indeed indispensable to the social and economic transformation of our African countries. We in Africa," and this is very important, "we in Africa must either begin to build our scientific and technological training capabilities or remain an impoverished appendage to the global economy. There is no reason to believe that Africa cannot achieve what others have achieved in these fields." And this is very, very important. It was also echoed by Bill Gates at Columbia University. He said all the technologies we have in biology, chemistry, and all the talents we have in Africa could be used to fight against major diseases like obesity, cancer, depression, and the like. And the upcoming of things like DNA vaccines, like we saw during the COVID-19, are very, very important. So at this point, I'm showing a very, very important slide in my drug discovery journey, because the whole of the world now is turning to personalized medicines. In cancer, we are now moving to looking at the genes that are causing cancer. And as you can see, I would like you to go with me, because when we have a community, a patient community, I hope you can see my cursor, we usually have a patient community there in the middle, which is genetic makeups. And when we provide a drug to a community, like when we give a chemo for cancer patients, there are those, the group on the left-hand side, the drug could be toxic and beneficial. But on the right-hand side, you can have a group where the drug is toxic, but not beneficial, but they are still taking the drug, the chemo. On the bottom left hand, the drug could not be toxic, it could be innocuous, but not beneficial, but you're still giving those patients. But the most, the one on the right-hand side, the bottom right-hand side, where the drug is not toxic, but beneficial. And today, most of the research in the Western world especially is going after what we are calling personalized medicine, which is patient-tailored and at the genetic makeups for the various populations before we give them the drug and before we even design molecules that could be future drugs. That's what they've done with breast cancer, where they have to look for HER2 positive overexpression and provide a drug that is appropriate for that indication. Now, what I'm going to do is show you where we are now in our drug hunting strategy. Things that have been done in the Western world and Asia, but things that we should now start thinking about bringing over here to our country. What extensively this area of what we call magic bullet treatment of cancer. Now, the magic to alleviate that, we have things called antibodies, which are very specific to certain targets in the body. And if you can take one of those very toxic molecules and put it on the antibody, specific target of interest, not going all over the body or to the unwanted targets. And when it is there, we have the chemistry that will allow you now to release the drug specifically on that target. For example, you can see to the right, we have the drug for breast cancer, Herceptin, which is used very often. And you can see we can, okay, sorry, internet here is dropping. The drug for breast cancer has now been put on an antibody. And through this putting on antibody, it is specifically to the specific area of the breast. And this drug, Kadcyla, was approved not too long ago, and it was working miracles. This is a technology that will improve drugs, in having drugs that are less toxic, and also more effective drugs. Other area is the gene editing frontier, which everybody now is getting into in the research area. This is where most of the diseases we all know, they come from DNAs that are defective, and they produce proteins that causes all these diseases. Now, just like you do with your Word document, you can cut and paste. Technology called CRISPR-Cas9 has come into being, whereby now you can look at the DNA and figure out where is the defective part of the DNA. And using the CRISPR-Cas9, you can cut that defective part of DNA and put the right piece in that DNA, as you can see in this picture. This is a very powerful instrument that is being used now in medicine, and people have embraced it, and it's the future of taking care of most of the diseases. Now, the last one, there are several of them I can talk about, but a message is sent to the brain, whereby it is sent to the brain, they send the T cells, which are the soldiers of our body. They protect our body. They come and fight if it's a virus, bacteria, or even cancer. They come and fight them and kill them using the T cells. You've seen that now, that's why we take vaccines and stuff like that. But you know, a lot of these agents, the microbes, the viruses, they've learned how the body system works, and they have turned off the signal that they sends the message that the T cells or the soldiers of the body should be sent. And when they turn off, if the viruses or the bacteria infect you, then they can continue proliferating without being killed by the T cells. Now, science has learned how these agents, how these bacteria, viruses, and cancer are doing that, and they are now blocking the system they use to deactivate or to stop the activation of the immune system. This has become very important, especially in cancer, what we are calling immuno-oncology. And the new drugs that are coming are very, very interesting. For example, we have Keytruda, which is a drug that came from my former employer, Mark Sharp and Dome. Keytruda is a very good drug for activating the cancer cells. And we know it is the drug that it's in the public domain that was used to treat Jimmy Carter of his melanoma. And it works, although it doesn't work to everybody. There's still a lot of research being done why it doesn't work for everybody. But it's very, very interesting because now, instead of just giving chemo, especially in terms of drug delivery. This is just took a list of a few drugs that sold very well, especially in the year 2012. You can see the best-selling drug was Humira for rheumatoid arthritis that comes from AbbVie. In that year, 2012, it sold about 14 billion US dollars. That's about 1.4 trillion Kenyan shillings. Then other one is Avoni for hepatitis, sold very similar amount, and Crestor for lowering cholesterol from AstraZeneca that was sold $5.07 billion. Now, if you look at the numbers, these numbers, the most exciting thing, and this is data, I haven't updated it from 2012, you can see the potential of having research in our country. For example, in that year, 2016, education, the government spent about 339 billion in education. Health was about 60.3 billion, and defense was 265. So in this country, we discovered a molecule like Humira that will bring out something like 1.4 trillion. You would be able to service many of these ministries of education, health, and defense. And this is a call that we have talented people, and they should come out and get into this game of technology, development of technology, because knowledge these days, knowledge is gold. We know here in Africa, especially in Kenya, know what our major disease is. Of course, you can see from that, and this is a report that came from the PS several years ago, and it still remains. Malaria is our big concern, pneumonia and cancer. And we really need to come up with various ways to combat these diseases through research and utilizing the modern technology that is available to us. Finish to my 40 years in the US, I'm now back into the country, and we have started the Center of Africa's Research, Center of Africa's Life Sciences in Naivasha, and it's attracting various scientists from all over the world. I've worked with more than 200 PhDs in drug discovery. They are very interested to come to Africa for what we consider to be scientific tourism. And we're going to cover most of these things: discovery of drugs, manufacturing and development of things like vaccines, and as well as having communication. That means information dissemination in having good hotels and convention centers where we can deliberate on issues of science. So this will, the institute in Naivasha will cover all the 4 pillars that the Kenyan government is talking about: hospitality, manufacturing, housing, and drug discovery. And we hope by doing that, we could generate jobs for our people, and even improve the state of the science in the country. And you can see from here, the numbers of 500 are jobs for our country. My recommendation is for us, we have a lot of talents to embrace technology, to have the government support research and access of foreigners, of people coming from home. Most of you will join these new ventures. Asante.
Okay, George, you're welcome back home after 40 years being away from the country. And as your life slide shows, you are standing tall in the area of research. What George has walked us through are the various opportunities that we have for research. Centers of excellence is definitely going to be research. Research in the cancers, research in a common condition in this country, in this area of the world, change in the lives of the people in this country. So George, thank you very much indeed, helping us in various areas of research in this region. Round of applause, please, as we... Can we then give a round of applause to our next speaker, Walter? Walter, are you in the room? I'm going to give you enough time. I'll not harass you this time. Walter is going to talk about training in the dental field. Yeah. So, Walter, are you around? Beautiful, come. Walter is going to be talking about 48 years of training dentists in Kenya. I think this is an important topic. I do not know what the population of dentists in this country is, and there are different levels of health workers in dentistry. So I think he's going to give us his experience or the experience in training in the area of dentistry in this country. Walter, you're welcome. You have 20 minutes. 5 for questions.
Thank you very much, Chair, Professor, and ladies and gentlemen, good afternoon. It is my honor and privilege to be here. I'm the current Dean of the School of Dental Sciences of the University of Nairobi, which was the first dental school in this country, and graduated the first lot in 1978. And now we are looking at what has happened for the last 48 years since the first batch joined the dental school. For those who may not know, in Kenya there are now, right as I talk, there are 2 dental schools. One in the University of Nairobi, which is the pioneer, and another one in Moi University. So this presentation is actually provoked by the fact that we are going to look at the workforce in health, and specifically I'm just going to highlight what is the current status of the workforce of people who provide dental health in this country. Please, may I have the slide? That one is already there. Let's go to the next one, please. Yeah, so as an outline, I'll just briefly take you through the state of oral health in Kenya, just what is the situation based on a research that was done in 2015, the first national oral health survey that was undertaken in Kenya, and I'm glad that most of the people who did that study were from the University of Nairobi School of Dental Sciences. As a matter of introduction, I would just like to show you the situation of the burden of oral health disease as reported by the CDC in the US, where they have done some studies. We are yet to do similar studies in our setting. Please, next. Yeah, so you can see that CDC did a study and which indicates that among the non-communicable diseases in the world, dental disease ranks quite high, and found that 40% of adults felt pain in their mouth within just the previous year or when they did the study. They also found that 80% have at least had a cavity by the age of 34. By the age they are 34, they had already experienced a cavity in their teeth. And this is something that most of you probably have also experienced, and you will see it in your children. As in terms of the burden, you can see from the slide that again the CDC found that the US spent about $124 billion yearly on dental health, and 34 million school hours is lost by children not going to school, and also when you count the number of adults not going to school, either because they are going to see a dentist or because they have been kept away because they are not feeling well. So next slide, please. So how about in our situation for the studies that we have done? the recent study, which was led by Professor Lois Gadeshe from the School of Dental Sciences and her team, found that among children that they surveyed, 54% had experienced a toothache or discomfort the previous year, and 47% of people they surveyed had never visited a dentist. One fact which is also worrisome in our setting and which is psychologically disturbing our children, especially in adolescents, that almost some of them are psychologically affected, and those of you who live in Muranga or Naivasha or the areas around Karen Langata, is fluorosis, the dental fluorosis, where in this survey they found that 42% of the children had dental fluorosis. And you can see that almost 100% of the people they surveyed the previous year, the year before they did the survey, that is in 2014, nearly everybody had a dental-related problem. So really, the issue of dental disease is not in doubt as one of the key factors that therefore would demand address in universal health coverage. Next. Now, despite the fact that, as I've said, that this is obvious, and I'm sure you in audience will agree with me, that what I've displayed would require that dentistry be addressed in universal health coverage. Kenya has about one dentist to 42,000 people as at that time, against the WHO recommendation of 1 to 7,000. Now, the two dentist training schools in Kenya, interestingly, have, and as I'll show you in the next slide, have only been able to graduate slightly more than 1,000 dentists in over 50 years, which is 5 decades, and they have trained only a total of 1,000 dentists. The other training institutions for oral health that have been supporting, especially in level 4 and 3 hospitals, it's the community oral health officers that has also trained almost about 1,500 since they were initiated in the 80s. By the directive by President Moi. We also have dental technologists whose role is largely normally mixed up by the community, that they do not know. Dental technologists usually do not offer actual clinical dentistry, but are actually involved in production of the prosthesis like the artificial teeth and so on and so forth that we use when people have lost their teeth. So that is where the technologies come in. Next slide, please. Yes, you can see this. I don't know. I hope you are able to see the figures of this projection, or if they are not too small. From 1978 to 2020, that has been the number of dentists graduated. The first decade, which I've put at 78 to 88, they graduated a total, that is a decade, in 10 years, they graduated 184. In the second decade, they graduated 186. The third decade, which is 20,000 to 2010, they graduated 207. And in 2011 to 2020, 285. This brings to a total of 922 dentists graduated in 50 years. The only good news in this is just that the girl child has been coming up, as you can see on that column, and finally they overtook the boy child in terms of the numbers graduated. That probably is the only positive thing in that projection. Next slide. So what I look at is that is the number of personnel in oral health care that have been trained in Kenya since the first batch in 1978. Next slide, please. And you can see one of the reasons why this is the case is that training of dentists is quite dear in terms of cost. And you can see this is one of the new dental units that we just installed at the University of Nairobi Dental School, thanks to the support of our alumni and staff members who contributed to this. And it cost about 2 million to get this set up into our system. So unfortunately, the dental school was initially supported by a grant from the German government in 1974. And up till to date, the units that were donated by the German government in this grant remains the main training facility at the institution. So the first batch graduated were 23, and where they trained to date remains nearly with the same structures. Very little improvement has been done. Next. Now, the other challenge, apart from the cost, is definitely competing interests in terms of health. I'm sure that as we gather here, we know, for example, the last 2 years since the COVID devastation, the cost of everything went very high, and COVID became a priority. We had to use every money to get the sanitizers, to get gloves. Gloves, for example, cost went up by 5 times. A pair of gloves, which was 300 shillings, was now costing 2,000 shillings. And that became totally unachievable. And we, of course, have to prioritize diseases like malaria, we have prioritized TB, we have prioritized HIV/AIDS, and, of course, trauma. So these have to compete with dentistry in interest. And you know, dentistry has been somehow traditionally looked at some element, it is cosmetics. And that is also another problem where things like insurance coverage, even by NHIF, has neglected this area. And despite the fact that it is known that the cost and the debilitating effect of dental health is obvious among us, especially the modern generation, it remains largely a disease that is borderline cosmetics. And that has really devastated in terms of resources. And so the paucity of training facilities, as of now, you know that private universities that have come into Kenya started medical schools, they have started schools of pharmacy, but to date we have no school of dentistry. That is simply because of the initial cost of setting up a dental school. Next, please. So, I think with regard to oral health or dentistry, if we maintain the pace that we have today of 1,000 dentists trained in 50 years, if we are to hope to achieve the WHO ratio of 1 dentist to 7,000 in our population of 47.6 million, this is as per the 2019 Kenya population census, then you know we are chasing a mirage. Because in the next 10 years, maybe if we train another 2,000, and we must accept that within 50 years we have lost another number to attrition, retirement, deaths, and all that, and even relocation to other areas, you can see that it is impossible to achieve the 7,000, 1 dentist in 7,000 objective. So 1,000 dentists trained in 50 years in 2 universities, 2,000 in another 50 years, when our population will be, that should be 20, if you add 50 to the current one, you can see where we will be. So really, we need to change the math. In other words, we need to get out of the WHO saying that we need to achieve 1 in 7,000 because we will never achieve, or we change the strategy. We need to change the math or change the strategy. Next. Can you project the next slide, please? And some of the thinking of the strategy is something we saw during the pandemic. Suddenly, COVID pandemic came up with some lessons that are positive because COVID-19 taught us that actually we can use technology to achieve training for more dentists than we thought before. So that instead of looking for lecture halls within the training facilities, we can use the modern technology. And this is the challenge that we must put between ourselves, the scientists who are here and the health workers who are here. The world is now moving to artificial intelligence. How much can we learn from this? Things like simulation in terms of not necessarily having the physical patient to teach with, not necessarily having to bring students to anatomy lab to dissect live cadavers. That is costly and not easy because of the congestion. So what do we do? Can we learn from these pandemics? And then again, we are forced to think beyond today because we have seen what COVID did to us. COVID came and found us very ill prepared. And even though I've had a lot of presentations here really talking about getting to the needs of the people, I think academicians like me must still think ahead. We must still not just think about what is the need today, because that is, as you emphasize that, let us go and find from the community what they are having. But there must be some of us who must, thank you, I'm about to finish. There must be some of us who then must think ahead so that we are not caught flat-footed as we were caught by COVID-19. So this is the time we were thinking, oh, we have e-learning and so on. Next slide, please. I just want to quickly throw you through. So I just wanted to share with you an example of what the Division of Biomaterials of the Dental School did with the Bachelor of Dental Surgery year 2 when they tested the e-learning more than from the year 2015 before COVID came. And this is what I call, we were thinking ahead. And this unit is now taught totally by e-learning module. Next. The students were then asked what they thought about in this just evaluation of our e-learning module as a pilot study before COVID. This was 2015. And you can see one of the things that the students liked the e-learning most about was that we don't need to travel to classes. We can do it wherever we are, even on our phone, wherever we are. We don't have to go and sit in class. And the ease of access. And this now is a lecture we are giving totally through e-learning module at the dental school. Next. And the performance of students using this model is comparable, even though it had not been refined. But if you look at the performance of e-learning and the pre-e-learning in this subject, we found that the performance was the same. And there were more credits and less failures when we used the e-learning than the previous pre-e-learning era. Next. That is the graph, and you can see, the colors are not very good for you, but you can see that the e-learning and the pre-e-learning are almost at the same level. So we feel that this is an area to go, and it does not make the students' performance poorer than if we use the pre-e-learning. Next, please. Conclusions, then. Dentist populations remains low in this country, no doubt about it. At the current rate of training, universal health care in oral health is unachievable. The main hindrance of training is lack of expansion of training facilities, which is largely due to cost and high demand for skilled supervisors. Actually, the dental school has about, despite those numbers you are seeing, which is very low, the dental school at the University of Nairobi has 40 academic staff members. And that is really costly, probably why nobody in private wants to go to that level. And then prioritization of other health needs and policy that regards some aspect of dental health as cosmetics. These are some of the areas. Next, finally. And recommendations, I would simply say that we put more on asynchronous to reduce the need for physical infrastructure, sharing of the few specialists between institutions. With the new technology, there is nothing which stops me from giving a lecture to University of Nairobi Dental School and still giving to Maseno University. If they don't need that specialist, there is no reason why they should not start a dental school because we are few. The technology now allows it. And then I recommend that we integrate management of training and care to reduce the cost. There is no reason why dental school should only be an academic center. Let it offer clinical services. And Kenyatta needs not to have separated institution of Kenyatta, which is Kenyatta Referral Hospital, separate from University of Nairobi, where you find University of Nairobi has 6 neurosurgeons, Kenyatta has 6 neurosurgeons, and JTRH has none. The Kenyatta has 5 maxillofacial surgeons, University of Nairobi has 6 maxillofacial surgeons, making a total of 11 at Kenyatta and University of Nairobi, and yet Jomo Kenyatta, as Anyang' Nyong'o said here, Jaramogi Oginga Odinga has none. So if we can integrate, and this is a matter of policy, I know it is very emotional, but we must agree that the university academic staff should offer clinical services, and where referral hospitals require services, it would reduce the need for personnel. And then we can think of accredited satellite institutions where students don't have to come to Nairobi or to the urban centers. As justification has been given, they can go to the accredited facilities for their clinical rotation. So next slide, I think that is my last slide. Thank you very much. I can just say that universal health coverage has been said there, but what question we must ask? Does universal health coverage mean poor medicine for poor people? It should not be that way. And is cheap medicine for poor people? And affordable doesn't have to be cheap. I think that is really what we have to go to. That we are talking about affordable, but it doesn't have to be necessarily cheap. Thank you very much, and asanteni sana, ladies and gentlemen, for your attention, and thank you, Chair.
Give you time. Sit this way. Yeah, thank you, Walter. Listening to what Walter has been saying, this is a common feature in almost all African countries. If I were to ask my Nigerian friends to give their remarks, they'd give you a similar story. If I was to ask Rwanda, it would be the same. So the kind of thing that you're seeing here is common. And I'm saying this because as regulators who have gone through the East African region and seen the dental schools, we are really worried about numbers. Because, for example, in Uganda, I think we have got 2 dental schools. In Rwanda, there's 1. Here you have got 2, which hasn't expanded, and similar figures we are getting. And if I may ask, what is the average output per year of dentists in this country?
Output?
Yes. How many do you train in a year?
We graduate about 30.
30. Can you imagine? That means about 15 from each of the dental schools. Are we serious when you are talking about universal health coverage? I think there's something that needs to be done. You have talked about changing numbers or changing strategies. I think we are not going to change the numbers. I think the WHO recommendations should remain, but we must change the strategy. And if you talk about the burden of dental problems in this country, what the politicians and economists understand is, can you put this into dollars? What does it mean? What is it costing the country if somebody has got a dental problem, is away from work, is attending treatment and so on? That is the language that they understand. So I think one area of research that you're going to have to do is to tease out the economic burden of dental disease in this country. And I think that study will help lots of other countries to understand the burden of dentistry in this country. Again, the thing that we are talking about in this region is the issue of mutual recognition and reciprocal recognition. And I think when you are talking about your curriculum, please take this into account, because we are already beginning to see that there are certain cadres of dentists in, say for example, in Uganda, whom we are finding it difficult to register them here in Kenya. what is the problem, what do we need to fix, so that there is free movement of persons between the different states in the country, in the region. You talked about e-learning. I think this is something that we must all embrace in this area so that we can quickly increase the number of dentists in this country. But a major stumbling block is always going to be, who are the trainers? If we are not giving support to train in specialist fields in dentistry, we are not going to be able to get the numbers that we are talking about. So thank you very much, Walter. And I think your presentation is well received, and I think we should give him a round of applause. Thank you very much indeed. What is my next speaker? Who is my next speaker? Hold on. Let's just. My next speaker. Please bear with us. I think we'll listen her out. So I have here with me Professor Regina. She's going to continue with us in the area of dental training. I'm going to ask her to introduce herself and the topic. Thank you.
Yeah, thank you very much, and good afternoon. My name is Dr. Regina Mutave. I know it's got a few issues on the way it has been spelled there, but I'm actually going to take very short because I know you are watching at lunch, and basically following closely with Dr. Walter Odhiambo. He has done most of the background, so I'm actually going to cover very quickly. If I have the presentation. So knowing that we really have lots of issues in training adequate dentists, and we also know that we also have a lot of issues in the way they are distributed in the country, that even the ones we train, you find most of them, 80%, are actually within the larger urban settings, leaving the larger rural population underserved. Yes, there has been discussions, and my topic looks at dental training for non-oral health professionals, because as Dr. Walter rightfully said, even if we were to continue training at the rate at which we are training, we probably may not make it in the next 100 years. We may not be here to witness what will have happened, and a lot of people will have suffered pain and discomfort and poor quality of life because of dental issues. So I'm going to take you quickly through this presentation, looking at the background, and I'll look at the methodology we use for this, and the discussion, and basically look at a quick conclusion and some recommendations. If we look at the burden of oral diseases, major organizations have been estimating about half the world population, about half of the world population has a dental issue at any one time in their life. And in Africa, that translates to about 480 million persons. In Kenya here, we did, I was in a team that did the first National Oral Health Survey. The heaviest burden of tooth decay was among children that were aged 5 years. About half of them experienced tooth decay. Now you begin to ask yourself, where do they get tooth decay that early? They have even just entering school systems. And so that gets us really thinking. How do we intervene? Where do we intervene? The children in Kenya, we have robust programs, the maternal child health program. And every child is probably religiously taken there by their parents and to get some education, to get their immunization. Why do we miss that opportunity? Yes, we also have having a problem that in Kenya we have water scarcity. And I know there's a catchphrase in the upcoming developments that there's borehole on site. That, every time I see, is like a bad pronouncement for the growing up children, because most of our underground water contains higher than normal amounts of fluoride. And that's why in the National Oral Health Survey, about 40% of the children experience dental fluorosis, while in the adult population, it was about 20%. So it does point to a worsening problem that we need to correct. Next. The goodness with dental problems is that most of them are preventable. We can easily be able to prevent dental caries because we know it is caused by a combination of not taking care of the good hygiene and basically a high sugar consumption. Do mothers know that a child doesn't need to learn how to eat sweet things before the age of 3 years? Who teaches them that there's a difference between sugar-free milk and sugared milk? And it is possible to do very simple interventions and be able to prevent dental diseases. And also the other thing that we need to know is that some of the medical conditions can be worsened by your dental issue. If you have diabetes, we know there's a direct relationship between your sugar control and how well your gingival health is doing. The same thing for pneumonia and a few cardiovascular diseases. And we know there are studies that were able to identify oral thrush during the era of HIV/AIDS. Next. And why should then the population suffer from that which is easily preventable? So all of us look at a young child and want them to progress and be in very good health, and which is forms the basic reason why during the 74th World Health Assembly there was now a statement on oral health in 2021, and some of the extracts from that statement include the awareness of the major contribution of health condition and the association of dental health and general health, and so forth and so forth. That statement is available. We can download and read it. Next. So basically, next slide, please. So every time we are looking at a child born, we want them to end up in the good health corner, not the middle image. The top image obviously is dental fluorosis. The bottom image in the middle is dental caries in a 5 or 6 year old. That's not the situation we want. We're always looking forward to having a healthy person. Next. And so, given the numbers that Dr. Walter Odhiambo has shared, we are not likely to achieve that state soon. Next. I was looking at the ratios in World Health statistics, and we at least have some sizable numbers of medical officers, sizable numbers of nursing staff. We have a lot of community health workers who are available, and we cannot be able to train in our limited space within the dental school. Why not expand and utilize this as a personnel? several studies have actually demonstrated a benefit of ensuring everybody coming out of our healthcare training facilities has been empowered to put in promotion, screening, and be able to recognize dental disease, refer the very serious dental disease, be able to work with communities to minimize numbers that are getting new disease. Next. And what I'm sharing today is the fact that we at the dental school in 2012 managed to have in the curriculum for MBCHB containing some training for dentistry, so that every medical student that is qualifying has had a rotation at the dental school and understands the basic ways of preventing dental diseases, and can be able to be out there and be an advocate, can be able to be out there and engage with communities and participate in prevention activities. Next. So this is an audit that was basically for the purposes of just auditing the process of training of our final year medical students. That is what I'm sharing. I'm just sharing their sentiments. We used a mixed method, and this was carried out during the COVID-19 lockdown. And there were open-ended questions, basically, and I've just summarized what the findings were. Next. Out of 273 students, we got 150 to answer through the online platform. Obviously, challenges, immediately we closed, there were challenges with a bit of communication, networking, internet. And at least about 2/3 had already covered the lectures that were given. And about 55 had gone through the clinical rotation. So they felt whatever was being given to them was delivered with a score of good to excellent for 82% of them, although they had issues with the timing that the lectures were being given, which was 4 to 5 p.m. Next. Yes, it is on the delivery of the course, they had various recommendations that they think the course should be started earlier because they thought there was an opportunity to utilize the knowledge that they were being empowered with in the community settings when they go there in the 5th year. And also, they wanted the lectures made more available online so they could be able to study this. Next. And yes, the majority of them found the course very useful. And in fact, some say they intend to use it to improve their own health, oral health, and also that of their patients. And they were able to appreciate the various specialties, because that means that when they have a patient, they'll be able to know how to correctly refer them. I think a lot of them say they learned a lot about their own teeth, and the fact that there were certain things that they did not quite think they understood in children growing up, but they were taken systematically, and they were able to say they could be able to help their parents with a child from that course. Next. Again, they also learned about, wholesome approach to patient management. Because sometimes it is very interesting to note that a nurse will be able to examine the throat of a child. But how do you examine the throat and you're looking right at the teeth and you don't see them? Because somebody hasn't sensitized you that every time you use a tongue depressor, you should also look at what are the surrounding structures, what is the gum health. It can tell you that there's anemia, it can tell you that there's poor health, they are lacking nutrients because there's easy breathing. But occasionally we ignore that and we just look at the throat and not be able to see. I think basically what I am seeing in the course utility is that the students thought they would be able to use this knowledge a lot, either to network with their dental colleagues in referring and so forth. Next. And they also pointed out to us room for improvement, that we needed to put emphasis on public health perspectives, because they also felt that could be a place where they'll plug in to be able to ensure that communities enjoy better health. They pointed out a few things that may have been too detailed to dentistry per se, that they did not think that we needed to include. And of course, a few of them, quite a good number, pointed out that they needed more time to be able to absorb and learn this, and that the course could be taught a little earlier. Of course, these sentiments will be given feedback for improvement of the medical curriculum. Next. But the one thing I know is that even in the core curriculum for the MBCHP, there's no mention of oral health or dental training, and we would like to influence and have a perspective that treats the whole patient. Not that you can look at the patient from the color of their hair to the color of their toes, but you miss out that they have a tongue, they could be having a cancer that's growing there and very obvious in the mouth. So the public sector needs also to lead in making sure that there's a lot of linkages between dentistry and general health to make sure that patients enjoy the whole package. Other healthcare professionals sometimes have demonstrated remote understanding on the scope of dentistry in patient care, and that affects referral across the system, and there is sometimes poor linkage of diseases. For example, if you're treating a patient with hypertension, and the drug that you are using is causing gingival overgrowth, do you engage the patient to be able to identify and actually know that certain drugs do cause gingival overgrowth and that there's management for that? If you're dealing with a diabetic patient, do you know that at least the blood sugar could complicate the gingival health, and also poor gingival health could actually cause havoc in trying to control the blood sugar. So we need to be able to be together and see the patient as a whole and treat the patient as that. Next. So basically, in conclusion, that we need to be able to include dentistry in all non-oral health care worker core curriculum. WHO led by a publication called Promoting Oral Health in Africa, where they actually have given guidelines to include non-oral health care practitioners training for oral health component from the community health worker all the way to everybody who is being trained in oral health. I do not think the country has implemented that, and that would be important for us to see if it is implemented. It is likely to bridge a gap and improve the multidisciplinary approach to patient care and improve the movement of patients across referral systems. I want to make the last slide there. Any recommendations? Yeah, so we need to ensure that everybody who comes in contact with a patient, with communities, can participate in oral health promotion. And we think that there will be better treatment outcomes. We'll have early disease detection, and that would be able to improve at least the oral health of populations even when the dentist numbers are not adequate to meet the growing population demands. Otherwise, thank you very much for your listening.
Thank you, Regina. I think Regina has taken us through a very important aspect of training that many of the doctors know very little about what is happening in the mouth. And yet, one of the most common things that we tell patients to do is open your mouth. Now, when you tell them to open your mouth, what are you looking out for? I think the point that she has made here goes very well into the kind of curriculum that we have that we must design that should, in the core curriculum, include areas of oral health. I think you've made the point, and I think it's well taken. And I would like to suggest that if there are any comments that you want to make, please let's make one or two before we break off for lunch. Is there any comment that somebody wants to make? Or is there something that Walter wants to say that he couldn't say before? Pardon? Somebody there, where? Yes. Please.
Thank you very much to both presenters. I have a question that applies to both of you. And my question is on the assumption that we all agree that health is a whole of society challenge. And so my question is, how are we involving other sectors, private sector, entrepreneurs, innovators, in number one, issues around prevention? So you mentioned some of the causative factors like sugar that contribute towards oral health issues. So how are we advocating to make sure that the messaging in the different media and so forth are actually promoting that, working with Ministry of Education to make sure that people know about how to take care of their oral health? And then in training, because of the cost of training, how are we working with other entrepreneurs who could invest in that infrastructure so that it becomes more accessible to other people? And the same question for the curative side. So what recommendations or what comments do you have about those kinds of collaborations and taking advantage of the fact that we have a very young demographic in Africa? People are waiting for these opportunities to invest and to work in. Thank you.
Thank you. Do you want to respond to that? Because I think one of the areas that oral health starts from is at the level of the household. What are you doing at the level of the household? And how are you promoting oral health and funding for oral health at the level of the household? Walter? Regina?
Yeah, okay. Thank you very much. I hope you can hear well with this. I know that when the competency-based curriculum was getting developed, we did get involved, and we actually have quite some content in the CBC in the early years, and that is why you see in the school program there's toothbrushing as part of it. There's also, of course, definitely some education on what foods are healthy and what are not healthy in the school curriculum now. When we talk about involving other sector, I know a lot of our colleagues and Kenya Dental Association, we are running campaigns all the time about making sure that people have the correct diet and people visit the dentist for early detection of disease. But we're trying to say yes, and you heard yesterday that there was some training for community health workers. So little by little, we could do better. But and I know we have a national oral health policy which is about to be launched, which also spells out the engagements that we would like to have at different with different sector. And I also know that there is a robust school oral health program. The community engagement has not been great, and I think we are exploring ways of getting there. The sugar sector is a little complicated to engage with, and a couple of times we have tried to legislate that, but we haven't been able to succeed. Thank you.
Okay, thank you very much. I would really like to appreciate everybody. Special thanks to the last two speakers and also to Professor Kulu, who has taken us through the whole morning with a lot of challenges, but he's done well. One announcement for any foreign guests who are here, please, as soon as you leave here, go and get your COVID test. The workers need to leave because they need to carry the samples they've collected this morning. Now we need to agree. We come back, we restart at 1:30. Please keep time. If we find a speaker is not here, we'll just adjust the timing as required because we have to be complete and ready for the gala dinner on time. So thank you very much, everybody, and let's meet at 2:30, please. Thank you very much. I forgot to thank the young gentlemen and the young ladies at the back there, because without you, we wouldn't have succeeded. And without you coming back at 2:30, we won't start at 2:30. Thank you very much.
kindly join the podium, Dr. Sospita. I hope this doesn't continue characterizing us. They say that in Africa we don't care about time, yet time is a resource that cannot, once time is wasted, doesn't go back, So Dr. Sospita is a public health specialist and currently working as a technical manager, health workforce training and regulations at the USAID-funded HRH Kenya mechanism. He has 12 years working experience in health system strengthening, focusing on HRH, governance and leadership, policy and regulation. He has also interfaced with programming in the areas of COVID, HIV, maternal and child health, and civil society strengthening. He's a certified project management professional and a PhD candidate. Dr. Janet Muriuki, unfortunately we have been told that you didn't submit your bio, so you will help us introduce yourself to the audience. So can we have our slides pushed for Dr. Janet Muriuki? Thank you very much.
Secretariat, the slides. Good afternoon, everybody. Glad to be here this afternoon to make this presentation. As the technology team is putting up the presentation, I will go ahead and introduce myself. My name is Dr. Janet Muriuki. I'm a medical doctor and a public health specialist. I've been within the health sector for close to 19 years now, supporting in different capacities, both in public, private, and also now from the development world. I've been previously the chief of party for USAID-funded HRH Kenya mechanism, and previously the technical director for the same project, but also the HRH Capacity Bridge project and Capacity Kenya project. I'm now currently serving as the country director for IntraHealth, and at the global level, the senior director, health workforce development. Thank you. Thank you very much, technical team. Yes, so this afternoon, I'll be making a presentation on improving the quality and accessibility of medical training to meet the needs of universal health coverage. This is my presentation outline. Next slide. So what really is the background towards the health sector's experience? I think critically, and this has been mentioned in various panel sessions, is the shortage of critical health workers due to the high cost of medical education. There are also glaring gaps between pre-service and in-service with medical education institutions, and I'm talking about here both the universities and the colleges, sometimes not producing graduates who are fit for the market. And I think that's where we are here in this conference. Curriculum may not be competency-based, it's more of the theory, and may not be responsive to both the county and national health needs and priorities. There have also been weak linkages between the clinical instructors, what they call the preceptors or the mentors, when students are actually going for placement. And this is arising because accreditation of health facilities at teaching hospitals is limited. We have more for internship than student placement during their training years. The linkage between the ministry, regulatory bodies, and medical training institutions still needs to be strengthened. A lot has been done, but I think we can do more. Inadequate institutionalization of in-service training, poor training data system for real-time data to make informed decision-making, the delays in actually translating data that comes from training assessments, and various have been undertaken, but their dissemination and forward implementation of their recommendation has been a challenge towards policy formulation. And lastly, really around COVID. We needed to have done more in terms of preparing our workforce for the pandemic, not from just face-to-face training, but also ensuring we had adequate online training. So IntraHealth began its journey, the partnership with the Ministry of Health pre-devolution. This schema highlights that journey from a project known as the Global Capacity Project through to Capacity Kenya. And then at the time of devolution, USAID was able to grant us 2 projects. The Funzo Kenya project, which I'm going to focus a bit of my presentation on, and subsequently the HRH Capacity Bridge project and the HRH Kenya mechanism. And the efforts of these projects that have been implemented under IntraHealth through funding from USAID have really responded to that enabling environment, functional systems for HRH, and ensuring quality, efficient and quality service delivery. What are the objectives for me as I look at these topical issues? I think when we are looking at improving the quality of training to increase the number of health workforce, I look at them from a 3-pronged approach. That is increasing the physical number. And for us, I will mention something here about a product we did in collaboration with the Higher Education's Loans Board, known as the Afya Elimu Fund, which was a low interest rate a product that will enable students to, at tertiary level, especially the medical training colleges, to pursue their dream career. The other is really about the quality of our pre-service training, faculty environment and curriculum, and lastly, institutionalization of in-service training at the county level. To achieve this, we applied various approaches for transformative education, and my presentation will focus on these areas based on the work and our experience as IntraHealth here in Kenya: curriculum development, the training regulatory framework, faculty development, but going a step further and actually putting in place mentorship between faculty and between institutions, accreditation of student placement, training data and training systems assessment, resource mobilization to improve the infrastructure that will support increasing the health workforce, institutionalization of in-service training, innovative student financing, this is the Afya Elimu Fund, and partnership and collaboration between the sector stakeholders for medical education, both at pre-service and in-service. Part of the work that has been done previously is when we look at a medical training institution, be it a university or a college, when you're going out there to a census for both baseline and subsequent midterm or even end term, there are critical issues that need to be undertaken. And this assessment is based on an approach where we look at the management up to the deans, you're looking at the VC, the educators, the faculty in the various departments, the student. How are these students being selected? Are they meeting the relevant criteria for entry? And even as they are doing their exams, are they qualifying? The curriculum that is being put in place, the infrastructure, the materials and equipment that provides that enabling learning environment, the clinical practice, that exposure, because that is where they first get their mindsets to look at standards. What are the standards by which I will be going out there to provide services? And what is that environment going to look like? And this is during the student placement years. The quality assurance measures that are being put in place by the regulators, the institutions themselves, and also the hospitals. What does that look like? And lastly, the partnership and exchanges. So when my team and I reflected on a framework for curricular governance, which we implemented and had good results, we really looked at, is that taking the context of the national health needs and priorities? And where can this be sought from? I think talking to the alumni is critical. Going there and finding out, are the alumni who have been through our products fit for the market? Do they feel that we, as training institutions, and I will use the word we because I have been part of training institutions during my career, are we preparing them adequately? I'm a product of one, and I can share yes, and in some instances, no. Because the rest, I had to build from the market by having the mentality to continue to be of a learning nature. So do the curriculum address those gaps? Then you really need to look at having in place that curriculum committee, both at the regulatory level for the core curriculum and also at the institutional level. And at the in-service level is really looking at the ministry because they guide the program standards, and really that is critical. And then now going to the pre-service, the service point. This is one of a tried and tested coordination framework around human resource development. As IntraHealth, since 2010, we have supported the Ministry of Health National HRH-ICC, and alongside that, worked at the intergovernmental level to also work with the HRH Thematic Committee and also the Chief Officers of Health. And during the term of Funzo Kenya, we would bring together, and even the HRH Kenya mechanism, would bring together the deans and the vice chancellors to meet and brainstorm, to really create a peer-to-peer environment where institutions could benchmark against each other, engage across the whole spectrum of the things I have mentioned previously, and then intersect with the county. At the county level, as an offshoot from the HRH-ICC, is really the County Technical Working Committee on that supports both management and training. And alongside that, this county-specific HRH committee, technical working group, would intersect at the cluster level where we are bringing a group of counties to engage and continue that dialogue with other sectors like the Public Service Commission, the County Public Service Board, the union leaders. They do have a voice in all this, as well as the HRH unit. So what have been the results of some of this work? I think the main important thing is the enabling environment, and those are the policies. One thing that has been anchored, especially for in-service training, is through a document that was supported, the training policy, the training procedure manual. At the institutional levels, I'll give examples of Kenya Medical Training College. We supported the quality assurance policy, a curriculum policy, And at the same time, looked at even how does one accredit clinical placement sites, gave a roadmap towards that. How do we also look at continuous professional development, and policies were created towards that, and we'll demonstrate how they were implemented. On performance standards, we went ahead and engaged with the various regulators to formulate what the standards would look like for various programs, whether it be doctors, nurses, clinical officers, nutritionists. And these were in efforts to ensure that there was compliance to the standards, both global and international. And I think now is the time to actually reflect on some of these standards and to see, are they due for review? And I think the answer would be a probable yes. Continuous professional development, this is critical for our health workers who are in the labor market serving. So again, we worked with the various regulators to ensure these documents were put in place. Core curriculum, working with the doctors board, nurses, council, clinical officers, environmental health, public health. We were able to also put some of this work in place to guide the medical training institutions. Some of the results really for us over this 16-year journey has been the establishment of the curricular committee. And these curricular committees were able to actually go out there, review their various programs. 81 of these were reviewed, and as end of 2020, 22 curriculums had been approved for those that were new, but the others were within the threshold of the institutions to move forward with them. Resource mobilization committees were also put in place. Various proposals were put across, either to financiers, public, to the Treasury, the PPP unit. Others put in place strategic plans that have been able to move on and be actualized with the support of the various institutional boards. We also looked at pedagogy and andragogy for faculty. We encouraged them to go out there and also mentor others, and this was working with about 13 medical training universities and colleges, so that they could support interdepartmental, then externally inter-institutional. So a university could easily mentor a college. For example, when I look at Moi University, they were able to mentor the Moi Teaching and Referral Hospital College of Health Science. We were working with the likes of Tenwek that were also mentored by the Moi University. So this actually provides the standards. This is about the Afya Elimu Fund. I'll not go into the details, but the outcome of this was 40,000 students supported, with those graduating and also going into the labor market. And the total pool of funds came from both government, private sector, and development partners of about 3 billion Kenyan shillings. At the end of our work, critically was looking at the maturation of the counties. Where were they? And we looked at those various building blocks, really to say, have we left sustainable systems? The answer would be yes. More could still be done, especially at the county sector, for institutionalization of in-service training. I'll skip that in interest of time. So what are the takeaways that I would want to leave here? Sorry, the slides are not moving as I want. For a few more seconds. Okay. I think what I really want to leave as the take-home messages is the establishment of the curriculum committees. These are key, and as we look at transforming education within our medical training universities, this is going to be critical. Infrastructure. Are we ensuring that we have the right teaching environment? When we also look at student placement, are the hospitals that our students, during their pre-service years, being exposed to, actually are of the standards to be teaching hospital? So I think it calls for dialogue between academia and the ministry and the county government to really ensure that we can have more of these clinical placement sites that can also support internship to gather and support the increasing number of our health workforce. Taking stock of the assessments that have been undertaken, ensuring that they are disseminated to inform policy, I think for me is key. And then lastly is centers of excellence. This will be key, and this again will be tied to the teaching hospitals. Can we ensure that if we're looking at specialty training, for example, let me take neurosurgery, that teaching hospital is dedicated, and it can be a county referral hospital where infrastructure is actually strengthened. Can it support the training of a multidisciplinary team? The doctors, the nurses, the clinical officers, the biomedical engineers, that whole team that is required to support neurosurgery. Could our Coast General Hospital, that has actually done a program on COSEXA, support not only the training of the doctors on cardiology, but the nurses and other staff that are required to support cardiac service, both from a physician perspective, but also a surgery perspective. The other thing is the accreditation. I think I've already mentioned a bit of that. Financing of our trainings. We've been having a lot of scholarships, but I think we need to move to the next level where there's government commitment to support a loans product. This is what is done in the US, the UK. Education of students, but we have it at the degree level. What about our diploma level? The bulk of our health workforce are our nurses, our clinical officers, health records, nutritionists. We need to support that career growth. And this is not going to be possible just through the county bursary funds, but they need to look at a loans product beyond scholarship that will sustain their development. Another point I want to bring out as my chair sends me off is really our community health assistance training. These are the supervisors of our community volunteers. We need to support their training. Right now, we're having a mismatch in the ratio of the supervisors for community health, the extension workers, and the volunteers. Most of them are supervising up to 30 of the volunteers, yet the community health strategy advocates for a ratio of 1 to 10. But who is producing them? Our medical training colleges, apart from one, are not accredited to produce that diploma cadre. So I think there is a move towards, and in the spirit of UHC, and what we have seen around COVID, this is a cadre that needs to be supported and ensure that they look into the quality assurance of the community health services. And lastly, innovative training. Can we move beyond our classroom? E-learning, mentorship, on-the-job training is critical for the development of the health workforce. And this will also reduce absenteeism, because when people are in classes for their training, we are increasing absenteeism. Thank you very much. I will pause there. I think I have brought together my conclusions and recommendations. Thank you for your attention.
Tumupigie makofi. Thank you very much, and apologies for being a bit nasty to you, because we are really chasing time. So I would like to request Dr. Sospita to take on the floor, and kind also bear with me. I'll be harassing you a bit. Thank you.
Great. Good afternoon, everyone. Good afternoon.
Good afternoon.
So as I wait for the presentation to be loaded, so it's my pleasure to be here with you today afternoon, basically to have a discussion with you for the next 20 or so minutes. 15? On 15? 15, I'm being told, on really what needs to be done by the counties, especially on the leadership, on issues to do with training. Because as you know, on issues to do with in-service training, we are really lagging behind pre-service training. For pre-service training, there's a lot of focus on curriculum development. There's a lot of focus on building the capacity of faculty. But for in-service training, not much has been done, especially in the county that have taken up the UHC model. So I'll request that we start off. Great. So my name is Sospita Ndaba. I work for the USAID-funded HRH Kenya mechanism that is implemented by IntraHealth. We're actually in the same team with Dr. Janet. But my presentation will really focus on a training needs assessment that we carried out in the year 2019 in 10 counties, and the implication of this TNA, especially in decision making, ensuring that the trainings that we're implementing in the counties are really aligning to the situations on the ground. Because before we did this TNA, there was a lot of focus on the quality of training and even aligning this to the requirements, especially in terms of the competencies. So this is my presentation layout. I'll quickly move to the introduction. So a TNA is basically a process that combines two things. As we know, knowledge is compartmentalized into two. We have tacit knowledge, which is knowledge that you gain from your workplace, from your interactions, but also we have explicit knowledge that we gain in class. So a training needs assessment essentially looks at how we can bridge the gap between what we know and what we should be knowing in context of the two knowledge gaps. And a TNA essentially should be done after 2 to 3 years. And you can see this is key, especially having done this in 2019, a lot has changed between then and now. Before then, we didn't have COVID-19, and also the strategy change to scale up UHC has just started now. So indeed, there's a lot of focus on what kind of knowledge and skill competencies we can have in terms of having quality healthcare that is aligning to UHC. In terms of background, training has been a national function until we had the promulgation of the Constitution in 2010, and this was now transferred to the counties. But I must say that the counties have been ill-prepared in implementing these trainings, both short course trainings, which are 6 months and below, and also long-term trainings. And this is essentially because of lack of capacity, lack of resources, and even lack of motivation and the know-how to implement the training needs assessment. And as per the MOH guideline of 2015, it critically says that, or it basically emphasizes the need to have a TNA done, which is evidence-based, before any training intervention. And I think this is key in any public health intervention. You need to have something that is evidence-based that preceding this. The objectives were 3. The main objective was to establish in-service training gaps and priorities to inform implementation of universal health coverage, especially in context of coming up with training projections for each cadre of health workers and even budgets, so that the counties are able to lobby the MCAs to include these training budgets in the county work plan, but also use this as a basis to lobbying the partners to fund trainings. Specifically, we're also looking at how this can also lead to knowledge in terms of leadership and management gaps. So we're also looking at coming up with gaps also on issues, the technical issues related to service delivery. And this linking, of course, with development of the training projections and budgets that I've just alluded to. So the data collection was done in 10 counties, and the emphasis here was on buy-in from the counties. And in this regard, we had planned several workshops with the county leadership. We started off by writing a proposal to the county Minister of Health. The county Chief Officer of Health and directors were engaged, basically to have their buy-in This also took place in context of our CHMT workshop. This is the County Health Management Team. We engaged them, and we had their input, especially in contextualizing the data collection tools. We formed a smaller committee after that meeting to lead the process of data collection after the customization of the tools. And we also had a piloting done in each county for us to understand which areas we need to prioritize. Data collection took a whole month. We had purpose to do this in 2 weeks, but there was a lot of delay, especially in receiving feedback, because we were moving from hospitals to hospital. We're also moving to the sub-county health management teams. And as you know, some of these counties are quite huge, so the movement was also delayed. So data collection took a bit of time. After the collection, we did analysis, and we did this using Excel and SPSS. And after that, we had to have dissemination and validation workshops. And this was key for us. As I said before, we needed the buy-in and also the input of the counties. And of course, this was followed up by key recommendations, which we are going to discuss shortly. So the two photos show the process that we used in data collection, the discussions we had with the county leaderships. The first one is a discussion, data collection discussion with medical superintendent, and the second one is a CHMT focus group discussion. As alluded to earlier, the counties that we focused were 10 as outlined, and the sampling was purposive. We used a three-pronged approach. We had data collection done from the top leadership, the CEC, and the Chief Officer of Health, and the county directors. But for us, the key decision makers were the CHMT, the sub-county health management teams, and the hospital management teams from level 4 and 5. And for quality purposes, and for that third eye, we roped in the partners just to give us some insights from their perspective. We used several data collection tools. We used questionnaires, structured questionnaires for the top leadership. We embarked on focus group discussions, especially in the hospital setup, where we engaged them through their weekly CMEs to collect the data, and even also used desk reviews with the HRD department to get insights on what has been done before. For data analysis, we used a triangulation approach from the three data collection tools for us to get the key areas, the priority areas of focus in terms of the training gaps that we identified. So quickly to the findings. This diagram basically shows the respondent distribution, and as you can see, majority of the respondents were from the sub-county and the county health management teams, because these essentially are the decision makers on the ground. We also had level 4 and 5 hospitals, and the smaller numbers were represented by the top leadership, as indicated. So this diagram basically shows the key findings, and if I can quickly explain, the x-axis shows the respondents, the distribution of the respondents in terms of the numbers on who prioritize the trainings. The y-axis, we have the service delivery domains, and in brackets, we have included now the key priority training areas that we identified. So I can quickly take you through this. For the TB HIV service delivery domain, we found that the key training priority was pediatric TB management. For public health service delivery, we found disease outbreak, preparedness and response taking the lead. For nutrition, we had maternal, infant, and young child feeding. For rehabilitative services, we had speech and hearing therapy, and this came out often from these counties that indeed they need to engage this group, disadvantaged group. For nursing, we had immunization, and the plan going forward is to unpack this to know which aspects of immunization that we can really emphasize on. For pharmacy, we had drug supply, management, policies and guidelines. Health information, we had data analytics and training. For radiology, we had CT scan, and especially this is in regard to the government system of procuring this through the SME procurement. And so this has to do with a lot of radiology and management of this machinery. Laboratory services, we had quality management systems. Reproductive service, we had emergency obstetric and neonatal care. Clinical services, we had integrated management of childhood illnesses. And finally, malaria services, we had malaria case management. So these were identified as the top or the priority disease, the priority training needs for these counties. We had many others that we have not included. We have just included the top priorities. For LMG, which was quite key for us, apart from looking at the technical aspects of service delivery, we were looking at also issues of performance and issues of career progression. So what came out in terms of performance was leadership for service delivery as a key need. And for career progression, we had senior management course. And as you know, many of these courses are offered by Kenya School of Government. So for discussion, I think from our initial interaction with the county, we found that there's really a huge unmet need for training. And this is specifically because many counties prioritize the training of only 3 cadres. In fact, we ended up calling them the cartel of trainees, unfortunately. And these are the medics, the nurses, and the clinical officers. So there's a lot of demotivation on the ground from other cadres because they're not really engaged in training opportunities, both long-term and short-term. And one of the consequences we have found of this is that there's poor service delivery because, of course, there's a lack of these competence and skill sets that are required for quality service delivery. There's also demotivation, as I've outlined, especially where they seem to have a lot of favoritism in terms of the cadres that are being trained. And finally, there's attrition. There are many cases of health workers who have left government service to move to other institutions, especially academia. We have an influx of health service workers moving to academia because of career progression. So prior to this exercise, we also found that the counties were using different methods of decision-making in terms of training. Key amongst this was benchmarking, which is really not scientific. You'll find County A benchmarking with County B and using their training gaps to train the health workers. And this is very rampant with the counties. We also found that many of these trainings are also partner-led, and as we know, many partners have their own agenda. So you'll find that in many counties, there are repetitive trainees or repetitive trainings, and these trainings are really not aligning to the situations on the ground. Finally, you'll find that many trainings in the counties are aligned to health worker needs and aspirations, which really should take second slot. The first should be the county needs. So finally, we're saying that the training needs assessment should really be a basis for the counties to know what kind of resources they can invest in terms of training, because it is evidence-based, it is people-led, and there's a lot of buy-in from the health workers, as you have seen, in terms of the key capacity gaps that exist in each cadre. So we are proposing going forward for all counties to embrace TNA. This is as outlined from the national training policy, that each county should embark on a TNA at least once in 3 years. One of the recommendations we're also coming up with, and this has been pointed out, is institutionalization of mentorship on the job training. And in IntraHealth, we have identified mentors and champions in each cadre to embark on the job trainings, and even e-learning, because there are many online resources that we can use for this. Thirdly, we need to engage with partners and MTIs. I can use the example of Kilifi. They have an MOU with Pwani University, and they're implementing trainings. The last time I was there, they were implementing a training on monitoring and evaluation. Those key partnerships are important, especially right now we are looking at many counties having their own universities and training institutions. Those synergies are important. Finally, we have come to realize that partners are also to blame. Many of the trainings that are implemented by partners are not evidence-based, and they're repetitive. And this leads to a situation where we have what we call professional trainees. And when you go to these countries, you find many of them because of the per diem and other amenities that they get from these trainings. So as I conclude, what needs to be done for the counties to institutionalize in-service training? I'll just quickly take you through that diagram. It's a diagram that shows the milestones, what we call the in-service training maturation, starting with the lowest level, which is the smallest dot, to the highest, which is the red dot. So for starters, all the counties require a training committee. They require governance structures to be put in place. And these governance structures are important because the training committee is what plans and implements the TNA. The training committee is what approves training requests. And this training committee is also what aligns the stakeholders and partners to the priority trainings. So those governance structures are important. Secondly, implementation of the training needs assessment, and going further from the training needs assessment to come up with training projections and budgets. Once again, as I said before, these budgets are important to lobby partners to fill in that gap, and also to lobby the county assemblies to include this in their annual plan. Thirdly, there is need of a system for approval of trainings. We have found that in some counties, this is haphazardly done, where there is no really a defined way of getting training requests approved. So we want the counties, or we propose to the counties to standardize this process for even motivation and also buy-in, and also having a system that is applied by all equally. Fourthly, is to have a data management system. In IntraHealth, we're implementing integrated human resource information system, which is a platform that enables us to understand and appreciate the role of training in the counties, especially who have been trained, which trainings they have attended, when they are coming back for long-term trainings, so that you can easily manage the trainees and even the training outcomes. Also, issues of CPDs are important. And finally, to emphasize on the last dot, which is the icing in the cake, we need to strengthen the bonding system, especially for long-term trainees. Many counties are suffering from long-term trainees who have gone for training, they come back, they have not been bonded, and they go back to do locums. And you can imagine you're paying them 80% of their salary, they have left for 4 years, but you cannot get them back. So our proposal is to have the bonding forms being signed prior to release of these health workers, so that the counties are able to get return on investment on these trainings. So as I conclude, those are the key references. I wish to acknowledge our donors, you said, for funding this process, the county that we have worked in, 10 of them. So there's still an opportunity for us to continue this work in other counties. The Ministry of Health, IntraHealth, and indeed, of course, the CHMTs and the partners who are involved in this. So thank you so much.
Thank you so much, Dr. Ndaba. Let's give him a lot of applause. He has actually made his presentation within 15 minutes exactly. Let's have the next presentation, please, such that we reserve more time for questions. We are having the next presenter online on the topic adaptations in ECFMG certification in the age of COVID-19. I think in the morning we talked about continuous quality improvement, and as part of keeping our health professionals on their toes, we realized that it's probably high time we introduced not only the continuous professional development courses or the CMEs, but we rather see whether we can actually introduce certification and recertification exams in our respective collegiate systems or societies, such that we keep sharpening our minds. Let's have the next presentation. It's a recorded presentation from Jill of ECFMG. Thank you. We tried to utilize our time optimally, such that we get some time from the audience, because this is supposed to be an interactive session as opposed to a one-way discussion. So we are trying to be in time to ensure that you get a lot of some time to ask questions. Because we had some revolts in the morning, people are saying that they put up their hands and we don't allow them to contribute or ask questions. So we want to be as democratic as much as we can. Can we have the presentation, please? The IT team.
Medical graduates, or ECFMJ. In this role, I oversee the operations of ECFMG's domestic and international services, including our program of certification and our credentials verification service. Thank you for having me. I'm delighted to be invited to connect with you today as you explore how to position today's healthcare workforce to be the healthcare workforce we need for tomorrow. Over the past few years, we at ECFMG have had to do just that, evaluate how to support today's international medical graduates and adapt our processes and frameworks to support them to move forward and practice in the healthcare system of tomorrow. Today, I'll share with you a little bit more about our work and how ECFMG adjusted to the impacts of COVID-19 while maintaining the integrity of the certification process, supporting IMGs entering the U.S. workforce. First, a quick overview of the session's agenda. I will start by providing you with some background on ECFMG, a brief history, and a highlight of our programs and services. Then, I'll explore details of our program for ECFMG certification, reviewing the pre-pandemic requirements and the impact of the COVID-19 pandemic on our certification program. Finally, I'll end our session highlighting some key takeaways and lessons learned. ECFMG and the Foundation for Advancement of International Medical Education and Research, or FAMER, are integrated, nonprofit, non-governmental organizations. We are based in Philadelphia, Pennsylvania in the United States, but we have a global reach. Through our more than 65 years of service, we have developed core expertise on the world's medical education systems and their graduates, the authenticity of physician credentials, the assessment of physicians, research on physician migration and the U.S. physician workforce, and U.S. immigration policy impacting international medical graduates. Now that you know a little bit more about who we are, I'm going to review for you some of the key programs and services we provide. During and after World War II, the United States began to see an influx of immigrants, including many physicians who wanted to practice their profession in their new home. However, because of the varied educational systems around the world, it was challenging to determine if these physicians met minimum standards to enter graduate medical education in the United States. Thus, ECFMG was founded in 1956 with the charge of assessing through a program of certification whether international medical graduates, or IMGs, are ready to enter U.S. graduate medical education programs. This remains one of ECFMG's core functions today and is an integral part of the medical training and licensure process for IMGs. Over the years, we have expanded on this mission to provide several other services for the medical community, including support for IMGs applying for U.S. graduate medical education programs through what we refer to as the match, visa sponsorship for foreign national physicians participating in graduate medical education programs, and verification of ECFMG certificates for organizations that rely on ECFMG certification as part of their evaluation of physicians. Internationally, we support regulators and other entities around the world by verifying credentials related to a physician's medical education, training, and licensure. These are just some of the highlights of the many services we provide. As we are here today to talk about the impact of COVID-19 on ECFMG certification, I'm going to spend a few minutes now talking about what that means. ECFMG certification is the gateway to the U.S. healthcare system for IMGs. Since 1956, we have certified more than 420,000 physicians, and today approximately 25% of the U.S. physician workforce are IMGs. ECFMG certification is required for IMGs to participate in U.S. graduate medical education programs, or GME. It is also a requirement for IMGs to take Step 3 of the United States Medical Licensing Examination, or USMLE, and for medical licensure. The program of ECFMG certification has operated continuously for nearly 70 years. ECFMG sets certification requirements and determines which exams meet our examination requirements. Over the years, these have evolved, but we have always required demonstration of clinical skills and English language proficiency as part of the program. This point will become important in a few minutes when we talk about the impact of COVID-19. To start our overview of the requirements for certification, I'll start by defining who is an IMG. An IMG is a physician who received their basic medical degree from a medical school located outside of the United States and Canada. It is the location of the medical school, not the citizenship of the physician, that determines whether the graduate is an IMG. To understand the impacts of COVID-19, it's also important to understand ECFMG certification requirements prior to the pandemic. First, IMGs must meet general eligibility requirements. IMGs who meet those requirements are able to move forward with the certification process, fulfilling the requirements for certification. Once all of these have been met, the IMG can be ECFMG certified. And this framework did not change with the pandemic. Some of the components of the requirements did, but the certification framework itself remained intact. In terms of general eligibility requirements, there are both medical school and individual prerequisite requirements that an IMG must meet in order to pursue ECFMG certification. First, the IMG's medical school must meet ECFMG's eligibility requirements, including that it is recognized by the country in which the school is located and the graduates of the school are licensable in that country. In order to determine if their school meets our requirements, applicants must check the World Directory of Medical Schools. Their school must be listed in the World Directory with a note indicating that the school's graduates are eligible to apply for certification. The physician must have received from that school the appropriate degree that leads to the practice of medicine in that country. There are also education requirements that the individual must meet, including length of curriculum attended and restrictions on credits transferred to their school of graduation. IMGs also must go through ECFMG's robust identity verification process. If the IMG meets these requirements, they can proceed with certification. There are 4 components to certification that must be met: medical science examinations, clinical skills assessment, communication skills assessment, including English language proficiency, and medical education credentials. Currently, to meet the medical science requirements, applicants must take and pass Step 1 and Step 2 clinical knowledge, or CK, of the USMLE. To meet the medical education credentials requirements, all IMGs must submit their final medical diploma and transcript, and these must be verified directly by authorized officials at their schools. Prior to the COVID-19 pandemic, passing performance on Step 2 clinical skills, or CS, of the USMLE met both the clinical skills and communication skills requirements for ECFMG certification. This had been the case since the early 2000s. And this is what brings us to 2020. In March of 2020, the USMLE program temporarily suspended administration of the Step 2 CS exam due to the COVID-19 pandemic. In May of 2020, the USMLE made the determination that the suspension would last for 12 to 18 months. The impact of this suspension for ECFMG certification was profound. Thousands of IMGs who are intending to apply for graduate medical education program positions beginning in 2021 would have no way to meet the clinical and communication skills for ECFMG certification. ECFMG quickly evolved to develop, plan, and implement a solution, the pathways, in just over 3 months. In January 2021, when USMLE announced the discontinuation of the exam, we quickly evolved again, announcing that we would continue and expand the pathways for training positions beginning in 2022 as well. This expansion launched in August of 2021. In developing and subsequently expanding the pathways, we kept several goals in mind. First and foremost is that we needed to ensure ECFMG certification continued to serve its critical functions. Certification assures the U.S. public and graduate medical education programs that IMGs are ready to enter supervised clinical training. It is a core requirement for IMGs to apply for and begin graduate medical education programs, so we needed to ensure that there would be a qualified pool of IMGs to enter training programs in 2021. In developing the pathways, we needed to maintain rigor and integrity by using appropriate measures of clinical and communication skills. we also needed to leverage existing measures available now for IMGs applying for the 2021 and 2022 positions. As I mentioned, this initially all happened in just under 3 months. In June of 2020, we announced that development of the pathways was underway, and it launched at the beginning of September 2020. Effective at that time, IMGs were able to meet the clinical skills requirement through either a passing performance on Step 2 CS or by completing a pathway. IMGs were able to meet the communication skills requirement either through a passing performance on Step 2 CS or through part of the pathways, which is the Occupational English Test, or OET, medicine exam. There are 3 main components to the pathways: the pathways themselves, the assessment of communication skills, including English language proficiency, and the expiration of certificates. I'll speak to each of these in a little more detail. Currently, there are 6 pathways. Pathways 1 through 5 were developed in 2020 for training positions beginning in the 2021 academic year. Pathway 6 was added for the 2022 academic year to provide an opportunity for IMGs who are unable to meet the requirements for Pathways 1 through 5. This gives all IMGs who would have otherwise been eligible for certification an opportunity to be certified. Now, Pathway 1 is for IMGs who are already practicing medicine in another country. These are mostly non-US citizens. Pathway 2 is quite small, but allows IMGs to use passing performance on OSCEs offered for medical licensure in other countries, such as Canada and the United Kingdom, to meet the clinical skills requirement. Pathways 3, 4, and 5 are primarily for students or very recent medical school graduates who have not yet obtained a license to practice medicine. All 3 pathways require the medical school meet certain eligibility requirements, such as accreditation by WIFME recognized accreditor. They also require medical school officials to attest to the students' clinical skills. As part of this attestation, the students' clinical skills must be assessed by appropriate medical school faculty during in-person encounters. Pathway 6 is intended for those individuals who do not meet the requirements for Pathways 1 through 5 and or who have previously failed the USMLE Step 2 CS exam. To meet the requirements for Pathway 6, the applicant's clinical skills must be evaluated by licensed physicians using ECFMG's Mini Clinical Evaluation Exercise, or Mini CEX. The Mini CEX is a well-studied workplace-based assessment tool used to evaluate an individual's clinical skills in a variety of clinical settings. Through Pathway 6, physician evaluators assess the IMG's clinical skills during real, in-person patient encounters. Completion of the pathways also requires assessment of communication skills, including English language proficiency. This is required for all IMGs, regardless of citizenship, native language, or medical school language of instruction. For this requirement, ECFMG selected the Occupational English Test, or OET, medicine exam. This exam is used for the purposes of medical licensure in countries such as Australia and the United Kingdom. The assessment includes 4 components: reading, listening, speaking, and writing, and ECFMG requires a minimum score of 350 on each component. To ensure currency of communication skills, the assessment must have been taken on or after July 1, 2018. Finally, ECFMG certificates may now be subject to expiration. Certificates issued to individuals who meet the clinical and communication skills through one of the pathways are subject to expiration if they do not begin an accredited U.S. graduate medical education program before the expiration of their certificate. This ensures reasonable currency of clinical and communication skills at the time of entry to training. Once the IMG completes the first year of their training program, their certificate will no longer be subject to expiration. This requirement provides an additional measure to assure the public and regulatory authorities that those obtaining certificates through these pathways have been appropriately vetted. If the IMG does not enter a training program before the certificate expires and wishes to revalidate their certificate, they will be required to meet additional clinical and communication skills requirements. This highlights that we are not yet done evolving our processes. We are currently working to develop the revalidation process for impacted IMGs.
Thank you very much. For anyone that is interested in the ECFMG FEMA certification through the USMLEs, we actually have a working protocol on behalf of AMCO and the ECFMG. The Health Professions Council of South Africa has already actually started implementing that one. So we agreed in principle to share their database. So if anybody is interested, I think the initial steps have been highlighted. Most of our regulatory authorities are in touch with ECFMG and FEMA. So I saw quite a number of young doctors here. So if there is anyone that is interested, and particularly for the implementation of workforce migration, looking for greener pastures, though we note that we probably need to create more greener pastures here than there. But again, one can go for knowledge. You acquire as much knowledge from that side, then come back and practice in your country. So, dear ladies and gentlemen, we would like to thank our presenters, and I would like to appreciate each and everyone through a round of applause. If you don't mind, please let's applaud our presenters. And this is a session for the Q&A or complimentary statements, questions, or particularly where we were rushing our presenters. Unfortunately, chasing time is not easy. So if there is any complimentary statement or differing opinion or asking on the methodologies that are being used, and maybe for those that do not come from Kenya, you can compare your counties as small countries to some extent. I think they have got some degree of autonomy and all that. Where they do, where we have decentralized entities or decentralized governments, we actually have a few federated governments on the continent as well. So the floor is open. We have a microphone there and a microphone here, and I think we have also some roving microphones. We have about 10 minutes. Please make your statement short and brief and be to the point. Thank you, sir. Walk faster, go to the mic, ask your question. I think it is important for people to move than remaining still. Thank you.
Thank you, Mr. Chairman. I just want to seek a small clarification from the presentation that touched on devolved government in Kenya. Among the questions during the TNA, I didn't see the participants raise issues about governance. And I believe leadership and governance is one of the 8 pillars in health systems management. Thank you.
Thank you very much. Yes, please. Please tell us your name and indicate who you're asking. Thank you. That's okay. The question was clear enough.
Good afternoon. My name is George Rai. My question is to all the presenters. The first one was particularly on training needs assessment. I see there was overemphasis on government employment and government health institutions, yet a sizable proportion of health workers are in the private sector in the whole of this country. How do you extrapolate this issue, and how do we involve all other health workers who are not necessarily in government? The second one is it possible to make contact with clients in postgraduate environments to be part of the training programs. What I mean here that after registering all practitioners in both private and public, the very fact, and it depends on how you design it, the very fact that you have had an encounter with a patient, you need to do detailed documentation and carry out citations of that case, whether it is surgery or whether it is a medical case, so that we move on in the future to make all places a training ground. Because if he did a cesarean section in a small hospital somewhere, then, and we have systems of monitoring that, it should go into your credit for training.
Thank you, sir. Yes, please. And we need ladies as well. Let's not have gender bias in terms of giving ideas. Yes, please.
Yes, my name is Meoli Kashorda from Kenya Education Network.
If you can remove your mask, please. You are alone,
yes.
so you.
I'm not.
And take away your.
Sorry?
Oh. Yes, please. Go ahead.
Yeah, my name is Meoli Kashorda from Kenya Education Network. We are the National Research and Education Network of Kenya.
Sir, we can't hear you. Maybe I know there is a vertical challenge here. Just get the mic out of it and then talk.
Yes. Yes, my name is Meoli. You can hear now. Meoli Kashorda from Kenya Education Network, the National Research and Education Network of Kenya. I want to ask the question, I think it was for both of them, asking the question that we have professional trainees because training is seen as a source of additional revenue. How do we solve that problem? If the training is not to help, but it is actually to increase revenue, how are we going to solve that problem?
Thank you very much. Let's first answer these questions. If there is anyone that is from outside Kenya that wants to ask, we can have that positive discrimination. If there is none, please let's answer the questions. Thank you.
Okay, so thank you for those questions. I'll start with the first one, which was on the LMG. Yeah, indeed, leadership and management training gaps were the key focus for us as we're implementing the TNA. We did not want only to dwell on the technical aspects of service delivery per cadre. We went further to look at leadership, management, and governance. As you know, leadership is about decision making, and especially right now as we're scaling up UHC, we need to have more decision makers, especially in the decentralized units. So for those who are not from Kenya, just to give you insights that our health sector is devolved to the counties. They have progressively taken up more responsibilities. Some of these responsibilities were supposed to be left to the ministry, but this has been taken up by the counties. And in essence, decision making, especially on service delivery, on human resources for health, and even analyzing the successes of the interventions now really lies on the counties. So from our training needs assessment, what came out as a key gap was on leadership, senior leadership, leadership management and governance in context of performance was a course on senior leadership and governance, which luckily for us, this is a course that is being implemented by the Kenya School of Government. So our plan is to link up these counties to these training opportunities at KSG. The second one on the TNA on issues of private sector engagement and NGO, indeed, this is one of the lessons learned for us, as we alluded to earlier. This is the first time we are doing this, so there are quite a number of lessons we learned, especially on also engaging level 2 and 3 service delivery units in the TNA. For us, we engaged level 4 and 5 and also the county leadership. I think going forward, and there's an opportunity now for TNA to be done, is to engage even the private sector and the NGOs. We are cognizant of the fact that in some counties, they account to 30 to 50% of service delivery. So that is a lesson learned for future TNA. Finally, the issue of professional trainees has been a headache. This has been a headache in many counties. And this can be dealt with by different strategies. One of them is actually the TNA itself. By implementing a TNA, you're able to know the various gaps that exist for each cadre. So this locks out any trainee who does not fit into this training, especially if they are not implementing this as part of their service delivery. Secondly, the institutionalization of a database, and I talked about this. We are currently implementing a database known as Integrated Human Resource Information a system, IRIS Train, which really gives us an idea on who has been trained, when they have been trained, which area of training, and when they are coming back. And the implication of this is that, and this is according to the MOH training policy, is that these trainees should not be released for another long-term training until the expiry of 3 years. So this database is key, especially in streamlining that aspect. Finally, stakeholder coordination. We take cognizance of the fact that stakeholders are to blame for health workers missing their duties. So this is a role that we are really emphasizing the training committees to take up, the issue of stakeholder coordination, especially partners. So whatever they are training should be aligned to the TNA, and also there should not be repeat trainees, so that this aligning and ensuring that the training really meets the demands on the ground is very key. So these are the strategies I would think of, or how to deal with professional trainees. But I must admit this is a challenge that is currently existing in counties. If you do an audit, really be shocked. There'll be quite a number of health workers, especially the 3 cadres that I talked about, who really attend all the trainings that exist because of the per diem and other issues that come with trainings.
Thank you very much. 1 minute to go. Thank you. No more questions, please. Thank you very much. You can ask actually in the preceding discussions. So they are still here. So you can, okay, please take over. Dr. Ojuko will have to bear with us. We don't need blood to flow here.
Okay,
please.
Thank you very much. So I want to appreciate the presenters. I want to limit, my name is Wycliffe Ogenya. I represent Community Health Services and Development Officers Association, CHESOA. And my question goes to the first presenter, Dr. Murioki. One, what is the role of professional associations when it comes to issues of training, especially within the HRH? And I also wanted, because during the presentation it was highlighted well, the cadres, the regulators that you are working with are the mainstream regulators. And bear in mind, in Kenya, out of the 42 healthcare cadres, only 9 are regulated. So what about the 33 other cadres? Then in terms of community health worker program, it is the WHO has actually recommended that the 3 main things: capacity building, supervision, remuneration. So in terms of capacity building, what is the HRH mechanism doing to ensure that the community health worker programs, they are capacity built? I mean, capacity building of that cadre. So then the other issue has got to do with, personally, I'm a beneficiary of one of your trainings, which is the workload indicator for staffing needs. I attended, but the unfortunate situation is that cadres that are not needed in training end up finding themselves. They become the professional trainees. So can we have a mechanism whereby if you need a nurse, let the nurse go for the training, as opposed to when you need a community health assistant, then you find a nurse, you find a doctor, you find a public health officer. So those are some of the issues, and I think it would be good if you look into it keenly, especially for the community health worker programs. Thank you.
Thank you very much, sir.
Yes, thank you very much for the questions. I'd like to begin by responding that the work that my colleague also Sospita has showcased on training needs assessment, this was county specific. I think this is a time right now that we need to look at training needs assessment from a national level. And the last one that was done under a prior project under IntraHealth was, that was Funzo Kenya did this, was in 2017. So this country right now is ripe for a training needs assessment that can cut across public, private, and the faith-based sector, so that there's prioritization of the trainings and resources then allocated appropriately through budgets and projections. To the question that was asked on the role of the health professional associations, they are key stakeholders in training, and to me, both to inform pre-service, and as we're looking at curricula, you have the experience of your association members. When I was talking about post-alumni survey, the associations, you bring the alumni together, be engaged, support the surveys. Are your cadres fit for the market? What was lacking at their pre-service level? What do we need to, through medical training institutions, to have incorporated so that they are relevant and current to the current evolving aspects of their in the labor market. I think the other point on health professional associations is on continuous professional development. This is where you have a big role. Do you have any programs that your cadres can add continuous professional development points, even if you're not supporting their relicensure? I think this is key. Encourage them to continue learning, because things are changing. Health today, health tomorrow is different. We didn't anticipate COVID. So what was done around COVID? What will be done around other epidemics, non-communicable diseases? So health professional associations do have a role in in-service training towards keeping the workforce relevant, but also towards relicensure. Yes, I do want to acknowledge that here in Kenya, we only have eight, I think even 9 regulators out of, for the 33 cadres that have schemes of service under the Ministry of Health and the Public Service Commission. And for the community health assistants, there has been a scheme of service that has been put together. And that scheme of service does guide how those we are calling assistants from 3 all the way to 1 to the officers will continue progressing. So what have we done as IntraHealth? We worked with the Kenya Medical Training College to support both the pre-service and the in-service curriculum to be relevant, and especially during this period of COVID. We have trained it's a 5-month blended face-to-face with online for community health extension workers. And this happened pre-COVID, and even during COVID, we continued to push for those supervisors, for the volunteers. I know there are other partners who have worked on the aspect of supervision. I would name one like LVCT or Living Goods. We collaborate with them. At the global level, we are continuing to support advocacy. In IntraHealth, we have an arm known as the Frontline Health Workers Coalition that is advocating for adequate remuneration of our community health volunteers, and in line with the bills that are being passed currently at both the national and the county level. So we will continue supporting community health work, and we're interested in, and we have partnered on registries for numeration,
Thank
for
you very
documentation
much
of the community health workers.
Thank you very much, Dr. Muriuki and Dr. Ndaba. Can you please give us a lot of applause? And as we go off the days, we would like to call upon Dr. Daniel Ojuka to come and chair the next session. Thank you very much for listening and for asking questions, for the contributions. God bless you.
Thank you, Prof, for sharing that session ably. The next session, my name is Daniel Ojuka. I will be chairing this particular session. This session will have 3 speakers. Dr. Wangare Waweru Sika, if you could come to the stage, and Dr. Geoffrey Goboka Thade Vuguziga and colleagues, and then Dr. James Mwanza and Dr. Azza Bara. I think those are the presentations that are there for this session. As they come, the sessions is about 2 very interesting. Dr. Wangari? Dr. Azza? Come. So Dr. Godfrey will be talking to us on issues of certification of deaths.
Right, exactly. The title is this one. Introducing ICT. So we should have the mask on. I forgot my mask. There you go. Where are they? Where are they? Yeah. It's in my room.
Unfortunately, we don't have Wangare Sika with us. And so we will have Geoffrey go first, and then Azza. And this session is about how, as practitioners, we certify people who have died. I think it's a skill that is required in our part of the world, because mortality statistics is an important statistics in health and health management. And so we will be having an experience from Rwanda, and then our colleague, Dr. Azza, James Mwanza, and the 2 other colleagues will be talking to us on the ICD compliant medical certification for causes of death developed by the WHO for Sub-Saharan Africa. So let's welcome Geoffrey Goboga.
Thank you very much, Chair. So let's introduce myself. I'm Vuguziga Thade. I'm the Registrar of Rwanda Medical and Dental Council, and the work has been developed jointly with Dr. Godfrey Ngoboka. Can you get the presentation, please? Okay. Thank you very much, Chair. It's about to share a success story of MCSOD certification in Rwanda. But this success is a joint effort. There is 2 key persons behind this success, mainly this great man, Ngoboka Godfrey, who is the country representative of Bloomberg Data for Health. Ngoboka, please can you say hello to the team? Thank you very much. So our sister council's representative, main registrar, should get the contact of this man together with the key support, the people from Bloomberg Data for Health. So it is about this success for improving deaf certification among Rwandan physicians. Doesn't go. Can you help to see how to get the next slide? Okay. Thank you very much. So normally, Vuguziga means talk briefly. I will use 10 minutes so that you have time to ask questions. So death certification, correct information on the cause of death to establish the fact of death legally. And correct filling of the death certificate is the duty of a medical practitioner who is fully registered and licensed according to country regulation. So those information recorded in the health certificate is used to compare mortality statistics for better planning and resource allocation because those data inform on where to provide appropriate intervention. Let's go to the next slide. So as you can see, this is a sample of WHO MCCOD form and certification, whereby we start from those number by C, where you state underlying cause of death. Then the second one is the intermediate death in B, which is caused by the terminal cause of death in A. So this has been the standardized form by WHO, so that our physician has been improving their skills for using this certificate. Next, please, if one can help. So, historically, before 2017, the medical doctors in Rwanda had not been trained on the certifying cause of death according to international standards. And this WHO international standard, death certificate, was not used in health facility, and the quality of cause of death was very poor. Thirdly, so the cause of death was characterized by ill-defined causes with little utility for public health decision-making. That was the key problems. To address it, we went through two approach. The approach number one was pre-service for those medical students who are at school, and then those who are in service, who are licensed to practice independently. So from the benchmark of EAC core curriculum, we have the Rwanda Medical and Dental Council developed a core curriculum whereby as a benchmark for new and existing medical school. And then that core curriculum incorporated the MCCOD course unit for those medical students to run it when they're at school. That's the catch them young approach. Secondly, those lecturers have been also trained on MCCOD to deliver the curriculum. Thirdly, there was now the MCCOD was integrated into clinical assessment of a digital logbook for medical intern during their internship, so that when they graduate, they are able to appropriately fill the MCCOD certificate. For in service, those who are already in service, medical doctors, there has been cascade face-to-face training program whereby a pool of trainers has been selected, and then they have been trained by master trainer, and then they go to train in the local hospitals during their formal or routine CPD program. Thirdly, for sustainability and to make it these courses is sustainable, the Rwanda Medical and Dental Council, in collaboration with the Ministry of Health, HRH program, supported by Bloomberg Data for Health, have developed a robust e-learning platform whereby that MCCOD course was considered for every year license renewal. So physician should present or submit a certificate of completion of that course as a requirement for license renewal. It was 50% of the required total CPD credit. Then number three, there was integrated MCCD into CRV system for routine death registration. Then at the end, there was establishment of a functional coordination structure from central to hospital level. For example, there is a national mortality committee in charge of monitoring this process to ensure that the system was put in place is sustained for a long time. Next, please. Okay. Now, what has been achieved as a result? Ministry of Health issued a ministerial instruction to all health facilities to start using the standardized MCCD death certificate since January. This is a political support. Then, when we tried to do a survey, it has been shown that 98% of health facilities adopted and report cause of death using the WHO guideline. And 90% of medical practitioners registered by the Rwanda Medical and Dental Council completed successfully the MCCD e-learning course to earn the required CPD credit for licensure. Then, the quality of cause of death has significantly improved from 48% in 2018 to 85% in 2021. And as a result, we have 3 medical schools. 2 are new, and 1 was in existence. And then all those medical schools has incorporated the MCCD into their curriculum, and MCCD is taught in all medical schools back home in Rwanda. And then MCCD certificate was also incorporated into grading of medical doctors policy, because among other requirements, which means portfolio and the patient's outcome, it was also requested for them, for being promoted, they should also enroll into that course so that we got the real data. 5, okay. And then as the results, it was produced annual veteran statistics report with cause of death, which is issued for the public health planning purpose, and the monitoring program was also considered. Then, as the results, integrated the MCCD into CRV system for routine death certification is now done perfectly. And the functional structure from central to hospital level was established and is functional, and they have their terms of reference and schedule of their meeting to monitor the progress. Next, please. So as conclusion, the integration of MCCD into medical regulatory authorities like Kenya Medical and Dental Council, Rwanda Medical and Dental Council is very important to implement the MCCD into, in terms of quality improvement, buy-in, sustainability, and accessibility. But stakeholders' engagement is very key, and the coordination structure plays a critical role to the success of MCCOD implementation. For the stakeholder which has been working together, which we acknowledge, it's the Rwanda Ministry of Health has been very supportive. Bloomberg Data for Health, which who are going to present in the next panel, they have been very, very supportive financially and technically. We recognize them. And the new and existing medical school, especially deans of University of Rwanda Medical School and the other private one, we acknowledge them, and we could not achieve this without the support of the board member of the council and the beneficiaries, which are medical doctors. I thank you very much, Chair.
Thank you, Dr. Thade, for that good presentation. I hope that we will have one question for Dr. Thade. But before we get to the questions, Dr. Aziza will make a presentation, and then we can go to the session of questions.
Okay, good evening, everyone. My name is Azza Badr, and I'm the technical lead for CRVS, which is Civil Registration and Vital Statistics, in WHO headquarters in Geneva. And I traveled 16 hours to deliver this 10-minute presentation today. So I hope it is well listened to, because the message that I want to deliver is that the curriculum of medical certification of death should be included into undergraduate medical education, like it was done in Rwanda. It's not difficult. And this is the reason we put Rwanda before the presentation of what medical certification of death is, to show you that we're not talking in the abstract. 77 countries in the world, actually more than 77. 77 countries in the world have very good civil registration and vital statistics systems, meaning systems of countries where they can produce good quality causes of death, which are very important for public health and decision making. Another 78 have systems, but the quality of causes of death are not so good, and only 77 countries have systems which are not functional, meaning they do not produce good quality causes of death. So before I go on, I just want to find out from you, because I'm going to take your assessment at the end of this presentation of whether I made the message or the message came across or not. So how many of you today are still awake? I show of hands. Okay. Okay, good. So you're awake, good. Good. So I can start now making the presentation. So can you please put my presentation? Maybe. Okay, good. So this is about introducing the core competencies for ICD compliant medical certification of death into undergraduate medical education. And okay, why do we need to do that? Because we need comparable statistics by age and sex and causes of death, because it is the foundation of public health. And we needed to measure also the Sustainable Development Goals. The three main purposes for medical certification of death are legal, statistical, and epidemiological. The legal, you understand, you need it to certify the occurrence of death. to find out if that death was natural or not, and for legal identity, and this is the responsibility of the Civil Registration Authority. Once a person is dead, they remove him from the population registered so that he cannot vote anymore, and his legal identity is no longer existing, and of course for inheritance. For statistical purposes, we get to calculate so many mortality indicators just by registering the death. And for epidemiological purposes, similar to what has happened in the COVID pandemic, we need to find out what people are dying from so that we can prevent death. We want to prevent death, and we cannot prevent death, but we can prevent premature mortality. Okay, so as I said, it's very important for determining levels and patterns of mortality in a country, establishing health priorities, assessing the health performance, the health system performance, and tracking national strategies, as well as measuring baseline and monitoring like the SDGs and so on. This morning, we heard a very important presentation about fine-tuning the curriculum of medical education to the epidemiological pattern of disease in the country. So how can anyone do fine-tuning of medical education to the pattern of diseases if we don't know that pattern? That pattern only comes out from proper death certification. Even surveys cannot give you the causes of death in a country. So there is no way you can find out what your people are dying from unless you do a complete system of medical certification of death. And again, the word certification was used today in 5 different ways. What we're talking about is not handing over the certificate of death to a person who dies. This is the responsibility of the Civil Registration Authority. And this is just a certificate that says this person has died. This is called a death registration certificate. And it's not about the accreditation or the certification that an hour ago was talked about. This is an old acronym or an old terminology that has been used by WHO for more than 60 years, and that's why we retain it. It is about completing the medical certificate of cause of death, and we call it certifying death. But actually that part, it has to do with the international form of certification of death, but not about handing a death certificate to the family of the deceased. Okay, so just let me give you an example of, this is just to illustrate one of the uses of mortality statistics. This is where you get the headlines in the newspapers. They get them from the compilation that is done by the Ministry of Health for the leading causes of death. Okay. And this is an example of how statistics are used. These are maternal mortality in the USA, England and Wales, and Sweden for 100 years. And because they were measuring maternal mortality, they were able to lower maternal mortality levels. Otherwise, it would have not been lowered. Another use is the measuring inequalities. This is the map of the United States. The red pockets have a life expectancy of 20 years less than the dark blue pockets. And mortality is the ultimate measure. It's a summary statistic. It's a summary statistic of what a person has been subjected to all his life. Socioeconomic inequalities, food inequalities, nutritional, lack of jobs, lack of education, all this reflects in the life expectancy. You find among the richer populations, people live longer. The poorer populations, people live less. So life expectancy is a summary statistic of inequalities. So it's very important. So what is this all about? I'm not talking about something complex. It's a one-pager, one page that the physician is required to complete. It is completed in exactly 5 minutes. And it's composed of 2 parts. Part A and what we call frame A and frame B. So frame A is this. It's just 4 lines that have A, B, C, D. The physician is requested to write 4 causes of death in sequence. meaning the direct cause of death is written on line A. And what is the direct cause of death due to, and the lowest used line is called the underlying cause of death. So what is the definition of a cause of death? A cause of death are all those diseases. This is a very important definition that WHO has developed in 1967, and it's still valid. All those diseases, morbid conditions, or injuries which either resulted in or contributed to death, and the circumstances of the accident or violence which produced such injuries. So this is the definition of a cause of death. This is what the physician is required to write on the death certificate. The other concept is the concept of the underlying cause of death. It is the disease or injury which initiated the train of morbid events leading directly to death, or the circumstances of the accident or violence which produced the fatal injury. This is what we're interested in. Any physician, even the forensic medicine physician, the legal medicine physicians, the pathologists, when they report the causes of death, they always quote the direct cause of death. We're not interested in the direct cause of death. We're interested in the underlying cause of death for public health and prevention. So it is the underlying cause of death that we would need to prevent so that the disease does not progress, so that we don't have to treat the patient during his lifetime until he dies from that disease. For example, a person dies from pneumonia, this is the direct cause of death. We call that an ill-defined condition. And statistically, we call it a garbage code. It is absolutely not essential for public health intervention. What we need to know is that this person 20 years ago had diabetes, and then it evolved and so on and so forth, and he got diabetic foot, he went to the hospital, he died in the hospital of pneumonia. So we need to find out the diabetes, and this single cause becomes the cause that becomes tabulated in the mortality statistics and the causes of death. Okay, so the rest is easy. Frame B is the manner of death, whether a person has died from disease or an external cause. External cause is suicide, homicide, or suicide, which is self-inflicted, homicide, or accidental. Okay, and then there's another section related to the place of occurrence of the external death, external cause. Where did it happen? In the street or at home or in the hospital or whatever. And then a section regarding fetal or infant death to determine whether this was a real live birth that died, or was it a fetal death. And then a section related to maternal death. Very few tick boxes that he just has to tick. The only thing that he writes in is the one which has the causes of death. Then, I'll give you an example. So, in the room today, how many physicians are in the room today? Can I have a show of hands? Okay. Very few. All right. Very good. This is good enough, but this example will be easy to understand even if you're not a physician. So, a 50-year-old woman was admitted to the hospital, and she dies from esophageal varices. So I can't see the example, okay? And the investigations revealed portal hypertension. Portal hypertension is the hypertension of the portal vein, which is in the liver somewhere. So the woman had a history of hepatitis B infection. So 3 days later, she dies. Now, the physicians in this room, please tell me, what would I write for the cause of death of this woman? Can I have just a show of hand? How, if you're the physician treating this person, how would you write the cause of death of this person? Esophageal varices. She had the bleeding esophageal varices due to liver cirrhosis, due to hepatitis B infection some 20 years ago. So what is the underlying cause of death? What is it that led this person to death in their final stages? Anybody except Dr. Yusuf. Go ahead. Can you just do this? No. Another? No. Okay, go ahead. use the microphone. Phil.
I would put first the immediate cause of death as bleeding esophageal viruses due to portal hypertension, due to liver cirrhosis, due to hepatitis B. So the underlying is hepatitis B infection.
Excellent. Please give her a hand. So, yeah, okay. The secret word here is that she's a pathologist, but even pathologists normally don't know how to write the causes of death. So excellent. The cause of death is hepatitis B. So this is what we want to prevent, so that this person does not need to die 20 years after. We need to prevent it 20 years earlier. So the sequence will be as follows in the death certificate, exactly as same as the professor mentioned. It is hepatitis B led to liver cirrhosis, leading to portal hypertension, and then leading to bleeding esophageal varices. The direct cause of death is the bleeding esophageal varices, and so on and so forth, until we get to the underlying cause of death, which is the hepatitis B. Okay? Very good. So let me just give you a flavor of what mortality statistics look like globally. The average death registration globally is 70%, with the Afro region, which is Africa, except North Africa, is 15% death registration, and the quality of the causes of death is 4%. So we know the causes of death for only 4% of all deaths that take place in Africa. So just can't seem to get this working. Can somebody move it from your side? Okay, and this is what the map of the world looks like when it comes to death quality of causes of death. So the whole of Africa, by the way, is gray. Means we don't even have information, except for those red places, and those red places are the ones with good registration of death, but low quality of causes of death. Okay, this is what Kenya looks like. For the data that we have, of course, we don't have causes of death for the whole of Kenya, only for a fraction. So the registration, neither the registration nor the certification of death is 100%. It is very, Madam Janet Mishuru is the head of the civil registration services in Kenya, and she will give you a short synopsis on what it looks like in Kenya in the panel discussion. But these are the causes. The causes, most of them, except for malaria, even tuberculosis is not sure. Except for malaria, these are all what we call garbage causes of death. Pneumonia is garbage, sudden death, cardiopulmonary arrest. Tuberculosis, if it's due to HIV, is also garbage, because we don't know if this person had HIV and that's why he developed tuberculosis, or it was a real tuberculosis. And so the codes also have to be there. So this one we've already done. Can we go ahead? Okay, so now this is the reason we need to do MCCOD training. WHO usually does that, but it does it for in-service. What we're trying, and it's like continuous and it never ends. Whoever we train leaves and goes somewhere else, and so on and so forth. So we need to start from the medical education. This will produce high quality statistics, and at the same time with higher efficiency. We don't have to do ongoing and continuous training. Yeah, exactly. For the causes of death. And so this is basically the last slide. So we need to integrate death certification in existing curricula. Where to integrate it, this is your game, it's not mine. But basically, it's 3.5 hours of lectures, only 3.5 hours of lectures, and 2.5 hours of practical. That's it. So that's it from my side. I just now need a show of hands showing how many of you got the message. Excellent. Thank you so much. Thank you.
Another round of applause for Aziza. I think we will have a question and answer right now. So we will be having questions and answer. Is that Dr. Wangari? Or, oh, okay, sorry. There are a number of colleagues who have come to assist Dr. Aziza from the global statistics in the WHO. And they will be helping her in answering some of the questions that will be asked. And then we have Dr. Tadi from Rwanda, who will be also answering questions from the presentations that he made. And so given that there were 4 areas of causes of death, I will give 4 questions, because I think he's part of the group. You're part of the panel. She's part of the panel. So, can I see by show of hands, so that we all have the people who want to ask questions? So we have 1, 2, 3. Can we go beginning from the back?
So good afternoon. My question is, in situations where it is not specified whether it is immediate cause of death or underlying cause of death, where mortality data is just captured. So what is usually that element that is picked? Is it the immediate cause of death or underlying cause of death? Because even in our statistics here in Kenya, in our DHIS, the records information system that we have in Kenya, we usually capture cause of death, but it's not usually specified whether it is underlying, immediate. So which one should we pick for the purposes of documentation and records? Thank you.
Did you get that?
Yes. Yeah. Also, I look at it. An excellent question. This is what we meet in when physicians write death certificates and they are not trained. Then we have created rules for the selection of underlying cause of death. These rules are found in volume 2 of ICD 10. It's the rules and the guidelines. They are quite complex, but we have now developed a simpler form of these rules. So we have what we call 26 selection rules. When the physician has not properly completed the death certificate, the statisticians or the coders or the health information management operators, they use these rules to reselect the underlying cause of death. And maybe Dr. Soti wants to comment as well.
Thank you. Dr. Soti is my name, from Ministry of Health, Office of the Director General. I'm also a focal point in the Ministry of Health for Bloomberg Data for Health Initiative. And I have before been a head of M&E where DHIS2 is, and we have trained before. So what finally goes, just to be direct to the answer to your question, what finally goes as cause of death is the underlying cause of death, because that is what is supposed to be picked as presented by us, that is what makes sense when you talk about the cause of death, not those other items. So when you see a cause of death in DHIS2, that is what is picked as underlying. Of course, we know that there are issues with that data because they pick it from the document that was shared, the certificate. So if it is wrong in the certificate, it is also wrong in the DHIS. Thank you.
Thank you. So at least the gentleman behind Professor Ogena.
Thank you, Mr. Chairman. Thank you, Dr. Aza. The statistics are interesting here on how poorly we are doing in Africa. I just have a notice that the definition of death was done by WHO in 1967. That is 55 years ago. The Universal Declaration for Bioethics in 2005 has raised issues as to exactly what's death. One, there are cultures that preserve human body and believe their people are not dead. Two, human rights has come up and they argue that if death is legal because the brain is not functioning, what about organ harvesting? What do we say? So these issues are arising and challenging the death definition of 1967. And the human rights activists are now becoming very strong in arguing that death is relative. Now, among the Christian community, they don't believe people die. They believe the spirit lives on. That is a third context of death. Your comments, Dr. Aza.
Yeah.
Thank you for that question. I don't know whether any of Aza's colleagues understood so that they can.
Actually, I have no comments if anyone can say, but he is very correct. But this is the definition of death. What we gave now was the definition of causes of death.
Speak close to the speaker. Dr. Aza, just speak close to the speaker so that we hear.
What the gentleman was speaking about was the definition of death. But the definition that we gave here today was the definition for the causes of death. So you are very correct. And that part is really still very kind of not settled on the actual definition of death. But the causes of death, that is settled. And it's just for the purpose of writing the death certificate. After we have established that this person has clinically died, then we need to establish also what he died from.
Yeah, so I think you want to contribute here.
Yeah, thank you very much. I want to echo what Azaz said, but also reinforce that by saying the definitions about cause of death are also enshrined within the constitutions in a country. And I think our civil registrar ministers can actually give us more specifications on what law defines how we report causes of death. And I will pass that to her. Thank you.
Thank you. Maybe what I would like to do, in Kenya we are doing very badly in registration of death. And sometimes we wonder why, because it's compulsory for one to, before they are buried, for a death certificate to be issued. But what we are seeing in our offices, despite death registration being compulsory, we see forms which are left blank, and we are unable to have completeness in death registration with those kind of forms. We derive our mandate of death registration from Cap 149, and it's actually criminal for those forms not to be filled properly. And the Constitution We also work under the Constitution, Section 3, and we need to make sure that the forms on death registration are properly filled. That is D1s. We make sure that we provide D1s to the health practitioners so that they make sure they take the time to fill them up. Otherwise, it's causing concern because we can't have complete death registration without those proper reporting.
Thank you. So I think there is definition of death that they are saying is not very clear for now, but causes of death is very clear. Professor Ogena.
Thank you, Mr. Chairman. I was just trying to draft in case I forget what I wanted to ask. And I really want to thank Aziza for that very well put presentation. And I want to tell the group that is sitting here that actually we are training doctors. This is in our curriculum. I have taught in the University of Nairobi, and we have the content. What I don't know is the attitude. Could it be an attitude problem? Could it be lack of supervision? And could it be also that there are so many people involved in death notification? We did a study in 2014. It's actually on, it's a free access paper, quality of cause of death statements in Kenya. And what we noticed was the causes of death that were written by pathologists at the city mortuary, the quality was good, between 80 and 90% quality. However, the causes of death that were written at a training institution, which was KNH, where the University of Nairobi practices, and we did that study while I was working at the University of Nairobi, the quality was ranging from 40 to 30%, just depending on what disease we were dealing with. And what our thought was, it is likely because there are so many people involved in the chain, including interns, clinical officers, the junior most medical officer, writing these causes of death. And number two, that the quality will depend on the type of disease. Why? Because we think that with KNH or UON, a lot of our patients die before we actually make a correct cause of death, identification or diagnosis. So we fear to look at it objectively, look at all the data and give. Now, what I would want to ask is the Rwandan success. How did you lock this form so that people fill it correctly? Because I think number one is the form to be locked in, and number two, supervision. I think Ojuka, Stephen Ogendo, who's in here, let's take those responsibilities seriously. And the interns are not rotating in departments that would supervise this. For example, in pathology. Thank you.
Thank you, Prof, for that good question. Do you want to answer?
Yes. Thank you very much, Professor, because you said it very well. You were asking herself whether it is attitude or lack of knowledge or lack of supervision. So she asked how now we come up that the form was accessible to all physicians and how. So first of all, there were two issues. As we said, there was lack of sufficient knowledge on how to fill it properly, and then the intervention was to conduct cascade trainings from face-to-face up to online. That was number one. Number two, now was to sensitize medical doctors, physicians, to appropriately determine the real cause of death by filling the form. Because there was a kind of negligence. They feel the way they want. They just say cardiac arrest in bad handwriting. So, and everybody knows that when there is a death, of course, cardiac is not the cardiac is arrested. No oxygen in the body. So that was number two was that now to try to sensitize medical doctors to take their time to establish chronological events of conditions. And then, number 3, as the intervention, it was to make sure they have skills and they make sure they complete appropriately. This reform was among the checklist to verify during a medical malpractice investigation process. When there is a malpractice is composed by either there is an injury or there is a death. When there is a death in hospital A, that case is immediately reported to medical council. Medical council establish a team of experts to go on the ground and do a serious investigation to establish facts. And then when they go there, they ask, first of all, who participated in the treatment of these patients. They come. Number 1, show us your license to make sure they are licensed to practice in that scope. Number 2, they say, present us the patient's file. And in the patient's file, they should check whether there is MCOD certificate. And then when it is badly filled or there's ignorance in filling the form, so the doctor will be accountable. So now, as they know that any single death is audited, any single death is investigated, they try now to fill the form appropriately. And the form is available on the website.
Thank you. I think this now that there are only 3 questions, I have my question that goes to the team that is over here, together with Professor Rogena. But I hope one person could answer it. What would be the policy statement that you would probably want to think from what has been said in this podium and in this hall with regard to filling in that form? Dr. Aza?
Sorry, I didn't get the question. So is it about the quality of the mortality statistics?
What is the policy?
Policy.
From
the
discussion. What is the policy statement?
What would you think would be the policy statement that would come from what you have presented together with the discussions that we have had?
Thank you so much. So in summary, what we're saying is that WHO and Vital Strategies and UNECA and the ministries of health of each country, they do in-service training for physicians for certification of death so that they have high quality mortality statistics. What we are recommending is that all countries in the African continent and globally integrate the competency of how to complete what is called ICD compliant medical certification of death into undergraduate medical education in order to improve the quality of causes of death. As mentioned by the professor here, it is not only about filling the certificate. There are like about 5-6 steps more that take place after the filling of the certificate. One of it is the validation. One of it is the selection of the underlying cause of death. We need to remove the implausible causes of death. Like, for example, a man dies from, for example, breast cancer. Even though men can die from breast cancer, but for something, or a man dies from pregnancy-related issues. So the cleansing process of the mortality statistics, and then the tabulation, and so many other, and then the analysis of the causes of death, and then to prepare policy briefs from that is very important. Because many times the countries do have good quality causes of death and they don't use them for policy making. And also to add to what the professor said is that most hospitals have what they call mortality audits. So this is a good a mechanism for improving the quality of causes of death. Through these mortality audits, they can go and review the medical death certificate even if it has already gone out. So for statistical purposes, they can revisit the death certificate and then produce correct statistics.
Thank you.
Thank you,
Dr. Aza. I think our colleague from UNECA, what would be your perspective?
Okay, thank you very much. And I'll begin by responding to Professor who was talking about issues around implementation. So in the region, UNECA is supporting the rollout of a framework for assessing the business processes. I agree with you when you mentioned that there are so many people involved, and so sometimes that is where the loopholes are. So we've introduced, together with our partners right here in front, we have introduced the business process improvement framework, where we are looking at the steps and each business process and identifying the bottlenecks that could be causing or resulting in poor articulation of causes of death. So my recommendation, and I think it's a recommendation from all of us, is that each country, we go back and we try to see where are we losing the data, where are we losing the right information. Then through identifying those bottlenecks, we identify our priorities, the low-lying fruits, and those then become our quick wins for our policy and strategies. Thank you.
Thank you. Dr. James, 1 minute.
Yes, I want to answer, Prof, the policy statement. Medical certification is part of good clinical practice. And doctors should be facilitated with opportunities to get skills on that area of work. And it should be regulated like any other aspect of clinical practice. Thank you.
All right. Facilitation and regulation. I want to thank you, all of you. Let's give them a hand of applause for that presentation and discussion. We appreciate the knowledge that we've got. And as James says, I think we will be thinking about how that facilitation should be and how that regulation should be done. I thank you. And I thank all of you for listening to us. I am told that there was a video that was missed, the video of Daniela Njeri Munene. That is the nexus between training and practice of pharmacy, adapting to health system requirements. So as these colleagues go to sit, those who will be available will be watching that video. I thank you.
Conference of Repositioning Today's Health Workforce for the Future. My name is Dr. Daniela Munene. I am a member of the Executive Committee of the Pharmaceutical Society of Kenya, and I am a Director of Kenya Healthcare Federation, as well as Head of Operations at Africa Health Business. Today, I'm pleased to get a few minutes to share with you my thoughts on the nexus between policy training and practice, and how we can adapt to emerging health system requirements. My presentation will go as follows. I'll make a brief introduction. I'll talk about emerging health system requirements. Then we'll look at aligning policy training and practice and what that takes. And then I'll make a few recommendations for your consideration to take out of this conference. So by way of introduction, let's talk about the elements of our profession. Professionals require specialized training and lifelong learning, and they exist to discharge a social contract to the society in order to alleviate suffering and bring solutions to their most pressing problems. So what about us as healthcare professionals? We are trained to alleviate illness and promote health. Ernest Greenwood, who is considered to be an expert in the field of professions, proposes that a profession must have the following elements. 1, a systematic body of theory or knowledge. 2, authority and credibility. 3, community sanction, the so-called social contract. 4, a code of ethics by which all professionals must follow. 5, a professional culture, which is exemplified by values, norms, and symbols. To the left of my screen, you see various logos of health professional associations. I just picked a few. And if you look, you'll see a recurrent theme of symbols. We see the bronze snake, the scriptural bronze snake that would bring healing to the dying. We also see weights and measures that must balance and not defraud, indicating integrity that is expected of professions. This being so, it follows then that it takes a lengthy process of training to qualify for professional practice. Number 2, this training incorporates a period of practical experience, the so-called preceptorship, internship, on-job training. 3, professionals require continuous practice and learning to remain qualified. If you graduated with your medicine degree 20 years ago and thereafter have not practiced, you moved into a different field, or you're in management, I dare say you're not safe to touch a patient today unless you go back to relearning and updating your knowledge. 4, a profession must evolve to meet new requirements within its field. And we're going to talk about how we need to adapt to evolving needs. So let's talk about emerging health system requirements. What you see on your screen is today's health client, the typical seeker of healthcare. Look at how confident she looks. She's not afraid of doctors anymore. She's extremely empowered. Why? She's standing on rights-based protections from her constitution and legal framework. She has a right to health, including emergency treatment. She has a right to privacy, including data privacy. She exists where population demographics are shifting, with a higher life expectancy leading to more diseases associated with aging, and this impacts the services for which she seeks care. As I said, she's a more empowered client than the client of a decade ago. She's more aware of her rights. She has access to the information she requires from multiple sources. And actually, her top priorities are convenience, accurate information, and choice. And all this in a context of emerging global health threats, such as a triple threat of infectious diseases, NCDs, and pandemics. For instance, we have COVID-19. It wasn't there 3 years ago. We have emerging antimicrobial resistance. Again, in a context that is shifting in terms of new financing models for healthcare. Today's health-seeking client is more likely to be insured than the client of a decade ago. We now have a higher proportion of people able to pay more for healthcare as our middle class grows on the continent. We have diminishing donor aid in many of our countries, and we have to relook at how we budget and finance our healthcare. And there's an increasing focus on reimbursing primary care, for example, counseling for smoking cessation. Another contextual consideration is emerging technologies. We have newer drugs, we have novel vaccines, cutting-edge diagnostics, and interactive health information systems, as well as digital health solutions. And we have to remain relevant in this shifting dynamics. So how do we align policy, training, and practice to remain relevant? Policy, training, and practice exist within a continuum. And in this continuum, the main stakeholders I want to present to you are the public, It all starts with the public, and we all exist to serve the public for their safety and well-being. So the public, what do? They demand services. They also provide feedback if we allow them. The next stakeholder is government, that makes the enabling environment for all the other actors to exist and discharge their function. Government makes policies based on the needs of the public. Thereafter, we have regulators that make and enforce regulations responsive to the guiding policies. Thereafter, we have higher education institutions that train fit-for-purpose professionals to meet the public's need within the confines of regulations and ethics. And last but not least, we have the professionals themselves. We engage in training others. Remember, in the training of professionals, we need teacher practitioners. We need people to train us who are also practicing our profession. Otherwise, they lose touch with what we need and the skills we need on the ground. So we don't need career teachers. We need career teacher practitioners. Professionals also carry out research, they engage with the public, and most importantly, they self-regulate in line with their codes of ethics. So let's imagine a couple of emerging health system needs and how this continuum needs to respond. We have the COVID-19 pandemic with us now. It has brought with it a new disease, of course, new therapeutics, new diagnostics, new vaccines, and a new aggressive, biggest vaccination global initiative that we have ever seen. How do we respond to this pandemic? The public needs to be educated about the disease, how to protect themselves, and they also need to be educated about vaccines, and they need to get those vaccines in their arms. Because we all want to get herd immunity, right? The government makes policies that enable emergency use authorization of vaccines or maybe market authorizations, and they allow the training of new health cadres to provide more care to stay ahead of the speed of this pandemic. We might need to mobilize more healthcare cadres to provide services that before they didn't need to provide. For instance, we might mobilize, as some countries have done, the pharmacy workforce to provide COVID vaccines. The regulators need to license the new products. They need to license the expanded scope of service of the professionals who are now practicing in an expanded capacity. The higher education institutions might want to introduce COVID-19 in their curriculum. And the professionals then need to provide services, perform training, educate, and get feedback from the public. Let's look at another instance of an emerging health system requirement. We have the emergence of antimicrobial resistance of unforetold proportions. So the public needs to be safe from antimicrobial resistance, and all the other actors in the continuum need to respond to that public need. The government then might want to develop an antimicrobial resistance policy, as I know has been developed in several countries on the continent, including Kenya. The regulators then develop and enforce regulations that ensure rational use of antibiotics. The higher education institutions introduce antimicrobial stewardship in their healthcare professional training. And the professionals, the buck stops with us. We then prescribe, dispense, and administer antibiotics rationally and responsibly. Each member of this continuum must do their role and must discharge their functions in tandem for the protection of the public. So allow me to make some recommendations for us to ponder on. For us to have a responsive professional training ecosystem that keeps us as healthcare professionals relevant to the public's needs, we need to establish engagement vehicles or platforms or channels for advocacy And this should be across the 3 levels: policy, training, and practice. We also need to establish representative bodies of training institutions, such as associations of schools. For instance, the Association of Schools of Medicine or Association of Schools of Pharmacy, in order to have a collective body for engagement with other stakeholders. Next, I propose that every profession must have a self-regulating association, and all professionals must be mandated to be members. We also must continually collect structured feedback from each level of the continuum and use this feedback to inform change. Finally, I propose that where it is lacking, let us develop a core curriculum to guide the training of each health professional cadre, and let us revisit this curriculum regularly for review and revision. Thank you very much for your attention. Enjoy the rest of the conference.
Ladies and gentlemen, thank you very much. That was a presentation. I don't think there's anybody available to answer the questions. So I think it will suffice to say, once again, thank you very much for the day. It has been a long day, and we really appreciate your perseverance with us. For those of you who are going to the gala dinner, I believe it will start African time. You've got 2 hours before it starts. However, there is tea out here, which was ready quite some time back. Maybe you can pick a small apple or something to eat while you're waiting for the gala dinner. Tomorrow, please, we start at 8 o'clock sharp. I see a hand almost touching the ceiling. I'm not quite sure why. Use the microphone.
Thank you, Chair. My name is Katra. We were in the other session, but we were told there is a rescheduling of the schedules. We are supposed to be here for our presentation on training and the harmonization of the curriculum. We also received that message, so I don't know where there is a disconnect. Maybe we need a clarity on that, because the presenter is actually here.
We were not advised. Now, what happened was the abstracts received were far in excess for one column, so they were spread into the other columns. And the understanding was that even if you're in another stream, your presentation would be recorded there. Are you saying you have a presenter ready?
I can actually read the message. Good afternoon, delegates. You are notified that...
No, we're not going to argue about that. We trust what you're saying
the presenter is here.
We trust what you're saying is correct.
Yeah.
Has the presenter given the slide presentation to the young team there at the back?
She's ready to address it. She doesn't have the soft.
It's a verbal presentation without slides when people are tired. So you're going to present it without slides? Can I take back everything I've said? While she's loading the slides, maybe rush out, pick up a packet. I can see a few there. Maybe get something to eat, and then we'll listen to her. Dan? Daniel Ojuka, can you come back on duty?